Hello everyone, this is Dr. Priyanka Sachdev and I welcome you all for second Prof Final Gear, this 75-hour rapid revision course. It's a rapid revision course to ace your university exams. Before starting, I would like to address few FAQs which I've frequently received on chats.
I haven't read anything. I did terribly in my pre university exams. Can FG save me?
FG is exactly for you. It is for the student who are starting late, starting scared, or starting after a bad pre-university result. But a bad pre-university result couldn't predict your university result. What predict is what you are actually doing between PUs and Us. FG is a system, and the system works regardless of the starting point. Distinction is the target, and we go for it together.
I've already read the entire Robbins. What will FG add for me?
Everything, because knowing is not equal to scoring. Reading Robbins and revising Robbins are two completely different things. You have knowledge, but you need a system that organize it, integrate it, and convert into exam ready output.
What is integration?
It is a technique to organize similar systems across patho, micro, and pharma. So we have three subjects, that is patho, micro, pharma, and we have 9 major systems in human body. You are knowing that. So I don't teach you subject wise. I teach you system wise. We take system one by one and we cover that system from all three subjects one by one. For example, day 7 is our CVS day. So on that day, you have to complete watching CVS diseases and pathology, CVS infections in microbiology, and CVS drugs and pharmacology. So it is for better retention, better understanding.
Your course is fast paced. How will I keep up in so little time?
The workbooks. That's the answer. It is not a textbook. It is not a printout. It is a strategic companion designed by me. On every page, you can see 80% is filled and 20% is intentionally blank. The blanks you have to fill during the session in real time so that revision goes on simultaneously. So by the end of all session, it will be no more workbook. It is converted into revision copy. The only revision copy you have to revise before your university exam. And the biggest catch is that the videos and the workbooks are 100% synchronized. Slide to slide, page to page. Whatever I'm teaching you in the videos, word to word, it is matching with the workbook. And we have done page stamping on the videos for easy navigation into the workbook. But if some students feels that they want 100% filled notes, they do not want to fill the workbooks. So the Prof Buster hard copy books for pathology and microbiology, they are already available on our website. You can go with that. It's 100% filled version of the workbook. It's already available. And along with the microbiology, master charts are also available. Master chart is a calendar. You can hang it on your wall, you can flip it, and you can compress the entire microbiology in just 50 pages.
I always start strong and then fall off schedule. What's different this time?
This time, you don't rely on willpower alone. You make public commitment. I dare you to take 16-day FG challenge. It's not just a timetable, it's a social contract. So, there are total 49 chapters in Patho, Micro, and Pharma. I have completed the 49 chapters in 75-hour lectures. You cannot watch 75-hour lectures in one go. That's why I divided the 75-hour lectures in 16 days. I have already decided that what you have to watch on what day. From day 1 to day 16, the complete schedule is in your hand. You can see one system, one day. For example, on day 9, it's respiratory system. So you have to finish watching respiratory disorders in pathology, respiratory microorganisms in microbiology, and the respiratory drugs and pharmacology. Likewise, one system, one day, the 16-day go, the complete syllabus, the 49 chapters in just 75 hours. So you already know what you have to watch today, what you have to read today, and that's the 16-day challenge. Every day you finish your target, every day you tag me on Insta, daily, no hiding. When the entire FG community is watching, showing up feels different. So make a commitment, show up, tag me. Let's go. The 16-day challenge.
I understood what FG is. But, ma'am, can you please tell the exact steps to be followed?
There are 7 steps to be repeated 16 times for 16 days in a loop. Step number 1, plan the next day the night before. It will take just 60 seconds but save your 60 minutes in the morning. Step number 2, declare it publicly. Make a social contract, make a public commitment. Step number 3, start your day with coffee, tea, stay hydrated, and start watching the videos dedicated for that particular day in that folder with a timer. Don't forget to put the timer. Step number 4, fill the workbook simultaneously. Simultaneously means simultaneously. It should not be later, it should not be tonight, it should be simultaneously. Step number 5, after watching the video and filling the workbook simultaneously, there are two type of quiz we have attached with every video, the university exam quiz and the MCQ quiz. You have to solve both the quiz immediately after watching the video and filling the workbook to analyze yourself. Step number 6, track your progress either on the physical tracker, we are sending this to you, or the digital tracker which is already there on the app. You have to make a tick mark to analyze yourself and track your progress. Step number 7, analyze, reset, repeat for 16 days. If you are following these 7 steps for 16 days, take my word, the distinction is yours.
I am having my exams after 6 months. Is FG for me?
No, not useful now. You can enroll for Prof Buster Comprehensive Batch. You have time, you understand the concepts in detail. FG might be useful just before the exams.
I am an intern preparing for NEET PG. Is FG good for me?
No, FG is exclusively for second Prof University exams. Concept for both the exams might be same, but approach differs.
Is FG enough for university exam?
Yes, so 100% coverage of all LAQs and SAQs of all universities, pan India. So 100% strike rate in just 75 hours. Hello everyone, I'm clearly visible and audible. Can you see the screen? You have to reply in the comment box. It is a live session from here. So you have to write down if I'm clearly visible, audible, everything is good to go. Kindly confirm. I'm waiting for your reply. I guess yes, it's working. Just a second, let me check. I'm clearly visible. Yes, it's working. Thank you. Thank you for confirmation. Thank you so much. So I welcome you all for today's session. So I welcome you all for this demo, the pharmacology demo, final gear pharmacology demo, right? So this is our third demo session, the last demo session of pharmacology. Before this, the 2 demo sessions are already over. I guess you must have watched the pathology demo session, which was on Friday, that is inflammation, complete inflammation in just 45 minutes. You must have watched yesterday's demo of microbiology, in which I taught you 30 infections, 30 microorganisms of GIT in just 3-4 hours, right? And today I am going to crush entire drugs acting on autonomic nervous system. That is 4 chapters: cholinergic, anticholinergic, adrenergic, and antiadrenergic in one shot. Be with me for the next 2-3 hours and complete ANS will be crushed like a cakewalk for you, right? So today is the third and the last demo. So before I start, there is an important announcement for the students, second prof students who are thinking of subscribing the final gear course. So let me tell you, after many days of preparation and countless sleepless nights, the entire MedLIVE team is super excited to launch the final gear tomorrow. So tomorrow on 27 July, that is Monday, 11 p.m. in night, we are launching the course. What you will get tomorrow at the launch, please be careful. So here we will give you pre-recorded lectures. Complete pathology, 100%, 25 hours will be delivered at the time of purchase only, at the time of enrollment only. Complete microbiology, complete 25 hours, again at the time of enrollment. But mind it, pharma, out of the 14 chapters, the first 3 biggest chapter will be available in the form of the pre-recorded sessions. That will be nearly 10-hour recording. The remaining 15-hour recording, that is chapter number 4 to chapter number 14, is scheduled, already scheduled. You can see on the app, it is already scheduled as live sessions from a day after tomorrow, that is 28th of July to 1st August in 5 days. So daily there will be 4-hour, 3 to 4-hour live sessions in the morning. And but you can mind the notes, MCQ question bank, university exam question bank, practical library, everything else is uploaded of all 3 subjects. Okay, you can see here. And the hard copy dispatch, we are starting from 11th of August. Okay, so any student, if you're having any query regarding the 16-day FG challenge, so you may be thinking my 16-day challenge will be affected because of this. No, it's not going to be affected. You can see here. This is what I'm telling you. So out of your 16-day challenge till day 4 of all 3 subjects, it's already uploaded on the app. Patho, all 16-day uploaded. Micro, all 16-day uploaded. But in pharma, till day 4, that is first, second, and third chapter, it is available as a pre-recording. You can start your challenge. And the remaining all days, the remaining all chapters will be uploaded in the upcoming 4 to 5 days as live sessions, which are already scheduled on the app. Right? Now, In this session, I will be very fast because it's a rapid revision. I will teach you entire ANS drugs in one shot in the next 3 hours, total 4 chapters. So maybe I'm not able to reply to your queries. So if you have any query, please don't hesitate to text on this number. This is our support number. Please, you can ask your queries there. I will personally reply your queries there. Right. So let's start the drugs acting on ANS. Okay. So can we start? The drugs acting on autonomic nervous system. Let's start drugs acting on ANS, right? So I will be teaching you the drugs acting on ANS, total 4 chapters. Cholinergic drugs, anticholinergic drugs, adrenergic drugs, antiadrenergic drugs, just in 4 master charts. Believe my words. You will compact the 100 pages of the textbook in just 4 master charts. My unique way of teaching autonomic nervous system, the drugs acting on ANS. Not only ANS, I teach you complete pharma in the form of the master chart. You can see my master chart. So cholinergic drug, anticholinergic drug, adrenergic drug, and antiadrenergic drug, that is alpha blocker and beta blocker. I am going to teach you under a fixed set of heading, and I call it a unique technique, that's master chart. So I request all of you to take out your notebook, take out your pen, and start filling this master chart with me during the live session itself, so that you can revise the entire chapter just in half an hour or 15-20 minutes. And you can do so without skipping any important information. I will make you to retain the entire 4 chapters permanently. It will imbibe in your mind. Believe my words. You can try it out if you don't believe. So let's start it. Before I start these 4 chapters, I want to give you an overview. What is autonomic nervous system? Most of the students directly start, jumping on the chapters, cholinergic, anticholinergic, adrenergic, antiadrenergic. They don't even understand what is autonomic nervous system. So before I start, I would like to orient you what is autonomic nervous system. So human nervous system. The God has given us 2 type of nervous systems. Central nervous system, known as CNS, and peripheral nervous is having 2 components, brain and spinal cord. These are the 2 components of central nervous system. What is peripheral nervous system? Today I am interested in peripheral nervous system. The peripheral nervous system, actually the nerves which are arising from the central nervous system. So the nerves arise from the brain as well as the nerves arise from the spinal cord, and these nerves constitute the peripheral nervous system. You know what is a nerve? Nerve is the axon of a neuron. You can see the neuron. The cell body of the neuron is inside the central nervous system, and the axon is coming out, and that axon is constituting the nerve. So this is peripheral nervous system, right? Now the nerves which are coming out of the brain are cranial nerves, and the nerves which are coming out of the spinal cord are spinal nerves. So the great God has given us 12 pairs of cranial nerves and 31 pairs of spinal nerves. You can see here, you can see the 12 pairs of cranial nerves, and you can appreciate the 31 pairs of spinal nerve. Out of the 31 pairs of spinal nerve, you can notice 8 of them are cervical, 12 are thoracic, 5 are lumbar, 5 are sacral, and 1 is coccygeal. So total 31 pairs of spinal nerves are there. Now the nerves are of 2 types. You can see I'm interested in nerves. I'm interested in peripheral nervous system. I'm today not interested in central nervous system. Central nervous system drugs I will teach you on other day. Okay. So this is autonomic nervous system, for which I'm interested in peripheral nervous system, right? The nerves are of 2 types. All these nerves are of 2 types. What are the 2 types of nerves? Sensory nerve and motor nerve. Sensory nerve, also known as afferent nerve, and motor nerve, also known as efferent nerve. What do you mean by sensory and motor? To understand sensory and motor, I will draw organ over here. Let's draw organ. Now, the nerves which are carrying the signal from the organ towards the central nervous system are known as afferent or sensory, and the nerves which are carrying the signal from the central nervous system and towards the organ, see the arrows, these are known as efferent or motor. So currently I am interested today in motor nervous system. I mean the motor nerves. Motor nerves or the peripheral nervous system. I am not interested in sensory, the motor nerves. So let's focus on the motor nerve. You understood 2 type of nerve. So sensory or afferent nerve and motor or efferent nerve, you can see. Currently I'm interested in these one. The motor nerves are of 2 types. What are the 2 type of motor nerves? Somatic nerve and autonomic nerve. What are the 2 types of motor nerve? Here only I will show you. Again I will show you. Let's draw 2 type of organ. Motor nerve means the one who is carrying the signal from the central nervous system towards the organ. I'm saying the motor nerves are of 2 types. So there are 2 type of organ to which they supply. Does this apply to skeletal muscle, that is voluntary muscle, or does this apply to smooth muscle, that is involuntary muscle? You can see. So say this is skeletal muscle, that is voluntary muscle or skeletal muscle, and you can see this is involuntary muscle or smooth muscle. Cardiac muscles are cardiac muscles, they are involuntary muscle. So all the visceral muscles is involuntary muscle. So these are the two. Both are motor. Look at the arrow. Both of them are carrying the signal from the central nervous system towards the effector organ. Both of them are motor. But one is supplying the signal from central nervous system to the voluntary muscle, that is skeletal muscle, and other is supplying the signal from central nervous system to involuntary muscle. The one which is supplying the signal to voluntary muscle is somatic nervous system. And the one which is supplying the signal to involuntary muscle, involuntary or smooth muscle, is known as autonomic. My topic today, autonomic system, autonomic nervous system. So my topic today is autonomic nervous system. I'm not teaching you somatic. Somatic I will teach you other day. Currently the drugs acting on ANS. So first you understand what is ANS, then I will come on the drugs quickly. So I hope you got the two type of the nerves, somatic nerves and autonomic nerves. See here. Here you can see all of them are motor nerves because you can appreciate the arrows. Can you appreciate the arrow? See the arrow, see the arrow, see the arrow. In all of them, you can see they all are efferent nerves. They all are motor nerves. They are carrying the signal from the central nervous system towards the organ. Now, who is the organ? Who is the organ? If the organ is voluntary, call it, ma'am, this is somatic because it is giving the signal to the voluntary muscle. And if the organ is involuntary, involuntary smooth muscle, so call both of them. These both of them are autonomic. So this is also autonomic. This is also autonomic. I hope everyone got it till now. Give me a thumbs up. So you can see the differences between somatic versus autonomic. You can see here somatic. Somatic is a single neuron. You know, it is arising from the central nervous system and directly ending in the organ. It is a single neuron. It is single neuron. Okay. And you can see autonomic. I have drawn two autonomic intentionally because autonomic is of two types. Okay. Sympathetic and parasympathetic. Both of them have two neurons. So you can see there is a junction of the neuron. The junction of the neuron is known as ganglia. The junction of the neurons is known as synapse or ganglia. So you can see two neurons are there. Can you see? This is known as preganglion. This is preganglion in both of them. And you can see this one is postganglion. Let me draw the postganglion. This is postganglion. So appreciate the preganglion and appreciate the postganglion. So both of them have two neurons. So you can see here the somatic supply to voluntary muscle, autonomic supply to involuntary muscle. Voluntary muscle means skeletal muscle. Involuntary muscle means visceral muscle. Here single neuron and here two neuron. One is preganglia and one is postganglia. Okay. So I hope you got it. Now the autonomic nervous system is further of two types. You may be asking, ma'am, what is the two types? I mean parasympathetic and sympathetic. What is the difference between the two? So both of them are autonomic nervous system, but they are of two types, parasympathetic and sympathetic. See the preganglion and postganglion, you will get your answer. See the preganglion here and see the postganglion here. This is preganglion and this is postganglion. Where is the ganglia? Where is ganglia? Answer that. Where is ganglia? Ganglia is this. So here ganglia is not at the center. Ganglia is not at the center. Here the ganglia is towards the organ. That's why preganglion is longer and postganglion is shorter. So when preganglion is longer, postganglion is shorter and the ganglia is towards the organ, it is known as parasympathetic system. And it is active when we are relaxed. Okay. And here you can see the ganglia is towards the CNS. Again, it's not at the center, but it is towards the CNS, not towards the organ. It is towards the CNS. Okay. So here preganglia is short. Okay. And postganglion is long. So such a system is known as sympathetic nervous system and it comes in role when it is some emergency situation. I hope everyone got it. Anyone have any confusion? So you can see the two type of system, parasympathetic system, sympathetic system. Parasympathetic system is active in us whenever we are relaxed. And sympathetic system is active in us whenever there is some emergency. If there is fight, flight, fright, any emergency. Suppose the exam results are going to be declared. Suppose there is a tiger behind me and I have to save my life. I have to run. So if there is any emergency at that time, the nervous system which is activated in the autonomic nervous system is sympathetic one. But currently I'm teaching you. Teaching is not a panic situation. Currently I'm relaxed. So I think in me, currently the parasympathetic system is active. I don't know about your situation in you, whether parasympathetic or sympathetic is active right now. I don't know. Okay, but all our organs have both nerve supply. Both nerve supply. So whether which one is active at one time, it depends on the situation. If we are relaxed, parasympathetic is in role, and if we are in some emergency, so sympathetic is in the role. And you got the difference between the two. In parasympathetic, the preganglion is longer, the post is shorter, the ganglia is towards the organ. In sympathetic, the ganglia is towards the central nervous system, that is pre is shorter and post is longer. Learn these two definitions. This is what I want to say you. You can see here the two type of autonomic nervous system. Parasympathetic system, it is active whenever we are relaxed. And sympathetic system, it is active whenever we are in emergency, in some emergency. See here the ganglia is towards the organ. That's why pre is long and post is short. And here the ganglia is towards the spinal cord, towards the CNS. That's why pre is short and post is long. You can appreciate the difference. Say yes if you got it. Anyone have any confusion? You can ask. Now coming on the neurotransmitters. You have to understand neurotransmitters if you want to understand the drugs, because all the drugs action will be on the neurotransmitters. So here you have to understand the neurotransmitter. Which neurotransmitter is present where? So in somatic system, since there is only one neuron, we need one neurotransmitter, and that neurotransmitter is acetylcholine. Only one neurotransmitter in somatic system. But in autonomic nervous system, since we have two neurons, we need two neurotransmitter. One at the preganglion, one at the postganglion. So preganglion in both of them, whether it's parasympathetic, whether it's sympathetic, it's acetylcholine. Preganglion in both of them is acetylcholine. Coming on the postganglion neurotransmitter differs. It differs in parasympathetic and in sympathetic. In parasympathetic, it's still acetylcholine. So it is acetylcholine both the ways. But in sympathetic, it is noradrenaline. It is noradrenaline. Now, this is the reason why parasympathetic system is known as cholinergic, because the postganglionic neurotransmitter is acetylcholine. That's why it is known as cholinergic. And this is why the sympathetic system is known as adrenergic, because the postganglionic neurotransmitter is noradrenaline. That's why it is known as adrenergic. So learn the other names. Parasympathetic is cholinergic and sympathetic is adrenergic system. So if I'm saying cholinergic system, I mean parasympathetic system. If I'm saying adrenergic system, I mean sympathetic system, because it is the postganglionic neurotransmitter that matters. The postganglionic neurotransmitter here is acetylcholine. That's why cholinergic. And here is noradrenaline. That's why adrenergic. But preganglion in both of them is acetylcholine. Okay. And in somatic, only one is there, somatic system, that's acetylcholine. The same story, you can read it here. You can see somatic nervous system, autonomic nervous system. Somatic nervous system, acetylcholine is there. Autonomic is of two types, sympathetic, parasympathetic. Now in each of them, preganglion, postganglion, preganglion, postganglion. Preganglion in both of them is acetylcholine. Postganglion is what that matters. So postganglion in sympathetic is noradrenaline, and postganglion in parasympathetic is acetylcholine. That's why this is adrenergic system and this one is cholinergic system. Okay, you can see the same is written. Parasympathetic is cholinergic system because neurotransmitter at the effector organ is acetylcholine, and sympathetic is adrenergic system because the neurotransmitter, postganglionic neurotransmitter at the effector organ is noradrenaline or adrenaline. Got it? Now coming on the actions, what actions they do? Now which organ of my body is having which nerve supply? Is it sympathetic or is it parasympathetic? So the answer is all organs having both. It depends on the situation which one will active. Currently, as I told you, I am relaxed right now. I don't have any emergency right in front of me. So I think in me right now, the parasympathetic system is active. But suppose there is a tiger behind me and I have to save my life. Suppose the exams are there or the results going to be announced and I'm in emergency, in some sort of fight, fright, flight, triple F. So in some emergency situation, at that time, the sympathetic system will be active in me. So each and every organ have both the nerve supply. You are getting my point. Now, most of the organs, the action of these sympathetic and parasympathetic is opposite. I will tell you the actions. The actions of these two will be opposite. Okay. But at some organs, the action is complementary. The best example of this is male sex organ. I mean, penis. You can see other organs. I will explain these organs one by one. You can see at most of the organs, appreciate all these organs. You can see the action is opposite. I will explain. But at one organ, the action is complementary instead of opposite. That organ is male sex organ, that is penis. In penis, there are two things you can see: erection and ejaculation. Okay, erection. In sexual intercourse, first there is erection followed by ejaculation. So erection is done by parasympathetic system and ejaculation is done by sympathetic system. So these two actions are not opposite. They are complementary. So here the sympathetic and parasympathetic are complementary to each other. That's what it is written. At most of the organs, the action is opposite. That I will discuss. But at some organs, the action is complementary. The example is in front of you. Okay, I hope you got it. Now at other organs, the action is opposite. Now we will discuss organ by organ. Whenever I say parasympathetic system, always imagine the relaxed state. Whenever I say sympathetic system, always imagine the emergency state. Okay. Now let's take the organ one by one. Let me take the first organ, pupil of the eye. Now, whenever I am relaxed, I don't need to see much. I'm relaxed. I'm having no emergency in front of me. So, do my pupil is small or large? I don't want much vision. So, meiosis. Pupil is constricted. I mean meiosis. So here meiosis is there. But whenever we are in emergency, there is a tiger in front of me. I need a wide vision. So mydriasis. You can learn like that. Okay. So here mydriasis. Coming on salivary gland. Whenever I'm relaxed, I can eat. I will feel hungry after some time. I will have my dinner. So salivation takes place. Salivation, increase saliva. But whenever we are in some emergency, there is a tiger behind me. Someone say, you want to eat food? No, I do not want. Salivation will not happen. So it inhibits saliva. You can see. Okay. Again, coming on the heart, the next organ, the third organ is heart. Whenever I'm relaxed, my heartbeat is less. Less means it is normal. 70 to 100. It's normal. No, heartbeat is reduced and normal. But whenever, my tiger behind me, my heart is pumping like anything, my heartbeat will be more than 120 per minute. So it is, increased heartbeat, increased tachycardia. Coming on the lungs, currently I'm relaxed, so I don't need much oxygen. I'm relaxed. Okay, so here bronchoconstriction. But whenever tiger behind me, all my muscles are contracting, so I need more oxygen. So bronchodilation. You can see the actions are opposite. That's what I'm saying. Okay, so this is how action by action I will teach you, and I will teach you the individual systems. I hope you got the broad overview that sympathetic and parasympathetic system, on every organ the action is opposite except few organs. So these are the various organs. Suppose this is one of the organ of my body. This is one of the organ of my body. So it is having sympathetic as well as parasympathetic. It is having both nerve supply. Okay. Whenever I am relaxed, this one is active. Whenever I am in emergency, this one is active. Here the end neurotransmitter which is released is acetylcholine, and here the neurotransmitter which is released is noradrenaline. So here acetylcholine will show that particular effect. Here noradrenaline will show that particular effect. Now suppose say this organ is heart. So acetylcholine reduce the heart rate, noradrenaline increase the heart rate. Suppose this organ is lung. So acetylcholine constrict the lung, bronchoconstriction, and this one dilate, bronchodilation. Suppose this organ is saliva. So it increase the salivation, this reduce the salivation, like that. So on most of the organs, the actions are opposite except male sex organ where the action is complementary. That is erection followed by ejaculation. Everyone give me a thumbs up. I will be very fast, but you can ask your query. Okay, got it. So this is what we have studied. The two type of systems: parasympathetic system, sympathetic system. You can see organ by organ. So on eye, parasympathetic means I'm relaxed. Okay, I'm relaxed. Right now I'm relaxed. But sympathetic, tiger behind me, right? Emergency. Okay. Here I don't need much vision, so meiosis. But in emergency, tiger behind me, I need wide vision. So mydriasis. Okay, saliva. Here I can eat. I will be hungry. Okay, because I'm relaxed. So salivation is necessary. But whenever we are in emergency, we don't eat. So here salivation decrease. Do a correction. Heart may currently my heart rate is reduced, normal. But emergency, there is an emergency, so heart rate will increase. All the smooth muscles normally constricted, but in emergency they go relaxation. Okay, like that. But here on male genitalia, that is penis, erection and ejection are not opposite to each other. This is complementary to each other. But at other organs, you can notice the action is opposite. Okay, so we are done with the overview of ANS. I want a thumbs up from each and every one of you who is live right now. I started from the scratch. My way of teaching. This is a rapid revision, but still I'm obsessed to start from the scratch. Okay, the students who are new, who have not read anything, it is from the scratch. Now I will start the drugs quickly. So I will teach you 4 chapters. Okay, cholinergic, anticholinergic, adrenergic, antiadrenergic, one by one in just 4 pages, in just 4 master chart. Okay, what are my 4 master chart I will teach you? You can see cholinergic drugs, I will fill here. Anticholinergic drugs, I will fill here. Adrenergic, I will fill here. And antiadrenergic, I will teach you in 2 parts, alpha blocker and beta blocker. Alpha blocker, I will fill here, beta blocker. So total not 4, there are 5 drugs, 5 categories of the drugs I want to teach you today only, very fast way. If your basics are strong now, it's very easy to understand these drugs. These drugs are very most easiest chapter of the pharmacology is this one. But your basics should be strong. So here I will teach you conceptually, not with the help of just rectification or mnemonics or like that. Okay, it will be conceptual so that it imbibe in your mind permanently even after the exams. So let's start one by one. The 4 chapters: cholinergic, anticholinergic. So cholinergic and anticholinergic, these 2 systems will act on parasympathetic system. Okay, and adrenergic and anti-adrenergic drugs, these 2 drugs will act on the sympathetic system. So one by one we will take the systems. First, parasympathetic system, I will teach you 2 chapters: cholinergic, anticholinergic. Here the main neurotransmitter is acetylcholine. Then for the next 2 chapters, that is adrenergic and anti-adrenergic, I will teach you sympathetic system drugs. These are the sympathetic, they act on the sympathetic system. Here the main neurotransmitter is noradrenaline. Can we start? Can we start? So let me start the first 2 chapters, cholinergic and anticholinergic, quickly. So I will teach you first cholinergic drugs, followed by anticholinergic drugs, one by one. As I told you, these 2 act on the parasympathetic system. Both these drugs, cholinergic, anticholinergic, they act on parasympathetic system. Okay, so the main neurotransmitter here is acetylcholine. You can't understand these drugs unless and until you understand the acetylcholine completely. So first you understand, because I'm teaching you the drugs acting on this system. You can see parasympathetic system. Okay, the drugs acting on this system. I will be teaching you. Cholinergic also act here, anticholinergic also. So first, it's your responsibility to understand acetylcholine in detail. So let me first teach you acetylcholine in detail, then I will start. So when I will teach you these two, first acetylcholine I will teach you. Then I will complete these two chapters. Then before starting these two chapters, I will teach you everything regarding the noradrenaline. Then I will start the remaining two chapters. In this way, the 4 chapters will be done dusted today. So let's see acetylcholine. It is the main neurotransmitter for cholinergic as well as anticholinergic drugs, right? Acetylcholine, you can see here. This is acetylcholine. So I want to tell you 4 things regarding the acetylcholine before I start. Its synthesis, its storage, its release, and its destruction. Okay, just a second. I will teach you 4 things over here. Okay, its synthesis, its storage, its release, and its destruction. 4 things. Then we will start the drugs quickly. How does acetylcholine synthesized over here? Can you see here? I'm talking about here. Everyone focus here. Here, this is the acetylcholine. How does it synthesized? It is released and act on its receptor, but how does it is synthesized? So it is synthesized here in the axon, in the exoplasm, in the axon of this neuron. Can you see the axon of this neuron? Postganglionic. Don't see the preganglionic. Okay, see the postganglionic one. In the postganglionic one, this acetylcholine is synthesized. So how does it synthesize? What are the steps? So there is an amino acid which is known as choline. So first choline go inside, choline uptake. Okay, so there is a transporter for this choline uptake. So this choline, that is amino acid, it will be uptake with the help of a transporter. The name of this transporter is sodium choline transporter. Can I zoom it? Can I zoom this portion so that you can see this portion as a zoom version? This is the zoom version. Can you see this yellow portion? This yellow portion is the zoomed version of this axon, inside which the acetylcholine synthesis, the steps I will tell you. And can you see this organ, the purple organ here I have shown you? This is the same organ here I have shown you. This is the green organ. So you know this is the acetylcholine. How it is synthesized? So step number 1. You can see choline, which is the amino acid. First of all, the choline uptake will take place. Okay, with the help of a transporter. The name of that transporter is sodium choline transporter. So the choline will go inside. It will reach in the exoplasm. Okay, then acetyl-CoA will come. Acetyl-CoA will donate this acetyl group to the choline and choline convert into acetylcholine. Choline will convert into acetylcholine. You can see. So choline go inside with the help of this transporter. Then acetyl-CoA will give its acetyl group to the choline and choline will convert into acetylcholine. Okay, with the help of an enzyme, choline acetyl transferase. Okay, now the acetylcholine is already synthesized. It will go inside the vesicle, synaptic vesicle, and get stored inside that, and it will be there only. Okay, so for entering inside the vesicle, there is another transporter, and it is entering inside this vesicular transporter. It is entering inside the synaptic vesicle and remain inside here only. This is how the synthesis takes place. So acetylcholine, once synthesized, it will be there inside the vesicle, synaptic vesicle. So this is synthesis. I hope everyone got it. Here also you can see the same steps. First you see the choline, appreciated. This is choline. Choline uptake taking place. Choline is converting into acetylcholine. Once choline converted into acetylcholine inside the exoplasm, the cytoplasm of the neuron, it will be stored into the vesicles. You can see the green color vesicles I have drawn. It will remain there. Now, how does it is released? And when it is released? When here the signal is coming. When the nerve impulse, depolarization is coming. When the nerve impulse is coming here from the brain and the spinal cord. When the nerve impulse is coming here, it will get a signal that I have to release. At that time, the membrane of the vesicle fuse with the membrane of the axon. Okay, so when the signal come, here depolarization takes place. When the signal is coming here, signal, this is signal. When the signal is coming here, at that time, there are calcium channels present on the exoplasm. These calcium channels will open. The calcium influx will take place. The calcium from the blood enter in the exoplasm. Because of the calcium in the exoplasm, the vesicles will fuse with the exoplasm membrane and acetylcholine will be released. You can see here. You can read here. So influx of calcium, and calcium causes fusion of the vesicle with the axonal membrane and acetylcholine release out. You can you see this brown color vesicle? Say yes. When the calcium, it is not shown here, when the calcium influx takes place at the time of depolarization wave, at the time of the signaling, the calcium influx takes place, because of which this vesicular membrane fuses with the exoplasm membrane and the acetylcholine comes out. This is how release. So you know how synthesis takes place, you know how release takes place. After release, what does it do? It will act on its receptor. You can see the 2 type of receptor, muscarinic receptor, nicotinic receptor, M and N receptor. So it will come and act on its receptor, the M receptor and N receptor. It will act on its receptor, muscarinic and nicotinic. You can see here. So you can see this is the neuron. You can see this blue color is the acetylcholine It is synthesizing and it is going and acting on its receptor, the muscarinic or nicotinic. It is acting. For how long it will act? You can see here, it is acting for a fraction. It is acting for a fraction of second, not even 1 second. I'm saying it is acting for a fraction of second. After a fraction of second, it is destroyed. It is destroyed. So who is destroying it? So third thing, synthesis, release. Now after release, it is acting on its receptor for how long? How long? Fraction of second. And after that, we have to destroy it. So how does the destruction of acetylcholine action take place? So acetylcholine first comes, it acts on muscarinic and nicotinic receptor for a millisecond rather than less than millisecond, fraction of second. After that, we have to destroy it. So who is destroying? So the great God has given an enzyme at this junction. I'm talking about the junction. Which junction? The junction of the nerve and the smooth muscle. In this space, okay, you can see the space in which the acetylcholine is there. I've shown the acetylcholine is green color. It is there. So there is an enzyme. The name of this enzyme is cholinesterase, or you can say acetylcholinesterase. Acetylcholine. So acetylcholinesterase, this enzyme the God has given. So after a fraction of millisecond, this enzyme degrade the acetylcholine. This enzyme degrade the acetylcholine into what and what? This enzyme, acetylcholinesterase, will degrade the acetylcholine into choline and acetate, and they are reutilized. So acetylcholine is gone. So which enzyme? Please mind this enzyme. If you want to understand the mechanism of action of various type of drugs, please learn the name of this enzyme. It is acetylcholinesterase. Acetylcholinesterase enzyme. Okay, it is causing degradation of the acetylcholine after its action. So this is how you can see here. This is the enzyme. So once it has already shown its action, it will degrade it. It will degrade it by this enzyme. You understood this diagram, everyone? If you understood this diagram, so you already know how the acetylcholine is synthesized, how it is released, and how it is destroyed. You know the 3 steps. Shall I repeat it? See, synthesis. So choline is the amino acid. So first of all, choline uptake takes place via sodium choline transporter. Once the choline is in the exoplasm, the choline get converted into acetylcholine with the help of an enzyme. This acetylcholine is stored inside the vesicle and remain there. When the wave of depolarization is coming, when the signal is coming, at that time the calcium influx takes place, and because of the calcium influx, the vesicular membrane fuses with the exoplasm membrane, and the acetylcholine released out in the space between the nerve and the smooth muscle. In this space it is coming, it will act on its receptor, the muscarinic and the nicotinic, for a fraction of millisecond. After that, we have to destroy it. It cannot keep on acting for longer hours. We have to destroy it. So the God has given an enzyme. The name of that enzyme is acetylcholinesterase. Very important. It is already present in this space. As soon as acetylcholine come out, after a fraction of millisecond, it destroyed, it converted into acetate and choline, which are reutilized. So this is done and dusted. I hope everyone got it. Now let's talk about these receptors, muscarinic and nicotinic. So muscarinic receptor actually are of 5 types: M1, M2, M3, M4, M5. But M4, M5 are not important. In our syllabus, we have to see the details of M1, M2, M3. But in reality, they are of 5 types. Nicotinic receptor are of 2 types, NM, NN. We don't call N1, N2. Mind it. It is NM and NN. So total 5 type of receptors are there. Now these receptors are present in our body from head to toe. These receptors M1, M2, M3 and NM and NN, they are already present from head to toe on various organs. The God have already done its job. The God has already distributed these receptors. You have to learn it. Which receptor is present here? So M1 is present on which organ? M2 is present on which organ? M3 on which? NM on which? And NN on which? So this is the chart. Now this is my master chart. I call it master chart. If you understand this chart, the next 2 chapters, mind my words, the next 2 chapters, cholinergic, anticholinergic, will be at the tip of your tongue. You have to understand that. You have to just learn this chart. Now, there is no logic behind that. The God has given these receptors on these organs. You have to learn that. There is no logic behind that. The logic is God only. So the God has given M1 on 3 organs. Which 3 organs? Say the 3 organs. Am I live now? Just a second. I guess I'm. So the God has given M receptors on 3 organs. One is on brain, central nervous system. One is on ganglion. You know the junctions I have told you, preganglion, postganglion, junction. And one is on stomach. So you can learn brain, stomach, and the ganglions. M2 is given only on one organ, heart. M2 is given only on one organ, heart. And rest all the organs we are having M3. Which all organs? On all smooth muscles. This is cardiac muscle. On all smooth muscles, we are having M3. On all smooth muscles. Okay, smooth muscles of GIT, lung, urinary bladder. These 3 are important. Uterus. So M3 is present. Okay, in their sphincters also, M3 is present. In the eye, M3 is present. On all glands of the body, salivary gland, sweat gland, lacrimal gland, tracheobronchial gland, gastric glands, all glands of the body, M3 is present. On the blood vessels, M3 is present. And on male sex organ, that is penis, M3 is present. Okay, so there is a mnemonic in Hindi. If you understand in Hindi, pehle khao, okay, fir dil lagao. बाकी सब काम बाद में. So this is how you can learn the sequence of M1, M2, M3. Okay, so M1 is present, पहले खाओ, it is in stomach and brain. फिर दिल लगाओ, so M2 is on heart, and बाकी सब काम बाद में, M3 on rest of the body. You have to learn as it is written. So this is M1, M2, M3. What about NM and NN? So what about NM and what about NN? NM is present on neuromuscular junction. NN not very important, you can read, but NM is present on neuromuscular junction. The neuromuscular junction, I told you, the somatic system, if you remember my diagram, my first diagram, in somatic system at neuromuscular junction, this NM is present. So with this introduction, I would like to start my first chapter out of 4. I want to teach you 4 chapters today, only in the next 2 hours. So let me start my first chapter, cholinergic drugs. If you understood this chart now, the next 2 chapters, cholinergic and anticholinergic, will be fun for you. Can I start? Everyone give me a thumbs up. People show some interest. Chalo. So let's start cholinergic drugs. Cholinergic drugs under these heading. Okay, first of all, I'm starting cholinergic drugs. Tell me the definition, then classification, then mechanism of action, then pharmacological action. If you understand pharmacological action, from this only, I will take the good ones as uses and the bad ones as adverse effect. So just learn the pharmacological action. You yourself decide the good one, that will be the uses, and the bad one, that will be the adverse effects and contraindication. So this is how we are going to complete the chapter in the next half an hour. Let's start the definition. Quickly, definition of cholinergic drugs. What is cholinergic drugs? Cholinergic drugs. You know, this diagram is a master diagram. See, what is cholinergic drug? You see, ma'am, God has already given acetylcholine, no? The natural neurotransmitter which is present inside all our body. So why need the additional cholinergic agonist? Why we need the cholinergic drugs? You know, acetylcholine, let's take a example, heart. What does acetylcholine do on heart? I told you, it reduces the heartbeat. It reduces the heartbeat. Okay, heartbeat is normal when we are relaxed. Currently, my heartbeat is normal, it's reduced. It's normal. I mean, reduced means it's normal. Okay, so suppose this organ is heart. I have drawn heart, and normal acetylcholine reduces the heartbeat. Okay, but you know it is not able to reduce it that should be there. So normal range of heartbeat is 70 to 100, but even after the acetylcholine is acting, the heartbeat is 120. Suppose someone, not mine, but anyone's, any patient. So any patient coming with a heartbeat of 120 or more than that, suppose. So acetylcholine maximum it can reduce the heartbeat to that. We want to reduce more. So we want to give a drug, external drug that go on this junction via blood. We will give orally, injectably, via any route. But we want the drug to reach at this junction. You can see the junction between the nerve and the effector organ. So we want that particular external drug to reach here and act in the same way as acetylcholine is doing. Do the same thing as acetylcholine is doing. So it will exaggerate the action of the acetylcholine. That's why these are known as cholinergic drugs. So I hope you got the definition. What are cholinergic drugs and why they are required? So whenever the natural acetylcholine is not sufficient on that particular organ to show its action, we need some external agency to exaggerate that effect, and that is known as cholinergic drug. Now there are 2 types of cholinergic drug. Via 2 ways we can do so. See, what is the natural? Forget the drug. What is the natural acetylcholine is doing? You tell me. Say, ma'am, the natural acetylcholine acting on muscarinic or nicotinic receptor, depending what organ is it. Muscarinic maybe is it M1, M2, M3, depending what organ is it. It can be any organ. So it is going and acting on that organ and showing its action. So there can be a drug, there can be a cholinergic drug that will also come in this junction and bind with these receptor and stimulate these receptor in the same way as acetylcholine is doing. These drugs are known as cholinergic agonist. They bind with the receptors like acetylcholine do and stimulate the receptor in the same direction as acetylcholine do. So basically by acting on the receptor, it is exaggerating the action of acetylcholine. That is the first type of drug. The second type of drug, now please mind, the second type of external agency drug, they don't act on the receptor. They come at this junction, and they inhibit the enzyme acetylcholine esterase. What does this enzyme used to do? This enzyme used to destroy the natural acetylcholine after a fraction of millisecond. So these drugs are not acting on muscarinic and nicotinic receptor. They just destroy the enzyme which destroy acetylcholine. Ulte ka ulta sulta. You have heard it. I mean, this drug is destroying the enzyme which is inhibiting the enzyme, or destroying the enzyme which is inhibiting acetylcholine, destroying acetylcholine. So the natural acetylcholine will bind with its receptor for a longer duration and exaggerating its action. So this is the second type. Ultimately, the cholinergic actions will be more, either directly or indirectly. So these type of drugs, since they are inhibiting the enzyme, which enzyme? Choline esterase enzyme. That's why they are known as anticholinesterase. Anticholinesterase drugs. Mind my words very clearly. Anticholinesterase drugs are cholinergic drugs. Don't get confused. Anticholinergic drugs are different. I'm not saying anticholinergic drugs. I'm saying anticholinesterase drugs. The anticholinesterase drugs are cholinergic drugs. Okay, what these drugs are doing? They are inhibiting the enzyme cholinesterase. cholinesterase used to degrade acetylcholine. Since the cholinesterase get inhibited, so there is no one to degrade acetylcholine, and acetylcholine, the natural acetylcholine, will bind with its receptor for a longer duration and exaggerated section. Give me a thumbs up, people. Give me a thumbs up. Got it? These are the two types of cholinergic drugs. So say, people say, what are the two types of cholinergic drugs? First of all, you understood why we need external agency. We need external agency, to exaggerate the cholinergic action in some humans if natural acetylcholine is not sufficient in them. Even we all have natural acetylcholine, maybe less in some human, more in some human. So if it is less and it is not sufficient to show that particular action on a particular organ, we need external agency, to exaggerate that action. So there are two type of drugs we are giving, for that. Drug one, the first drug, the drug one is Hamshakal, identical twin of the acetylcholine. It looks as it is as that of acetylcholine. So whenever this drug, suppose D1 I am taking orally or injectably, so D1 will reach via blood at this junction. So, this receptor, muscarinic and nicotinic receptor, think that this drug is also acetylcholine. They will bind with this drug also like the same way as they used to do for the acetylcholine, and it will stimulate the receptor in the same way as that of acetylcholine and show the same action as acetylcholine. So these are Hamshakal. I call them the twin, Hamshakal, identical twin of acetylcholine. These are known as cholinergic agonist. These drugs are known as cholinergic agonist. They bind with the receptor in the same way, okay, as acetylcholine used to do. And the second type of drug, D2, they don't bind with the receptor. They have a different phase. They are not Hamshakal. So when I'm taking D2 orally or injectably, when via blood, D2 will reach at this junction. When D2 is reaching here, at that time, the M or N receptor will not bind with D2. They will see it is having some other phase. So this is not acetylcholine. We will not bind with them. So this D2 cannot bind with M and N. Okay, but what the D2 will do? D2 will destroy. It is having a gun and it will destroy the enzyme that is used to destroy acetylcholine. Okay, so cholinesterase enzyme will be destroyed. Cholinesterase is destroyed. Okay, so there is no one to destroy natural acetylcholine now. Natural acetylcholine remain on the receptors for a longer duration. These drugs are known as anticholinesterase drugs, which are also showing the cholinergic. So basically, cholinergic agonist exaggerate the cholinergic action by binding with muscarinic nicotinic receptors, and anticholinesterase drugs exaggerate the cholinergic action by increasing the duration of natural acetylcholine on its receptor. So these are the two types of cholinergic drugs. I tried my best, people. I hope you got it. Okay, the two types of cholinergic drugs. I taught you, I'm starting the first chapter out of 4. Drugs acting on ANS. I taught you the definition of cholinergic drugs. Read the two definitions. There are two types of cholinergic drugs, and I've explained both of them. I hope you can see here what the drug 1 is doing. Drug 1 is coming and acting on this receptor and stimulating in the same way. The drug 1 is Hamshakal, identical twin of acetylcholine, and the drug 2 is inhibiting this enzyme, inhibiting the enzyme cholinesterase. That's why known as anticholinesterase. So definition is done. Coming on classification, I already taught you the classification, the two type of the drugs. What are the two type of cholinergic drugs? Cholinergic agonist and anticholinesterase. Anticholinesterase are also cholinergic drugs. I'm not saying anticholinergic drugs. I'm saying anticholinesterase drugs. Mind your question in your university exam. Okay. So these are the two type of drugs, cholinergic agonist and anticholinesterase. Okay. Cholinergic agonist, further we divide based on their chemical composition. Which of them are esters and which of them are alkaloids. Esters are in front of you. We have natural acetylcholine inside us. Artificial acetylcholine also available. This is the artificial acetylcholine. Apart from natural, artificial is also available. Okay, methacholine is also available. Carbachol is also available, and bethanechol. So acetylcholine, methacholine, carbachol, bethanechol. These all are esters. Okay, they are Hamshakal of natural acetylcholine. And alkaloids mein muscarine, pilocarpine, ericolin. These are also Hamshakal. They all are Hamshakal, the identical twins of the natural acetylcholine. Some of them are esters, some of them are alkaloids. You have to learn as it is. Okay, coming on anticholinesterase. Anticholinesterase, what these do? They destroy or they inhibit the enzyme cholinesterase. This enzyme used to destroy acetylcholine. Since this enzyme is gone, there is no one to destroy. So whether they are inhibiting this enzyme reversibly or irreversibly, this is the basis of classification of anticholinesterase. So the basis of classification of anticholinesterase, they both inhibit this enzyme. You can see this enzyme is gone. It is inhibited, but reversibly, I mean temporarily or permanently. Is it reversibly or irreversibly? The reversible one are carbamates and the irreversible one are organophosphates. If you can learn complete classification, very good. If you can't, at least learn some the main drugs or prototype drugs. So carbamates में physostigmine, neostigmine, pyridostigmine, you have to learn edrophonium, okay, rivastigmine, donepezil, galantamine. You have to learn all carbamates. All of them are actually important. Okay. And organophosphates में, you can see organophosphates, daflos, okay, malathion, diazenon. These all are organophosphates. So I hope everyone got it. So we have two type of cholinergic drugs. My chapter is cholinergic drugs. Okay, what are the two type of cholinergic drugs? Cholinergic agonists, the humshuckle, the identical twin of acetylcholine, they act on the receptor. And the second one is choline esterase, anticholine esterase. Okay, they inhibit the enzyme choline esterase. The basis of classification is this is their chemical composition, esters and alkaloids. And the basis of classification, whether they are inhibiting the enzyme reversibly or irreversibly. The reversible one are carbamates and the irreversible one are organophosphates. And I request all of you to learn the drugs inside each category because you get long questions on many of them. If a long question is coming in your university exam, the first step you should identify the category of that drug. If you don't even identify the category, what you are going to write. So classifications are must, ultra important, stick it on your wall. So on our app, we have uploaded a 60 pages, approximately 50-60 pages PDF. It's printable. Take a printout of that, okay? And it is one side print. You stick it on your wall, okay? All the important classification of complete pharma in one shot, okay? So aate jate, khate pite, look at that, and you will realize by the end, in few days, whenever you are having exam, you can recognize that which drug is from which category. Okay, now, so we are done with the definition of cholinergic. We are done with the classification of cholinergic. Let's come on the mechanism of action. I already taught you the mechanism of action, the two categories. So mechanism of action of cholinergic agonist and the mechanism of action of anticholinesterase. You see how to write in your exam in the form of the flow charts. So mechanism of action of first cholinergic agonist, the humshuckle one. Okay, so cholinergic agonists are humshuckle of acetylcholine. Write down in English. They are structurally similar to acetylcholine. That's why when they reach this junction, that muscarinic and nicotinic receptor think, yes, it's acetylcholine only, they accept it. They bind with it. So they bind with muscarinic as well as nicotinic receptor because the receptor cannot differentiate the real one and this artificial one. They stimulate this receptor in the same way as acetylcholine used to do. So this is how they are bringing cholinergic actions. And the anticholinesterase, they are not humshuckle. They are not identical twin. You can see these drugs. They reach at this junction and they inhibit this enzyme. The name of the enzyme is cholinesterase enzyme. This enzyme is gone. So the natural acetylcholine will be protected from degradation. Okay, so the natural acetylcholine will remain at the receptor for a longer duration. So basically they are potentiating the action of the natural acetylcholine for a longer duration and they are prolonging the cholinergic effects. So I hope you got the both. Okay, now these are of two type. Carbamates and organophosphates. Carbamates are reversibly doing so and organophosphates are irreversibly doing so. Both of them are inhibiting the enzyme. Further hydrolysis will be slower, but here extremely slower. Here it will be back in 6 hours. Here it will be back in more than 100 hours. So 100 hours we are considering almost irreversible. 100 hours mein to naya enzyme will be formed. So we are considering it's irreversible. I hope you are getting it. Okay. So definition is done. Classification is done. Mechanism of action, we draw two flow charts for both of them. Okay. Now pharmacological action must. Please, I request to understand the pharmacological action in my ways. Okay, the good things in that, take it as uses. And the bad things in that, take it as adverse effect. Chapter done. Okay, please understand the pharmacological actions, what these drugs used to do. Okay, so please, while considering the pharmacological action, never forget what I'm teaching you. I'm teaching you cholinergic drugs, which are exaggerating the parasympathetic system action. Cholinergic action. Parasympathetic action comes in our body whenever we are relaxed. Not emergency. It is a relaxed system, always. Now, pharmacological actions I'm dividing in two categories, the muscarinic, the nicotinic. You already know my two charts. Here we have M1, M2, M3. Here we have NM, NN. God has given these receptors on what organ? Okay, you already know that. So let's start the muscarinic. Okay, this I already taught you. I assume each and every student of mine knows it. Okay, if you don't know, please learn it first before we proceed. Okay, here M1 is not important, so I'm directly starting from M2. So first I will teach you M2, then M3 may one by one. One by one, we will take all these categories. So M2, M3 all category, then we will move on uses and adverse effects. Let's start with M2. M2 may only one organ, heart. M2 is present where? Heart. I told you the mnemonic, पहले खाओ, फिर दिल लगाओ, बाकी सब काम बाद में. So M2 is present on the heart, है ना? So what does my natural, I'm having a heart. Okay, here is my heart. So on my heart, the God has given M2 receptor. On all of our heart, the great God has given M2 receptor. So on M2 receptor, the natural acetylcholine is also there at the junction. So when the natural acetylcholine come and bind with the M2 receptor on my heart, what does it used to do? It decreases heart rate, decreases contractility, decreases velocity. It decreases three things in the heart. Okay, it is negative dopamine dependent, negative inotropic, negative domotropic, and negative chronotropic. It is reducing all because I'm relaxed at. During relaxed state, I don't need much heart rate. I don't need much contractility. I don't need much velocity. I'm in relaxed state. So all these things are reduced by the natural acetylcholine over here. You're getting my point. So heart rate, heart velocity, and heart contractility. I mean, inotropic, domotropic, and chronotropic. It is negative. It is reducing the natural acetylcholine. So this is our heart. In our heart, this is the M2 receptor given on the myocardium of all of us. When natural acetylcholine combined with this M2 receptor, it reduces the heart rate, it reduces the contraction, it reduces the velocity. So negative chronotropic, negative inotropic, negative chronotropic. This is natural. So these drugs also do the same. Whatever acetylcholine do, both these drugs, cholinergic agonist and anticholinesterase, they exaggerate that effect. So both of these category, they reduces heart rate, they reduces velocity, they reduces contraction. So you imagine the diseases in which it will be helpful. Whenever heart rate is more, we give this drug. Whenever velocity is more, we give this drug. Whenever contractility is more, we give this drug to reduce it. The drugs do that. Okay, I hope you are getting it. Now come on M3. We have seen the M2. M2 में only one organ was their heart. Come on the M3. M3 me first, please do understand people. Please. Visceral smooth muscle. I will be explaining you 3 organs here. I will be explaining you GIT, then urinary bladder, then lung. Please do understand. Students have much confusion over here, I have seen. One by one, I will take. Okay, first GIT. See, this is GIT. First, I will take GIT, then I will say bladder, and then lung. GIT, bladder, lung. All of them are smooth muscle. Let's take GIT. Can you see the first one? This one, this diagram. Both of them are GIT. See, in the GIT, the God has given us the rectum. The complete GIT. Suppose this is the rectum, and this is the anal sphincter. This is the anal sphincter. Here we are having the sphincter. So we are having M3 receptors on the rectum. I mean, complete GIT, not only rectum. I'm saying rectum, it's complete GIT from esophagus onwards. And it is the M3 receptor on the sphincter. It is the M3 receptor on the sphincter. Whenever we are relaxed, whenever the humans are relaxed, we can defecate. Okay, but in emergency, no one defecate. Okay, so here the defecation is possible. I mean, the sphincter can relax. When defecation will occur, when the muscle will contract and sphincter. Suppose this is a tube and there is a sphincter. To defecate it, we have to relax the sphincter and contract the muscle. So defecation happens. Okay. So here you can see we are relaxing. We are contracting the muscle and relaxing the sphincter. Okay, contract the muscle, relax the sphincter. So defecation can happen and it's a relaxed state. In relaxed state, the persons can defecate in relaxed state. So this is what the action of the GIT. So on action of GIT, say ki ma'am on muscles. Here we have 4 layers. I guess everyone know the basic. Mucosa, submucosa, muscularis propria, and serosa. So I'm talking about the M3 receptors on the muscularis propria. So muscularis propria is contracting. Okay, contracting, and the sphincter is relaxing. So defecation takes place. So you can see here. Okay, so muscularis propria contract and the sphincter relax. And you can see this is how the defecation takes place. I hope you got it. So again say muscle contract, sphincter relax. This is the action of acetylcholine. This is the action. Same occurs with bladder. See the bladder. So whenever we are relaxed, the humans are relaxed, we can urinate. In emergency, we don't urinate. Okay, in emergency, there is a tiger behind me, I'm running. The people don't urinate. We don't have time in emergency to urinate. Okay, so urination don't happen in emergency. Now there is a confusion. Many students ask me a question we have seen in movies or in somewhere whenever the persons are in emergency, they urinate in their clothes only. So that is the stimulation of parasympathetic system after exaggerated sympathetic. Okay, but please learn the summary. During sympathetic activation, urination don't happen. During parasympathetic, it's happened. So for urination, again, we have to contract the muscle and we have to relax the sphincter. The same thing. Okay, contract muscle, relax sphincter. So muscle has to be. So we have M3 receptors on the bladder and M3 receptors on the sphincter. The same. The urinary sphincter. So contract the muscle and relax the sphincter, so urination happens. You can see here. Contract the muscle, relax the sphincter. Here also muscle contract, sphincter relax. Here also muscle contract, sphincter relaxed. So the summary here, the person can defecate, and the summary here, the person can urinate. This is these drugs are doing. We will use them in opposite disease. Okay, so these drugs help the person to defecate. So we will give them in constipation. These drugs help the person to urinate. We will give them in urinary retention. So these are the diseases in which we will give. If you understand the basic, it's very easy. Now, what about the lungs? Lungs don't have sphincter. Lungs have only muscle. So they are constricting the muscle. See, here also muscle contract, muscle contract, muscle contract. But the other 2 organs have sphincter also, that was relaxing. So the summary, GIT, urinary bladder, and the lungs. Okay, here we have muscle and sphincter. Okay, so muscle contract, sphincter relax, it don't have sphincter. This is a summary, very easy. So muscle contract, sphincter relax, so defecate. Muscle contract, sphincter relax, so urinate. And muscle contract, bronchoconstriction. So these drugs causes bronchoconstriction. People never ever give them in asthma. So asthma is a contraindication because these drugs constrict the lung. I hope you are getting it. You are getting the good things from here as uses and the bad things from here as adverse effect and contraindication. Take it like that. You can see this is the bronchial bronchi and bronchioles. It is constricting the bronchioles. I hope you got it. So that was about the M3 receptor. People say that was about the M3 receptor. You can see over here. Now coming on the eye, again, very complicated. I mean, it's very easy, but students have much confusion over eye. I will teach you the action on the eye of all 4 chapters in one shot. Today I'm going to teach you 4 chapters. Which 4 chapters? I'm going to teach you cholinergic, anticholinergic, adrenergic, and antiadrenergic. I will teach you all 4 today only in the next 2 hours. Yes. So I will teach you the action of these 4 drugs on eye in one shot right now. I will not repeat it 4 times. So currently in cholinergic only, I'm teaching you the action on eye of remaining 3 also. Okay. So at remaining 3, whenever the eye will come, I will skip that portion. I will just show you the slide. I will not explain it again. So see eye. Please understand eye. Where is my eye model? Okay. I will try just a second. You know eye, human eye. Give me a minute. You have to give me a minute. Just a second. My model is not ready. You can appreciate this is human eye. It is like a sphere. You can see it's like a sphere. And this is the iris. We are having the iris over here. Okay. The iris is like a curtain with a hole at the center, which is known as pupil. You can see it's like a sphere. Okay. We can open the sphere to see the layers here. Okay. Normally I teach ophthalmology with this model. I will show you the iris over here. So let me take the iris separately. I need iris to explain you the meiosis and mydriasis, which muscle is causing like what. So let me keep the rest of the sphere, rest of the eyeball, and let me keep iris in my hand. Okay, iris is attached with the ciliary body. Here we are having the ciliary body. On the next page, I will show you the ciliary body. Just a second. Here you can see. So this is the eyeball. This is the iris. If I cut it from the side, it will look like this. Let's cut it from the side and see the side view. It is like this. Let me keep it. Okay. It will be like this. I will keep this in my hand and explain you the action of the eye, the action of these drugs on the eye. You can see this. So in the eye, we are having 3 layers. I'm interested in the middle layer. In the middle layer, the middle layer is known as uvea. In the uvea, we are having 3 structures. You know, this brown color structure, you can see black color. It is choroid. The anterior connection of choroid is ciliary body. See the orange structure. The orange one is the ciliary body. And the anterior continuation of the ciliary body is the iris. See this blue structure. Blue structure is iris. So from the side, if you cut it like this, from the side, it is looking like that. But from the front, it's like this with a hole at the center. You can see this is pupil over here. You can see from the side. This is the pupil, I hope. So this hole is the pupil. You can see. So iris is not like this. Iris is a circle with a hole. It's like a curtain. Okay. So currently I'm interested in 2 type of muscle. I'm interested in iris muscle and ciliary muscle. Where is the iris in this diagram? Say, where is the iris in this diagram? The blue color. And where is the ciliary body in this diagram? The orange color. Appreciate the blue color and appreciate the orange color. Can you see the blue color and orange color on the screen? You can see. So blue color is your iris. This one, and this orange color is your ciliary body. I will tell you what is the action of these 4 chapters, the drugs on iris and on ciliary body. Basically on iris. You can appreciate this is the iris. It's in my hand. And behind that, this is the ciliary body, which is not here. It is in the complete model. You can see. In the iris, this is the pupil. Meiosis and mydriasis taking place. Meiosis means constriction of pupil. Mydriasis means dilatation of the pupil. I guess everyone knows that, right? Now, how does meiosis and mydriasis take place? Actually, how does it take place and which drug is causing what? Let me explain you here. You know, so inside the iris, the God has given 2 type of muscles. You can see the 2 type of muscles over here. You can focus on the 2 type of muscle. We are having circular muscles, which I'm drawing with a black color. These circular muscles. Circular muscles, when they contract, it's meiosis. The circular muscles is known as sphincter pupillae. They are like the circular. When they contract, it will be meiosis. And there are radial muscles. I'm drawing them with red color. The radial muscles, these one, the radial muscles. The radial muscles are known as dilator pupillae. So when the radial muscles contract, there will be mydriasis. You can imagine here there is a radial muscle which is contracting, radial muscle which is contracting, radial muscle which is contracting. You know, so overall the diameter of the pupil will increase. That's mydriasis. So I hope you got the 2 type of the muscle, meiosis and mydriasis. The 2 type of muscles is sphincter pupillae and dilator pupillae. The sphincter pupillae is the black one, I mean circular muscle, and the dilator pupillae is the red one, I mean the radial muscle. Call it SP, call it DP. So we have 2 type of muscles in the iris, SP and DP. If you can see closely here, also it is drawn. The circular one are sphincter pupillae and the radial one are the dilator pupillae. I hope you are getting it. You know, so when the sphincter pupillae SP is contracting, it's meiosis. And when the DP is contracting, when DP, dilator pupillae contract, Dilated pupilla contract this way, this way, this way, this way, radially. So it will be mydriasis. So I hope you got it. Which muscle is causing meiosis? Which muscle is causing mydriasis? Now, again, use your logic. Whenever we are relaxed, I don't need much vision. I need meiosis only. So meiosis is caused by which muscle? Sphincter pupilli. So sphincter pupilli is supplied by parasympathetic system. It is supplied by parasympathetic system. And dilated during emergency, I need a wide vision. So dilated pupilli is supplied by sympathetic system. So please learn, or you understand by logic. Please, you can see the green colored nerves over here. Can you see the green colored nerves? This green colored nerves. So this, you can see this one is a dilated pupilli. It is supplied by parasympathetic one, and this one is sphincter pupilli. You can see this is sympathetic. Sympathetic nerve is supplying the dilated pupilli, and parasympathetic, this one is parasympathetic. It is supplying the constrictor pupilli. Okay, sphincter pupilli, I mean. So you can understand it. Yes or no? Now use your logic. I hope you got the overview. Lose your logic. What is happening? When sphincter pupilli contract, what happens? And when sphincter pupilli dilate, what happens? Which drug causes constriction of sphincter pupilli? Sphincter pupilli is supplied by which nerve? It is supplied by parasympathetic nerve. So cholinergic drugs. Cholinergic drugs causes contraction, and anticholinergic drugs, they prevent the contraction. Okay, I mean they cause relaxation of sphincter pupilli. So cholinergic, and my next chapter, anticholinergic, they act on sphincter pupilli. Cholinergic drugs causes constriction, and anticholinergic drugs cause relaxation of sphincter pupilli, because both of them, sphincter pupilli is supplied by parasympathetic nerve, and dilated pupilli is supplied by sympathetic nerve. Okay, so I mean adrenergic drugs, my third chapter. Adrenergic drugs causes constriction of dilated pupilli, and anti-adrenergic drugs, okay, I mean alpha blockers in that. Anti-adrenergic drugs, they cause relaxation of dilated pupilli. So when sphincter pupilli contract, it will be active meiosis. Yes or no? When sphincter pupilli relax, there is no mydriasis. I mean, it is known as passive mydriasis. This meiosis unable to happen, it is known as mydriasis. That's why it is known as passive mydriasis. So this is active meiosis, this is passive mydriasis. And when dilated pupilli contract, it's active mydriasis. It is the radial muscle, active mydriasis. When dilated pupilli relax, so it is unable to do mydriasis. That's why passive meiosis. So I hope you got the four terms: active meiosis, passive meiosis, active mydriasis, passive mydriasis. This is a summary of the four chapters at one page in one shot. Now, I will not teach you this thing 4 times again. Currently, I'm interested in cholinergic drugs because my first chapter is going on right now. So cholinergic drugs act on the iris. Where is my iris? This is my iris. So this cholinergic drugs, my first chapter, cholinergic drugs act on the iris. So iris, it is acting on the circular muscle or radial muscle? It is acting on the circular muscle. Okay, sphincter pupilli. Okay, so it is having the receptors on sphincter pupilli. So sphincter pupilli contract. Whenever sphincter pupilli contract, active meiosis happen. Everyone give me a thumbs up if you got it. Everyone give me a thumbs up if you got it. This is sphincter pupilli. Say yes. Can we go ahead? So this is the action of the 4 drugs on the iris. Please do learn. The same thing is written. You can see this. I'm going to show you 4 times, one by one. The 4 chapters, 4 times it will come. You can see what does cholinergic receptors do? The cholinergic drugs do. Cholinergic drugs act on M3 receptor, which are present on sphincter pupilli, and they stimulate them in the same way as natural acetylcholine do. So they cause contraction of the sphincter pupilli, and they cause active meiosis. What does anticholinergic drug will do? My next chapter, they block these receptors. They block these. So natural acetylcholine is unable to bind them. So meiosis will not happen. So passive mydriasis will happen. Okay, similarly, you can see adrenergic drug and anti-adrenergic drug. I will show you this. I hope everyone got it. If everyone got it, please give me a thumbs up. Please, this is a summary chart I have drawn for you, the simplified version of action of the 4 drugs in ANS on iris. The 4 drugs in the ANS: cholinergic, anticholinergic, adrenergic, anti-adrenergic. You can write down cholinergic, anticholinergic, adrenergic, anti-adrenergic. Please say cholinergic drugs cause active meiosis, anticholinergic cause passive mydriasis, anticholinergic cause active mydriasis, and anti-adrenergic cause passive meiosis. Don't do learn. Please do understand if you can. I tried. Okay, so same story is written in front of you in various ways. I would like to show you a video over here to show you the meiosis and mydriasis. Let me try. You can see human eye, you can see the pupil, you can see the 2 type of muscle. Appreciate the circular one, appreciate the radial one. The circular one are with pink color, the radial one are with green color. You can appreciate the pink one are sphincter pupillae. You can appreciate the green one are dilated pupillae. When natural lights fall, the meiosis happen. You can see here, we are dimming the light. When the light dim, mydriasis occur. So they are showing how mydriasis and meiosis occur. Mydriasis is caused by dilated pupillae, and meiosis, when we are increasing the light, the meiosis in high light, we do like this. Okay, but whenever the light is dim, we do like this. So I hope you got it. Now see the pharmacological actions of drugs. The drugs will come. You can see here phenylephrine, here alpha, I mean adrenergic drugs. What does adrenergic drugs do? They cause active mydriasis. See, mydriasis have happened. Okay, this is adrenergic drugs, the alpha receptors. Now see muscarinic receptor agonist. These are cholinergic drugs. What does they cause? Active meiosis. Active. See, meiosis have happened. This is how meiosis happen. So I have shown you in the video the active mydriasis and active meiosis. Passive you can imagine by yourself. So that was the action on the iris. What about the ciliary muscle? What about the ciliary muscle? There are two type of muscles in the eye, now people. Iris muscle and ciliary muscle. Iris muscle I taught you. What about the ciliary muscle? Let me tell you what does normally ciliary muscle the God has given to us. Where is ciliary muscle? Here is ciliary muscle. No, I'm not interested in iris. I taught you the function of the iris is meiosis and mydriasis of all 4 chapters in one shot. Now I'm interested in the ciliary muscle. Why God has given these ciliary muscle? Let me zoom it out to explain you the normal function of the ciliary muscle. See, I have shown you the zoom version of this. Appreciate this zoom version. Where is ciliary muscle? Here is ciliary muscle. You can see this is ciliary muscle over here. Ciliary processes you can see. Ciliary body you can see. This is. So eye is having two chambers, anterior chamber and posterior chamber. So the chamber ahead of lens is anterior. The chamber behind the lens is posterior. Posterior chamber contain vitreous humor, which is given by the God once for all. It is jelly-like material and it is on birth only. It is not formed every day. Okay. But the anterior chamber ahead of the lens, there is a liquid which is known as aqueous humor. Aqueous humor formed daily and drained daily. So daily basis on a fixed rate it is formed and drained. The anterior chamber contains the aqueous humor. Now my question is who forms aqueous humor and who drain aqueous humor? Who form aqueous humor? Answer is ciliary body. Ciliary body forms aqueous humor. So aqueous humor is formed from the ciliary body. You can see the arrow is shown to you. Once it is formed from the ciliary body, it is released here. It is released here in the anterior chamber, the aqueous humor, I mean aqueous chamber like that. And it will take a U-turn from the iris, from the pupil, it will come here. It will come here. It takes and it will fill the entire cavity over there. Okay, the entire aqueous cavity over there. Say, so this is how you can see the arrow. Appreciate the ciliary body first. This is ciliary body. This is ciliary body. Appreciate the ciliary body is forming the aqueous humor, and the aqueous humor is coming from the posterior chamber, taking a U-turn and filling the aqueous cavity. The two cavities are, let me correct, I have said the cavity ahead of lens is the aqueous cavity. The cavity behind the lens is vitreous cavity. Vitreous cavity contain vitreous. Aqueous cavity is having two things: posterior chamber and anterior chamber. So aqueous humor is formed in the posterior chamber. Take a U-turn from the pupil and fill the anterior chamber, and this is what is formed. Now my next question: how the aqueous humor is drained? Formation we understood, but how it is draining? For draining, you can see here again. See, this is ciliary body. The process of the ciliary body from which the aqueous humor is coming, forming. It is coming from here. It will come from here. It will take a U-turn and it will go here. Here you can see an angle, the angle between the cornea and the iris. Okay, the angle between the cornea and the iris. In this angle, small pores are present. It is known as trabecular meshwork. It is like the sieve. Have you seen the chunni sieve? The small pores are present and it is drained here. Okay, in this angle, you can appreciate. I will show you in this video also. You can appreciate. So here I'm talking about this angle. I'm talking about this angle. See the zoom version. I'm talking about this angle, the angle between the cornea and the iris. In this angle, there are small pores. It is known as trabecular meshwork in which it is drained. So if the angle is wide open, it will be drained. But if the angle is narrow open, the pores are closed and it is unable to drain, it will accumulate and leading to the disease glaucoma that I teach in ophthalmology in third prof. I hope you got it. I will show you a video and then I will show you the action of the ciliary muscle. See, this is the eye. You all can appreciate the eye. You can appreciate the sphere. You can appreciate the ciliary body. You can appreciate the ciliary body. Let me zoom it out. The ciliary body. Appreciate the ciliary body. How the aqueous humor is synthesized. The aqueous humor is synthesizing on a fixed rate, daily basis. Every minute, every second it is synthesized. And via pupil, it is taking a U-turn and filling the entire anterior chamber. See, it is coming out of the pupil and filling the anterior chamber. Now it is going to that angle, the angle I'm talking. Appreciate these pores. These pores are looking like a sieve and it is known as trabecular meshwork. If the angle is wide open, it will go. But if the angle is closed, it will block. It will glob. So when ciliary muscle contract, the angle open. When the ciliary muscle relax, the angle close. Now you tell me, the drugs which is contracting the ciliary muscle, they will open the angle and drain the aqueous humor. So it is given as a treatment of glaucoma. Okay, and the drugs that will relax the ciliary muscle. So angle is closed. Okay, and the aqueous humor cannot drain and it will accumulate. They are contraindicated in glaucoma. This is how you can understand out of the 4 chapter which drugs are given in glaucoma and which drugs are contraindicated in glaucoma. I tried my best, people, conceptually. So here you can see currently talk about my first chapter, cholinergic drugs. Cholinergic drugs contract ciliary muscle. It contracts ciliary muscle. Since it contracts ciliary muscle, it opens the angle. Since it opened the angle, it drained the aqueous humor. Since it drained the aqueous humor, it decreased intraocular tension, and it is given as a drug for glaucoma. So cholinergic drugs are one of the treatment of glaucoma. I hope you are getting it. So the summary of the eye, cholinergic drugs. Okay, cholinergic drugs. Currently, what I'm teaching you, my first chapter is still going on. Cholinergic drugs. Cholinergic drugs on the eye. In the eye, what it do on the iris and what it do on the cilia. It contracts both. It contracts the sphincter pupillae of the iris and it contracts the ciliary muscle. Okay, cholinergic drugs contract both. Since it contracts the sphincter pupillae of the iris, it causes actinomyosis. And since it causes contraction of the cilia, it is opening the angle, draining the aqueous humor, decreasing the IOT. It is given in glaucoma. Give me a thumbs up, people. I tried my best. Say, got it? Say. So we are done with the smooth muscle. We are done with the eye. Now coming, still I'm teaching you the pharmacological action. Let's come on the glands. Let's come on the gland. How many glands you have in the body? Many glands. On all glands, God has given M3 receptors. M3 receptor on my salivary gland, on lacrimal gland, sweat glands, salivary gland, lacrimation gland, tracheobronchial gland, gastric gland. On all the glands, M3 receptors are present. So when natural acetylcholine come, bind with the M3 receptor on my gland, it increases the secretion of all glands. So more saliva, more salivation, more sweating, more lacrimation, more secretion of all gland. That is the summary. Coming to the next, blood vessel. What does acetylcholine, the natural acetylcholine, does on the blood vessel? It causes vasodilation. Learn one word. It causes vasodilation. So all the cholinergic drugs also do vasodilation. Okay, vasodilation. And last, male sex organ. I already taught you parasympathetic system does erection and sympathetic system does ejaculation. So, male sex organ on the penis, the God has given M3 receptors. And M3 receptors, when acetylcholine comes and bind with the M3 receptors present on the penis, it causes erection of the organ. So erection of the male sex organ occurs because of the here M3 receptors are present. When natural acetylcholine come, bind with these M3 receptors, it causes erection. It causes erection. So that is the muscarinic actions. Now nicotinic actions. Nicotinic actions, I'm talking about NM. NM is present at neuromuscular junction. So I'm talking about the somatic system, not autonomic. Currently, I was telling you the actions here at muscarinic. Now, nicotinic are somatic system. This is known as neuromuscular junction, NM junction, neuromuscular junction. So here NM receptors are present, NM. Here M1, M2, M3 are present. M1, M2, M3, the muscarinic. Okay, muscarinic receptors are present in parasympathetic system, but nicotinic receptors, NM receptors, are present in somatic system. I already taught you at the beginning what is somatic system. So when here also the neurotransmitter is acetylcholine, like here. So when acetylcholine is released here, it is binding with the NM receptors present on the skeletal muscle. It contracts the skeletal muscle. See here, see here. So here you can see when it is causing contraction. It is causing contraction of the skeletal muscle. So skeletal muscle contract. So I hope you got the pharmacological action. It is fitted in your mind. Okay, the summary of the pharmacological action is in front of you. People, please, if you have not understood, please learn this table. Please learn this. Now, the good things you take out as users and the bad things you take out as adverse effect. The chapter is done. Bad things is taken out. So out of which I will take 9 good things and 6 bad things. So I am having 9 users and 6 adverse effect. Okay, no mnemonic, conceptual learning. Got it? So learn this pharmacological action. I have explained you each and every action. See, where is M1, where is M2, where is M3, and what is its action? Where is NM? NN is not important. So these all 5 receptors you understood on which organ it is present and what is the action of cholinergic drugs on these 5 receptors. Say, now can I take the good things out of that? I will mark the good things with red. I will show you the uses with red, and I will mark the bad things with blue. I will mark the bad things with blue. So at the end, you will get a table in which 9 red markings and 6 blue markings. That will be my summary 1 page of cholinergic drugs. Let's start it. Let's start the 9 uses as I told you. These are the 9 uses. Don't learn, people. Understand. You will say by your own. So one by one we will say. Let's start the first. See my red markings. I will show you 9 red markings. 9 uses, so there will be 9 red marks. You understood this table? The first is GIT. What does the cholinergic drugs do on GIT? They cause this defecation. If you understand, they contract the muscle and relax the sphincter. They cause defecation. So name the diseases in which we can give it. We can give it in the diseases whenever the person want to defecate. I mean, post-op abdomen. Post-op defecation is difficult. Post-op person cannot defecate. Okay, gastric atony or gastric stasis or congenital megacolon. In all these diseases, person can't defecate naturally. So we want to help them with these cholinergic drugs. So it is used for defecation. I hope you are getting it. Defecation. So how these drugs are helping in defecation? On the muscles M3 receptor, they contract it, and on the sphincter M3 receptor, they relax it. So these drugs, they are humshical of acetylcholine. These drugs, they will go and bind here and bind here. They contract the muscle, they relax the sphincter and help in these conditions via defecating the patient. So learn the disorders. Okay, post-op abdomen, gastric stasis, and congenital megacolon. In these patients, if you want to defecate the patient, you can use these drugs. So that is the first use of these drugs. The second use is urinary bladder. What does these drugs do in the urinary bladder? So M3 receptors present on the muscle as well as sphincter. So whenever you give these drugs, I'm talking about cholinergic drugs, they are humshackle, they are identical of the acetylcholine, they bind M3 receptor here and here, they contract the muscle, relax the sphincter, and they help to urinate. So whenever you want your patient to get, your doctor, you want your patient to urinate, I mean your patient cannot urinate naturally, you can use these drugs. Whenever your patient is unable to urinate naturally, post-op retention, okay, postpartum retention, or neurological bladder. In these conditions, patient is unable to urinate naturally and you want to initiate the urination, you can use these drugs because these drugs contract the muscle and relax the sphincter and help the patient to urinate. So I hope you got the second disorder, the second use also urination. So you got the first disorder, the GIT disorders. You got the second disorder, second uses. Uses mean you have to write the name of diseases. So I am a doctor. Whenever any patient will come with GIT retention, I mean congenital megacolon, congenital megacolon, gastric atony, post-op abdomen, I will use these drugs. Whenever any patient will come with urinary retention, unable to urinate, like post-op retention, postpartum retention, or neurogenic bladder, I can give these drugs to urinate. Okay, third is eye. What does these drugs do in eye? Two things. It causes meiosis and it causes decreased IOT, decreased intraocular tension. So tell me the uses based on the eye. If any patient comes to me with glaucoma, can I use this drug? Yes, definitely, because they decrease IOT. So in glaucoma, I will give it because it is decreasing IOT. And since it causes meiosis, these drugs also causes meiosis. Whenever we need meiosis, there is a disease known as synecdoche. Synecdoche, you will read in ophthalmology. Synecdoche means fibrous tissue is formed between cornea and iris. Fibrous bands are formed between cornea and iris. Between cornea and iris, we want to break these bands. So we want to do alternate meiosis, meiosis, so that these bands will be break. So for causing meiosis and alternate meiosis, meiosis, for causing meiosis, we can use it. So we want to do alternate meiosis and meiosis. For alternate meiosis, for breaking these adhesion. For alternate meiosis, whenever there is a number of meiosis, we can use these drugs. So these drugs are used, for breaking these bands. I mean, synecdoche, and for reducing IOT. So glaucoma and synecdoche are the two diseases where we can use these drugs. The next is glands. What these drugs do on the glands? They increase the secretion. They increase. Suppose a patient to me with dry mouth, decrease saliva, very less saliva, no saliva, dry mouth. The disease is known as xerostomia. Person cannot eat. We eat with the help of saliva. So we want to give a drug so that increases salivation. We will use these drugs. These drugs increase the salivation. On the salivary glands, we are having M3 receptor. Okay, so xerostomia based on the gland. You can see my red marking. It will be total 9. Okay, I'm coming on the fifth one. The fifth one is on CNS. CNS. Okay. CNS में M1 receptors are present. M1 receptors are present. And in CNS, acetylcholine helps in memory and learning. Acetylcholine helps us in memory and learning. So we will give them in Alzheimer's disease. Alzheimer's disease is a neurodegenerative disorder in which memory, dementia is in, memory lost. So these drugs help in memory retention in Alzheimer's disease. So that is the use. Now the next use. So till now I taught you 5 uses based on muscarinic effects. So GIT retention, for example, congenital megacolon, gastric stresses, post-op retention, urinary disorders, again post-op retention, postpartum retention, neurogenic bladder. I will give in synecdoche and I will give in glaucoma. Okay, glands I will give in xerostomia. Okay, CNS I will give in Alzheimer. Okay, so these are my 5 uses till now, 4 more to go. So the remaining 4 will be in nicotinic receptors. So let's come on neuromuscular junction. Let's come on neuromuscular junction. Okay, NM receptors are present on neuromuscular junction. There is no, it's complicated. People, please focus. Here I will tell you 3 uses based on this. 1, 2, 3. The remaining 3 will be from here. Okay, the remaining 3 will be from here. Please understand, I'm talking about neuromuscular junction, the somatic system. I'm talking about this. Can you see? Can you see? This is my skeletal muscle. Let's say this is my bicep. This one. This one is my bicep, tricep, deltoid. You can see bicep, tricep, deltoid. This one. Okay. And this is the nerve. I'm having the nerve supply of this muscle. So I can contract, I can relax. It's my choice. I can contract, see. I can relax, see. Because this is happening inside me. Whenever I am contracting acetylcholine, the signal, I think I should contract. So signal is coming from the brain. And acetylcholine releasing. And here I am having NM receptors. Please understand, people. NM receptor. The acetylcholine come in the space, bind with the NM receptor and contracting it. See, I'm just thinking and I can contract. It is happening very fast. Yes or no? And whenever I want to relax, I can relax. Yes or no? So because thankfully the God has given multiple NM receptors on this muscle. Suppose let's say just for understanding there are 100 receptors, 100 NM receptors on this muscle. So I can contract it well, relax it well whenever I wish. Now there is a disease which is known as myasthenia gravis. What is myasthenia gravis? I taught you this in pathology. What is myasthenia gravis? Myasthenia gravis is an autoimmune disorder in which my own body form antibodies against my own NM receptors. Against my own NM receptors. So instead of 100 receptors, I'm having only 50 receptors now because the remaining 50 is destroyed my own antibody. So my own antibody is coming and destroying the receptors present on this bicep, tricep, any skeletal muscle. So my acetylcholine is bharpoor and acetylcholine is sufficient. It is enough. It is not less. But the receptor with which it will bind is less. It becomes less. So whenever you will ask me, ma'am, contract your muscle, I will do like this. I am unable. I'm very tired. I can't do it. I will feel like that. And that's the disease, myasthenia gravis, in which the person feel very tired. Especially after doing some activity in the evening hours. In the morning, the person is energetic, but whenever person does any activity, all the receptors are saturated. Understand the disease. So how these drugs can help here? In these, there are two types of cholinergic drugs I taught you. One is cholinergic agonist. Forget that. What is the second category? The second category I taught you is anticholinesterase. What does these anticholinesterase do? Anticholinesterase drugs, they inhibit the enzyme which destroy acetylcholine, natural acetylcholine. So I will give anticholinesterase in this case. In myasthenia gravis, which drug I will give as a treatment? Cholinergic drug only. I'm teaching you cholinergic drug, my first chapter. I will give anticholinesterase wala cholinergic drug. What does this drug will do? The patient is taking the tablet as a treatment. The patient is coming to me and I'm taking it's okay. You are having myasthenia gravis. We have done the diagnosis. Now you start taking anticholinesterase drug. So patient is taking anticholinesterase drug. It will go in the blood. It will reach here at this junction. It will inhibit this enzyme. Once this enzyme is inhibited, this enzyme used to destroy acetylcholine. So natural acetylcholine is not destroyed. It remains at this space, at this receptor for a longer period. So I cannot increase the receptor again from 50 to 100. Receptor are 50 only. I cannot increase it. But to these 50 receptors, the acetylcholine will bind for a longer duration and the muscle can be contracted like normal. So this is how we are treating the person. I hope you're getting the principle behind it. So this is the disease myasthenia gravis. First, you understand what is disease. I told you autoimmune disorder in which body is making antibodies against NM receptor. So NM receptor become 1/3. So instead of 100 is not 50, it is over 33. Very less receptors. Okay. So here what drug we are giving? We are giving anticholinesterase drug like neostigmine, pyridostigmine are the drug of choice here. These drugs will go and they will accumulate the natural acetylcholine over there. So receptors are same, okay, but they will remain at the receptor for a longer duration and contract the muscle. So person will feel better. You say, ma'am, okay, you solved the problem. Very, very good. No, there is a catch. There is a climax in the story. If we constantly give the acetylcholine here, we have destroyed the enzyme. Okay, this enzyme is destroyed, and acetylcholine is there on the receptor for a longer, more longer duration. So after some time, you know what happens? After some time, there is persistent depolarization of the muscle. Constantly the muscle is contracting. After that, it will give up. It will give up. So constant depolarization of the muscle because acetylcholine will be there for a longer duration. After that, again, patients say, doctor, I'm taking the treatment, but again, I cannot contract now. So there are two type of crises. The patient can come with any of the crises to you. Myasthenic crisis, it is due to the disease, and cholinergic crisis is due to overtreatment. You're getting my point. Myasthenic crisis means the muscle is unable to contract. In both of them, the patient says, doctor, I'm having weakness in the muscle. My muscle cannot contract. My skeletal muscle cannot contract. Now, why cannot contract? Either the person is myasthenic crisis or cholinergic crisis. Myasthenic crisis means, the receptors are less and that's why muscles cannot contract. So you cannot increase the receptor, obviously. You are not God. You cannot increase, but you will increase the concentration of acetylcholine for a longer duration so that the acetylcholine, natural acetylcholine bind with the same receptor, less receptor for longer duration. So your contract polarization, persistent depolarization. Now the person will go in weakness. So you reduce the treatment. Okay, so here, so that is known as cholinergic crisis. So patient is coming in myasthenic crisis, give anticholinesterase as treatment. If patient is coming with cholinergic crisis, stop anticholinergic or reduce its dose. So treatment is opposite. In both of them, the complaint of the patient is same. Doctor, I'm having treatment. So first time when the patient is coming, doctor, I'm having treatment, you start the treatment, person feel better. But after some days, even on treatment, patient again have weakness, and that's the cholinergic crisis. You reduce the dose or stop it for some days, then again patient feel better. I hope you are getting it. I don't know whether you are getting it or not. Okay, so myasthenic crisis is due to the disease itself. Here the treatment is anticholinesterase, and cholinergic crisis is due to overtreatment of anticholinesterase, that is persistent and depolarization of the muscle. Okay, here you withdraw the anticholinesterase. Say, ma'am, how will I come to know? There is a patient. Suppose I'm your patient. I'm saying, doctor, I'm having weakness. I'm already on your treatment. Okay, I'm a myasthenia gravis patient and I'm having the weakness again. I'm already taking the treatment very regularly, whatever you have prescribed. So you don't know in which crisis I'm having. My further receptors are reduced further. That's why this weakness is there. Or you have given over treatment, and that's why because of persistent depolarization, this weakness is there. You want to know am I in myasthenic crisis or am I in cholinergic crisis? Because if I'm in myasthenic crisis, you increase the dose. If I'm in cholinergic crisis, you reduce the dose or stop the treatment. So treatment are opposite. So that's why we do a test. Okay, person can feel experience of any of these crises alternatively. So you do a test, and the name of that test is adrophonium test. You know what is adrophonium? Like neostigmin, like pyridostigmin, adrophonium is the shortest acting anticholinesterase drug. Okay, so in your clinic, okay, in your clinic only. So these patients usually have ptosis also. These patients have ptosis, fall of the upper eyelid. They have ptosis also. So you give injection of adrophonium. Okay, if the muscle improve, it is myasthenia crisis. If it is even worsen after adrophonium, if it is worsen, it's cholinergic crisis. Okay, I hope you are understanding. And if it is improving, patient will be happy. But if it is worsening, patient will shout, your doctor, it's even worsen. What you have done, which injection you have given, you say it's okay, it is short acting. In few hours, it will be back to baseline. So this is how we conduct this test. It is known as adrophonium test. Adrophonium is the shortest acting anticholinesterase. That's why we use it. We give the injection of the patient. In the next few minutes, we will see there is improvement or there is worsening of the symptom. So I hope you got it. If there is improvement, the patient see improvement, it's myasthenic crisis, increase the dose. If it is worsening, it's cholinergic crisis, stop the treatment or reduce the dose. I hope you got it. Okay, so that was the first use based on neuromuscular junction. Now the second use is the post-op decoderization. What is post-op decoderization? During surgery, we give neuromuscular blocker along with the anesthesia. I will teach you neuromuscular blockers also in skeletal muscle. Okay, so what is neuromuscular blocker? During surgery, the surgeon wants the patient to get 100% relaxed. The skeletal muscle person should not move during the surgery. Otherwise, the cuts can be wrong. So we want the complete 100% relaxation, and we give neuromuscular blocker. The name of the neuromuscular blocker most commonly used is D-tubercurenin. I will teach you. We will give tubercular. It is known as Curer. So we give Curer to relax it. It is a neuromuscular blocker. Say yes, ma'am. So uska yahan kya lena dena? The surgery is over. The patient is back to ward. The patient is out of the OT. The patient is back to ward, but still patient is paralyzed. The complete body is paralyzed. It is not back. So we want to revitalize it. Okay, so we want post-op decurerization. So during Curer, what we have done? We have blocked these neuromuscular junction. We have blocked these neuromuscular. Now we want to again do the decurerization. So we will give this drug. So how this drug will have? This drug will inhibit the enzyme cholinesterase. So acetylcholine will be there for a longer duration and it will accumulate. Since the acetylcholine will accumulate, it will replace the drug from the receptor and person will be back. Back can contract the muscle, and it is known as post-op decurerization. I hope you got it. Okay. The next is the third and the last use based on that is cobra bite. Cobra. Cobra is a snake. It's a very dangerous snake. I teach you in forensic medicine. So this cobra venom, the venom of this, when the cobra bite, inject the venom. So this is the cobra, it is biting, injecting the venom. The venom of the cobra is nothing, it's Curer only, which we give during the surgery to relax the muscle. So immediately after cobra bite, person go in paralysis. Like during surgery, we intentionally paralyze the person for some time so that we can do the surgery better. So cobra bite contain the Curer. The venom of the cobra contain the Curer, and immediately after the bite, the person go in paralysis. So we will give this again to decurerization. So this and this is actually same. Decurerization, here also we are doing the decurerization because the cobra venom is Curer only. Okay, so person is paralyzed after the cobra bite, you can see. Okay, so these are the three uses here I told you. One is myasthenia gravis, one is Curer, and other is also Curer. I mean post-op decurerization and cobra bite decurerization. So these are the three uses. So how many? 8. You can see 1, 2, 3, 4, 5, 6, 7, 8. 3 based on that. The ninth one is the Datura poisoning. Datura is my next chapter. Anticholinergic drug, Datura or Belladonna. So since in anticholinergic axis, you will give cholinergic. Currently, I'm teaching you cholinergic drugs. So in anticholinergic drug axis, you will give cholinergic drugs. So that is Datura poisoning. So these are the 9 uses. I don't think you have to learn if you know these 9 red marks. You can count these are 9. You can see it's 1, 2, 3, 4, 5, 6, 7, 8, and 9th is antidote. Antidote in the anticholinergic, that is Datura poisoning. So these are the 9 uses. You don't have to learn. If you need some mnemonic, I can give you mnemonic, but conceptual learning is better. You get short question, very short question. They are asking why we use this drug for the treatment. So you should be able to answer that why if you understand the concept. So these drugs cause defecation. So we give them into post-op abdomen. We give them in post-op abdomen congenital megacolon. Okay, whenever we want the person to defecate, these drugs cause urination. So we give them in post-op urinary retention, postpartum urinary retention, neurogenic bladder. These drugs cause increased salivation. That's why we are giving them in xerostomia. These drug causes meiosis. That's why we are giving them in synecdoche. And they decreases IOT. That's why we are giving them in glaucoma. These drugs sharpen memory. That's why we give them in Alzheimer. These drugs accumulate acetylcholine at neuromuscular junction. That's why we give them as myasthenia gravis, but it's not a cure of myasthenia gravis. Okay, these drugs we give in post-op decolorization and cobra decolorization. So for decolorization, you understood for how it is helping. And these drugs are given in dhatura or belladonna poisoning because dhatura and belladonna is anticholinergic excess in the body. So to antidote that, we will give cholinergic drugs. So these are the 9 uses. You want to learn, it's your choice. You want to understand, it's your choice. You want to go with my 9 red markings, it's your choice. So we are done with the 9 uses. Let's come on the 6 adverse effects and pack the chapter. So coming on the 6 adverse effects, they are in front of you. See my 6 blue markings. You can understand what these drugs are doing in the GIT and in the bladder. You tell me in the GIT as well as in bladder. In both of them, what these drugs are doing. Here, these drugs are contracting the muscle and relaxing the sphincter. Here also contracting the muscle and relaxing the sphincter. So muscle contract, sphincter relax. Here also muscle contract, sphincter relax. Suppose a patient is coming to me, person cannot defecate or person cannot urinate. Okay. Here also retention, here also retention. Person is coming to me. So you will say ki Dr. Priyanka have taught me, madam have taught me ki whenever a patient will come with retention in the GIT or retention in the bladder, we can give cholinergic drugs. Yes, definitely you are right. But please understand, we can give cholinergic drugs before that rule out obstruction. Suppose the person is in retention because of multiple causes. But suppose it is an obstruction over here. The obstruction is because of anything. Maybe because it is having tumor, it is having some whatever, spasm, or there is an obstruction over here. If the retention is due to obstruction, okay, and you are giving this drug, so this drug will cause vigorous contraction. Vigorous contraction. Imagine the GIT, there is an obstruction ahead, and you have done the vigorous contraction by giving a drug to relieve the obstruction. It will perfo. It will perfo. So you have to give in retention, but before that, rule out obstruction. If it is not obstruction and then retention, then you can give this drug. So never give an obstructive GIT retention or obstructive urinary retention. I hope you are getting it. So never give it an obstructive GIT retention and obstructive urinary retention. So you give in retention. Again, take my words. You give them in retention. GIT retention like post-op abdomen, congenital megacolon, gastric atony, urinary retention like post-op retention, postpartum retention, neurogenic bladder. You give, but there should be no obstruction. In obstruction, it is contraindicated. If you give them an obstruction, niche obstruction hai. Here there is obstruction and you are contracting the muscle. Perfo will happen. First, relieve the obstruction so that, if contraction, it will relieve it. Defecation and urination will take place. Never give them an asthma because it causes bronchoconstriction. It will exaggerate the asthma. Suppose it is a patient who is having asthma and I'm giving cholinergic drugs. Oh my God, that will be a blunder. The person can go in the attack. Okay, because these drugs causes bronchoconstriction and person is already having the asthma. So that can be exaggerated. So never give them an asthma. Never give it to a person who is having coronary insufficiency because these drugs causes vasodilatation. Okay, further you are reducing the BP and you are causing vasodilatation by giving these drugs. The coronary insufficiency get exaggerated and person can get an attack of MI. Never give these drugs if the patient is having bradycardia because these drugs reduces the heart rate. The person already have bradycardia and on the cherry on the top you are giving cholinergic drugs. They further reduce the heart rate and bradycardia will be exaggerated, person can die. So never give them in the bradycardia. Never give it to a person who is having peptic ulcer because these drugs increases gastric secretion. Person already have a peptic ulcer. You are giving cholinergic drug. Further acid secretion and peptic ulcer will be exaggerated. The perfo can happen. So never give this drug to these patients. The patient having GIT retention due to obstruction, urinary retention due to obstruction, okay, asthma, coronary insufficiency, bradycardia, and peptic ulcer. If you try to learn, you will forget. If you try to understand with my blue marks, you can give a reason for all of them. I have given each and every reason. You can count the number of markings. They are 6. You can count if you wish. So you can see I taught you these 6. So I taught you 9 uses and 6 adverse effects. These are my 9 red marks. These are my 6 blue marks. So you can see 9 uses, 6 adverse effects, cholinergic chapter, cholinergic drugs chapter, done and dusted. Done and dusted. Appreciate my 9 red and 6 blue. This is what you have to revise before going to your exam with a clear reason for why for each of them. You should know the reason for why. I have explained you each and every and it is written in my notes. Okay, now the next thing I would like to teach you over here is anticholinesterase poisoning. Anticholinesterase is one of the cholinergic drugs. There are 2 types of cholinergic drugs. Sometimes anticholinesterase, there are 2 types of anticholinesterase, carbamates and organophosphates. Organophosphates usually used as a suicide agent. Person use to because organophosphates are present in agricultural pesticides, so the people can use it for doing suicide. Suppose a person, a farmer or anyone who try to do suicide, okay, by taking organophosphates, and the relatives took that person to you. The person is unconscious on the stretcher and relatives want you, the parents wants you, the relatives want you to save this person. So it is anticholinesterase poisoning. Okay, just a second. Am I live? I guess. This is known as anticholinesterase poisoning. Okay, so what will be the, imagine a patient on the stretcher, okay, who is having bradycardia. You can imagine everything here. Who is having bradycardia? You know why. Who is having hypotension? You know why. Here is hypotension. Okay, who is having bronchoconstriction? Person can't take the breathe. You know why. Here is bronchoconstriction. Okay, I can explain everything. Who's having increased secretions of the bronchi? You can explain it here. Who's having increased lacrimation from the eye? You can explain it here. Okay, who's having sweating? You can explain it here. Sweating. Okay, who is having meiosis? If you check the eyes with the torch, it is meiosis. And who is having urinary retention? You can see urinary. You can explain each and every. Now imagine this person is on the stretcher and person is in paralysis, complete paralysis. Person can't move. Imagine, and relatives brought it. Doctor, this person tried to commit suicide by eating something and they are showing the pesticide. Okay, you understood. It's a clear case of organophosphorus poisoning. I mean, it's a clear case of anticholinesterase poisoning. Person tried to commit suicide, and obviously, being a doctor, you want to save it. So how you will save it? How you are going to save it? What is the treatment? What is the treatment? So supportive treatment, specific treatment. Supportive treatment, you know ABC. You know the supportive treatment. Okay, terminate the exposure, maintain A, airway, B, breathing. If the person have convulsions, give diazepam, treat the shock. So ABC, supportive treatment. But specific treatment, I'm interested. The specific treatment is atropine. Atropine, my next chapter. Okay, Datura. So I told you, na, in cholinergic poisoning, we give anticholinergic. In anticholinergic poisoning, we give cholinergic. They are antidote of each other. Okay, so if the person have taken too much of cholinergic drug, give anticholinergic drug. My next chapter, atropine. Give atropine as a specific treatment. Okay, so atropine over poisoning, give anticholinergic. Anticholinergic over poisoning, cholinergic over poisoning, give atropine like that. So atropine we will give. Number one, you can understand why we are giving. And if it is an emergency, of course it's an emergency. So you have to learn the dose. If you want to learn emergency doses, it should be at the tip of your tongue. Other doses are not required here. So atropine, you have to give up to 200. You have to start directly giving injection. And then you can give oxyms. What are oxyms? These are cholinesterase reactivators. What drug the patient have excessively taken? Patient have taken anticholinesterase. Anticholinesterase have inhibited that enzyme. You want to reactivate that enzyme which is present at the junction. So the drugs are known as this enzyme I'm talking about. So person have taken excessive drug, anticholinesterase that have inhibited this enzyme. You want to save this person, so you want to reactivate this enzyme. So cholinesterase reactivators are available. The reactivators are known as oxyms. The reactivators are known as oxyms. Three types of oxyms are available: pralidoxym, obdeoxym, and DAM, diacetyl monoxide. So three types of oxyms are available. We are done with the first chapter. Everyone give me a thumbs up. You want me to continue? Say, got it. So can we continue? Let's come on the next chapter, anticholinergic drugs. We are done with cholinergic drugs. Let's come on anticholinergic drugs. Quickly, anticholinergic drugs. Cholinergic drugs are done. Anticholinergic drugs is very easy now. It will be very fast. You have to do just opposite. So again, the same headings tell me the definition of anticholinergic drugs. What does anticholinergic drugs do? Please see here. See here, see here. Here we are having muscarinic receptor. Okay, say yes. And here we are having nicotinic receptor. I guess everyone knows this till now. Anticholinergic drugs are misnomer. They should be anti-muscarinic drug. So they block the muscarinic receptor. They don't block nicotinic receptor. Take my words. So basically, anticholinergic drugs are anti-muscarinic drugs. They just block only muscarinic receptor. They don't block nicotinic receptor. The one which block nicotinic receptor are neuromuscular blocker that I will teach you in PNS. I hope you are getting it. Okay, so here I'm saying here we are having muscarinic receptor. The drugs which block these receptors so that natural acetylcholine cannot bind with it. Okay, so natural acetylcholine is supposed to do this. Okay, now suppose there is no drug. So what is the natural some organ I'm having entry? You can see the list. When acetylcholine come and bind with all these organs, this all happen. It's written in front of you. Suppose it is heart, so reduce heart rate. Suppose it is this, so whatever is the effect. So this is happening. Now imagine I'm giving a drug which is blocking this M receptor, which is blocking the M receptor. So the natural acetylcholine cannot bind with the M receptor, whether it's M1 or M2 or M3. Natural acetylcholine cannot bind with this. So opposite of this will happen. Opposite. So when you give anticholinergic drugs, the heart rate will increase. When you will give anticholinergic drugs, instead of meiosis, the mydriasis will happen. Okay, instead of reduce IT, increase IOT will happen. Increase secretion, instead of that, reduce secretion will happen. Everything will opposite. So make a table opposite of that. That's the action of anticholinergic drugs. That's it. So I taught you the complete chapter in one line. Now we will quickly flip it. Everyone got the meaning of that? So what I'm saying, what these drugs will do, I'm teaching you the next chapter, anticholinergic drugs. Anticholinergic drugs, learn its other name, it's anti-muscarinic drug. They block muscarinic receptor. Imagine this receptor is blocked. Now what will happen? The natural acetylcholine is there. It's there in the junction, but it cannot bind with its receptor. Since it cannot bind with its receptor, it cannot stimulate the receptor and whatever organ it is. So that effect will not happen. Opposite of that will happen. Suppose this organ is heart. So if acetylcholine was binding here, it was reducing the heart rate. But now acetylcholine is not binding. So heart rate will not reduce, rather heart rate will increase. Passively it will increase. Okay, so this is how opposite will happen. Say yes, people, at least respond. Okay, got it? Yes. So this is how opposite will happen. I hope you got it. So anticholinergic drugs do the reverse of that. I cannot reverse the table because that is not actually happening. That is passively happening. I mean, please understand my words. Anticholinergic drugs do not increase heart rate. They inhibit acetylcholine to reduce the heart rate. So passively heart rate will increase. Anticholinergic drugs do not cause contraction of iris and meiosis. They inhibit the acetylcholine to do that. That's why passive mydriasis will happen. So everything is happening passively, not actively. So opposite of this table, you have to consider in your mind for anticholinergic drugs. Give me a thumbs up if you got my concept. So if you got the definition, can I proceed? So definition may write down these are the drugs which block M receptor, all three M receptor, M1, M2, M3. So whatever acetylcholine is supposed to do on M, opposite of that will happen, but passively, not actively, because acetylcholine is prevented to do that. So opposite of that will happen. Now coming on classification of anticholinergic drugs. Can you tell me the classification? The classification is based on their chemical structure, whether they are natural or semi-synthetic or synthetic. There are three types of anticholinergic drugs. You can see the natural one, the semi-synthetic one, the synthetic one. Now classifications you have to learn by yourself. I can show you, but you have to learn. Natural में only one drug, hyoscine. Semi-synthetic में atropine. Atropine, homatropine. Okay, hyoscine, butyl bromide, ipratropium, tiotropium. So atropine, homatropine, hyoscine, butyl bromide, ipratropium, tiotropium. So these are semi-synthetic. And synthetic may we divide them again based on their function. Some of them are anti-secretory, some of them causes mydriasis, some of them, they act only on the bladder. They are known as vesicoselective. Vesicoselective means they act on the bladder. And some of them are anti-Parkinsonism. So you can read the prototype drugs over here. Please read the classification by yourself. Rather, my advice, take a print and stick it on your wall. Please print of this is separately available in the course. You take the print, stick it on your wall, all important classification at one page. Okay, here from these all drugs, the prototype drug is atropine. Here, the prototype drug is atropine. So I'm telling you atropine, which is the prototype drug over here. Atropine is derived from a plant. The name of the plant is Dhatura. The scientific name of Dhatura is Atropa belladonna. So belladonna and Dhatura is one and the same thing. So whether they are saying Dhatura, whether they are saying belladonna, whether they are saying atropine, the meaning is same. So atropine is derived from this. It is the chemical which is derived, it's a drug which is derived from the plant, the Dhatura in Hindi. The scientific name is Atropa belladonna. And it's a prototype drug of this category. So you know the definition, say yes, these are the drugs which block muscarinic receptor. You know the classification, say yes. In classification, you have to write down there are three types, natural, semi-synthetic, and synthetic. Natural means hyoscine, semi-synthetic means atropine, homatropine, hyoscine, butyl bromide, ipratropium, tiotropium, and synthetic may you divide according to their function. Okay, now coming on mechanism of action, you already know that. What does they do? They block M1, M2, M3. They are antagonist of M. They block M1 as well as M2, as well as M3. So M1, M2, M3 is blocked. So the natural acetylcholine is unable to bind with its receptor. It prevents the natural acetylcholine to bind with its receptor. So whatever acetylcholine is supposed to do, it will not do that. Opposite of that will happen. So that is known as inhibition of muscarinic effect of acetylcholine. I hope you got it. So you can draw this diagram, you can draw this diagram, whatever. Okay, so you know the definition, you know the classification, you know the mechanism of action. Now, pharmacological action. I will just reverse this table. Quickly, I will flip it. I will reverse the table. Some points are new that you should consider. Let's start with M1. In the M1, what does natural acetylcholine do? We will do opposite of that. Okay, what does natural acetylcholine do? We will do opposite of that. Natural acetylcholine stimulate vestibular center in the brain. Okay, so it inhibit the vestibular center. Natural acetylcholine stimulate the basal ganglion. It inhibit the basal ganglion. Now learn these two things. Natural acetylcholine stimulate vestibular. Now what is vestibular center? Vestibular center we are having in the ear. You know, in the ear we have three portions: external ear, middle ear, inner ear. I teach you in ENT. External, middle, inner. In the inner ear we are having why inner ear is there? Inner ear have two functions: hearing and balancing. You know, balancing is done via three semicircular canals. This is known as vestibular system. 1, 2, 3. The God has given three semicircular canals at perpendicular planes to each other so that we can balance. Suppose there is some road is like this and I'm just losing my balance, but I will hold anything and control myself because my vestibular system is functional. Yes or no? So vestibular system, on these three semicircular canals, M1 receptors are there. So when acetylcholine come and bind with the M1 receptor, Okay, and whenever there is an imbalance at that time, you can see these three semicircular canals. Inside these three semicircular canal, there is a liquid. The name of that liquid is endolymph. The God has given that liquid. Okay, so endolymph is moving. Suppose my head is moving like this, so endolymph is going here. Head is moving like this, so endolymph is. So I can move like this. Suppose I'm a roller coaster ride. Suppose I don't like such, experiments, but suppose I'm challenging my vestibular system, and I'm on a roller coaster is just a challenge to your vestibular system. So if I'm challenging my vestibular system and I'm on roller coaster rise, imbalance, imbalance like anything. If I'm imbalancing it, some people vomit. I'm among one of them. Some people vomit whenever the imbalance occurs. It is because of the M1 receptors present over here. So on these three semicircular canals, M1 receptor is present. So whenever imbalance occur, like in roller coaster, right, like in road trips, on a road trip, the road is like this, and you are traveling with car. Okay, not the flight. You are going with the car. Okay, you are going with the car. Okay, it is known as motion sickness. You have heard this word, motion sickness. In motion sickness, the person have vomit whenever the road imbalance is there. Okay, on a road trip, whenever they are moving with a vehicle, car, so they have motion sickness. Okay, so that is M1, because of the M1, so this will block the M1. These drugs will block the M1. So it is a treatment of motion sickness. It is anti-motion sickness. Now you are doctors, some your neighbors and patients will come to you. Doctor, I'm having motion sickness and I have to travel by a road trip. It is a compulsory for me. Give me some drug preventive so that whenever I travel with a bus or car, usually I have vomit, but I do not want to have it. Can you give me some prophylactic drug? It's very common query asked to the doctors. You have to give these drugs. Okay, you can give hyoscine. You can give it tropin. Hyoscine is the best drug over here. It's anti-motion property. I hope you got the reason for that. Yes or no? So in motion sickness, we can give motion sickness, and you got the reason. And second, on the basal ganglion in our brain, we have basal ganglion. In the basal ganglion, we have M1 receptor. Normally, acetylcholine stimulate those basal ganglion acetylcholine receptor, and the person can have Parkinsonism. So blocking it will be anti-Parkinsonism. Okay, so it is given as a treatment of anti-Parkinsonism. So based on the M1, we are having two uses over here: anti-motion sickness and Parkinsonism, because it is blocking vestibular system M1 receptors, that is semicircular canal M1 receptors, and it is blocking the basal ganglion M1 receptors. Okay, it is blocking vestibular M1 receptors and basal ganglion M1 receptors. That's why these drugs, anticholinergic drugs, are used as motion sickness, and they are used in Parkinsonism. I hope you got it. M2 may you use your common sense. What does acetylcholine do? Acetylcholine reduce heart rate, reduce contractility, reduce. So this one increase heart rate, increase contractility, increase velocity, because it inhibits acetylcholine to bind with its receptor on the heart. So anticholinergic drugs inhibit M2. This organ is heart. So it is inhibiting M2 on the heart. So natural acetylcholine cannot bind with the M2. So instead of reducing, it will be increase. So these drugs leads to tachycardia. They increase heart rate, they increase velocity, they increase contractility. Okay, so they increase. You can say cholinergic drugs are negative chronotropic, negative inotropic, negative dronotropic. But anticholinergic drugs are positive chronotropic, positive inotropic, positive dronotropic. I hope you are getting it. So coming on M3 now. M1 I taught you, M2 I taught you. Let's move on the M3. Anticholinergic drugs M3. Everything will be opposite, people. All things will be opposite. You tell me what happened in GIT. In GIT, cholinergic was causing defecation. This one will lead to retention. They lead to retention. Okay, opposite of that. Cholinergic were causing urination, they cause retention. Lung में cholinergic were causing bronchoconstriction, they cause bronchodilation. So they were contraindicated in asthma, they are given in asthma. They are drug of choice of asthma. I hope you are getting it, everything. Yes, so you can see, again, this is rectum and this is sphincter. This is urinary bladder, this is sphincter, and this is lung ka bronchiole. So here the God has given M3 receptor, M3 receptor, M3 receptor, M3 receptor. Here don't no sphincter, only muscle. M3 receptor. Normally this is acetylcholine. When acetylcholine come bind here. So muscle contract, sphincter relax. Muscle contract, sphincter relax. Muscle contract. Lung mein we don't have sphincter. Okay, but now the receptor for this is blocked. These receptors are blocked. So natural acetylcholine cannot bind. This natural acetylcholine cannot bind with M3 receptor. So opposite will happen. So muscle will relax and sphincter will contract instead of that. Okay, muscle will relax. Say, muscle will relax and sphincter will contract. Muscle will relax, sphincter will contract. Muscle will relax. Now imagine a bladder. Imagine a bladder in which muscle is relaxed, sphincter is contract. So this is known as retention. Imagine GIT. Muscle will relax and sphincter contract. This is known as retention. And here, muscle relax, it is known as bronchodilation. So it is drug of choice in asthma, and it causes retention. I hope you got it. Give me a thumbs up. Got it? So you got it. Now I've already explained you. I will not explain you again. So cholinergic drugs. Cholinergic drugs causes meiosis, active meiosis. These cause passive mydriasis. Cholinergic drugs decrease IOT. That's why they were useful in glaucoma. They increase IOT. That's why they are contraindicated in glaucoma. I have already explained you how they are causing passive mydriasis. I've already explained you. I hope you got it. Okay. Now coming on the glands. Cholinergic drugs increase the secretion from all glands. They reduce the secretion. Anticholinergic drugs reduce secretion from all glands. So skin become dry and hot because of less sweat. Eye become dry because of less lacrimation. And mouth become dry because of less saliva. I hope you got it. This is anticholinergic drug. Now the next is blood vessel. Cholinergic drugs reduces BP. They cause vasodilatation. They cause vasoconstriction. They prevent the vasodilatory action. And they have an additional action of local anesthesia. The anticholinergic drugs. So you got the actions. Now from the actions, I taught you all the actions. You just do reverse of this table. You know the table. You have to reverse. Now the good things you take as uses and the bad things you take as adverse effect. This is how you have to learn. So there are 9 uses and 7 adverse effects. Here also we were having 9 uses. Here we were having 6 adverse effects. Here we are having 9 adverse effects. 7 adverse effects. I'm sorry. So let's start with the uses, the 9 uses. You can understand. You can understand. One by one, I will show you all the uses with the red color over here and all the adverse effect with the blue color. So uses will be shown to you 9 red. Adverse effect will be shown to you with 7 blue. Let's start with the first use. You can see the first use over here. Just a second. It is GIT. What they do on the GIT? They cause retention. So when you want to give, when you want to, they relax the muscle and contract the sphincter. They relax. When you want to relax the muscle, name the diseases. Whenever we have cramps in the abdomen, we want to relax the muscle. Whenever it's intestinal colic, intestinal cramps, irritable bowel disease, gastritis, we want to relax. We want to relax the muscle and contract the sphincter. So we give these drugs. Okay. So in all these diseases, we want to relax the GIT muscle. We want to relax the muscle. In cramps, obviously the cramps are due to contraction of the muscle. So we want to relax them. In intestinal colic, intestine is contracting. We want to relax it. Irritable bowel disease, gastritis, gastric hypermobility, pylorospasm, we want to relax the muscle. So relax the muscle. So we give these drugs. I hope you are getting it. When you will give for the lung, in asthma, they are the drug of choice for asthmas and COPDs. For asthma and COPD will because they cause bronchodilation. Okay, acetylcholine was causing bronchoconstriction. They prevent acetylcholine from causing bronchoconstriction, so they passively do bronchodilation. And that's why they are given in COPDs and asthma. Okay, the next is urinary bladder. Again, they cause retention. So when you want to give whenever there is increased frequency, whenever there is increased urgency, and whenever there is enuresis. Enuresis means bed wetting. Bad wetting. Some people in night during sleep, they pass the urine unknowingly, involuntarily. So bad wetting, it is known as enuresis. So you want to do the retention. Whenever there is increased frequency, increased urgency, or enuresis, or there is urinary colic. You want to do the retention. Okay, in that cases, it will be useful. The next is uterus. What does it do in the uterus? What does acetylcholine do in the uterus? Acetylcholine contract uterus. So this relaxes uterus. It prevents the acetylcholine from contracting. So passively it is relaxing the uterus. When we want to relax the uterus in threatened abortion, we want to relax the uterus in threatened abortion and in dysmenorrhea. Dysmenorrhea. Why does dysmenorrhea occur? During menstruation, severe pain in the pelvic region occur because of uterus contraction. During menstruation, it's physiological contraction of this. Some females have severe pain. We want to relax the uterus so that the pain decreases. So in that case, we can give these drugs. So in dysmenorrhea, we can give it. The next is eye. In the eye, what does it cause? Mydriasis. When we cause to do the mydriasis for refraction testing, you go to ophthalmologist. So ophthalmologist, before checking, they put some drops in their eye so that they can do the retinoscopy very well. For doing mydriasis, so before refraction testing, these drugs are given. Okay, for mydriasis, and they causes cycloplegia also by relaxing the ciliary muscle. So for producing cycloplegia and all the iritis, inflammations of the eye, we can use this drug. I hope you are getting it. They decrease secretion. So we give them in a disease like siluria. What is siluria? Excessive salivation. Excessive salivation is known as siluria. You remember the uses of cholinergic drugs. In cholinergic drugs, the name of the disease was xerostomia. Xerostomia means decreased salivation. If I'm having xerostomia, you give me cholinergic drugs. If I'm having opposite of that, I mean siluria, excessive salivation, you give me anticholinergic drugs. Cholinergic drugs, what does cholinergic drugs do? Cholinergic drugs, anticholinergic drugs. Okay, cholinergic drugs increase secretion from the gland, increase saliva, increase secretion from all glands. Anticholinergic drugs do opposite of that. They decrease saliva, decrease secretion from the glands. So if the person is having xerostomia, you want to increase secretion, give cholinergic drugs. If the person is having siluria, the person already have more secretion, you want to reduce it, give anticholinergic drugs. I hope you are getting it. It's not very complicated. So in siloria, pre-anesthetic, during anesthesia, the anesthetist want to do the decrease secretion so that laryngoscope can be inserted very well. And excessive salivation, the Parkinsonism, that is siloria only. So that is based on the glands. The next is heart. What does these drugs do in the heart? Before that, you tell me what does acetylcholine do in the heart? Acetylcholine reduces rate. These drugs increases rate. Increases rate, increases contractility, increases velocity. So in what diseases you want to increase the rate, contractility and velocity? So whenever the person is having bradycardia or heart block, you want to increase the heart rate. Suppose a patient coming to me, patient is having severe bradycardia or partial heart block. I want to increase the rate. I can give these drugs. I can give these drugs. You say. The next is CNS. In the CNS, I already taught you two uses. It is given as anti-motion sickness. It is used in Parkinsonism because it blocks vestibular M1 receptors. It blocks basal ganglion M1 receptor, and it is used as a lie detector. Okay, so it is used in motion sickness. It is used in Parkinsonism, and is used as a lie detector. You know what is lie detector? You may have seen in some movies or series. There is a lie detector test. Before doing the lie detector, we give some injection to the patient. This injection is of hyoscine. We give hyoscine, that is anticholinergic drugs. You know what does anticholinergic drugs do? Anticholinergic drug go in the brain and depress. You know, depression. Whenever we go in depression, we are very sad. You know, there is a theory: depressed person cannot lie. If the person go in severe depression, so whatever questions are asked, person will answer it, truly. So this is the lie detector. This is the principle of lie detector test. So the person will go in depression, and a depressed person cannot lie. So we will give scopolamine is the other name of hyoscine. So it is used as the lie detector. It causes sedation, it causes amnesia, and it causes depression in the brain. Okay. The next is antidote. It is given as an antidote. So in cholinergic poisoning, we were giving anticholinergic. In anticholinergic poisoning, we give cholinergic. Okay. So it is used as an antidote in anticholinesterase poisoning. That is cholinergic poisoning. Anticholinesterase is cholinergic drugs. That is organophosphorus poisoning. You know, the agricultural pesticides. And it is used in mushroom poisoning. Mushroom also contain cholinergic drugs. Mushroom contain cholinergic content. Okay. So in mushroom poisoning, wild mushroom poisoning, it is given as antidote. So I hope the 9 uses are in front of you. You can see the 8 markings. The ninth is the antidote. You can appreciate the 8 markings. Can we revise it quickly? So whenever we want to do GIT muscles to relax. Okay, when we want to GIT muscle to relax, in abdominal cramps, in intestinal cramps, intestinal colic, inflammatory bowel disease, gastritis, gastric hypermobility. In all these, we will give it. Okay. In urinary bladder, whenever we want the urinary retention, we want the urinary retention in increased frequency, increased urgency, and neurosis. We want to do urinary retention. It causes bronchodilation, so we give them in asthma. Okay. In uterus, it causes uterus dilatation, so we give them in dysmenorrhea. It decreases the secretion of the gland, so we give them in siloria and pre-medication and excessive salivation and Parkinsonism. It increases the rate, so we give them in bradycardia. Okay. And in CNS, there are 3 uses. It is used as an anti-motion sickness, as a lie detector, and Parkinsonism. You know the reason. And after that, it is used as a antidote for cholinergic poisoning, anticholinesterase poisoning, organophosphorus poisoning, and mushroom poisoning. Everyone give me a thumbs up. Please, everyone give me a thumbs up. So these are the 9 uses. Don't try even to learn them. See the markings. If you learn this table, you already know the good things of that. Even no need to learn. The good things you can pick up if you have understood the concept as a uses. If you want to some mnemonic, you can make some mnemonic, but you will forget. It will be a temporary learning. You should be able to say the reason why it is used in all these conditions. Anticholinergic drugs. With reason, with answer, with assertion, reason and assertion, you can write your answer. Whether it's a long question, short question, very short question, you can draw the flowcharts to explain. So this is the uses we have done. So I taught you 9 uses. Let me tell you the 7 adverse effects. Now from the same table, I will take the bad things. The good things uses, the bad things as adverse effect. So I will do the 7 blue markings. Okay, my blue markings are adverse effect. Okay, so you can understand. If the person already have constipation, would you like to give this drug? Anticholinergic drug. Person already have constipation and it causes further retention of the feces. So constipation will be exaggerated. Don't give this drug if the person already have constipation. Okay, if the person already have urinary retention, don't give. Person will go in permanent urinary retention. Suppose in BPH. You know what is BPH? Benign prostatic hyperplasia. This disease is known as benign prostatic hyperplasia. Prostate is a gland in males. Normal prostate is like this, but in BPH, the gland increases like this. This gland is present around the urethra. Whenever it's normal size, the urine can pass from the urethra. But whenever it increases size, it compresses the urethra. It is compressing. See, the urethra is hardly any lumen. So already this person have urinary retention. You know, urine come drop by drop, not in a flow. It occurs in males. In old age male, after 50, 60 years, it's very common. So here the urine retention, but normal person, the person with BPH pass the urine drop by drop, and it takes many hours or many minutes to pass the urine and empty the bladder and micturate. Okay, so this person already have the urinary retention. Okay, cherry on the top, what mistake a doctor have done? The doctor have given some anticholinergic drugs to treat some other disease, and doctor forgot to ask you, do you have BPH? If you have BPH, I will not prescribe this drug. Doctor has given anticholinergic drug to treat any other disease, suppose. So you know here M3 receptors are there, and here M3 receptors are there. What does anticholinergic drugs do? Anticholinergic drugs relax the muscle and constrict the sphincter. तो पहले ही उसको यूरिन नहीं आ रहा था. Initially also before your drug, the patient was in retention. Patient was having drop by drop urine. Now urine will completely stop because the muscle is relaxed and sphincter is constricted. So person will go in permanent urination. So in BPH, never ever give this drug to any person who is having BPH in urinary retention. Okay. Uh, like one of the side effect, the mydriasis. You know, whenever there is mydriasis, the vision get blurred. Okay, vision. So whenever we go to the doctor for eye checking, doctor, ophthalmologist put some drops, do the checking and ask us to go away. But we see everything blur for next few hours. You may have experienced if you have specs and you have done your checking, ophthalmology checking. Yes or no? So blurring of vision as a side effect. Okay, this increases IOT. Never ever give these drugs in glaucoma. Glaucoma will be exaggerated. Glaucoma mein already intraocular tension is high, and these drugs increases IOT. You can see these drugs increases IOT. Here you can see. So never ever. So these are the two side effects related to eye. Okay, they cause mydriasis, that's why blurring of vision, and they cause increased IOT, that's why contraindicated in glaucoma. Okay, they cause dry mouth. So if the person already have dry mouth, don't give these drugs. The dry mouth will be exaggerated. These drugs causes hot skin. Hot skin, you know, I mean, because they decrease sweating, and these drugs cause tachycardia and palpitation. They increase heart rate. So these are the side effects. I hope you got it. Contraindication you can take out from them. Okay, side effect is exaggerated, that is contraindicated. So BPH and glaucoma are the two contraindication if you want to highlight. BPH and glaucoma. These are the two contraindication. I hope you can write down here too. Okay, so this is the side effect and the contraindication. So at the end, I taught you 9 uses and 7 adverse effect of anticholinergic drug on one page. Don't learn this list. Don't learn this list. My advice, you see my red and blue markings. The red one are 9, the blue one are 7. You can count, and if you know this table, you can make out the reason why it is good to give and why it is bad to give. Okay, you can understand if you understand this table. So I promised you I will give you complete ANS just in 4 pages. 2 pages are done, 2 more to go. I already taught you 2 chapters till now. I taught you cholinergic drug, I taught you anticholinergic drug, and now I will teach you adrenergic drug, and I will teach you antiadrenergic drug. In antiadrenergic drug, I will teach you alpha blockers, and I will teach you beta blockers. So 3 more chapters to go: adrenergic, antiadrenergic, alpha blocker, and beta blocker. So do you want to see the summary? So total it will be on 4 pages. By the end of the session, after 1.5 hour more, I will teach you. Anticholinergic you can revise in 2 pages right now, and we will go ahead. Okay, you can see cholinergic, anticholinergic. Basically, you have to learn the 9 uses, 6 adverse effect here, 9 uses, 7 adverse effect here. You don't have to learn. You just learn the action. The good one is uses, the bad one is adverse effect. Again and again, I'm saying. So most important something here is the action. If you are learning that master chart, the good and bad, you can easily pick up with your common sense. Okay, I hope you are getting it. So this is the cholinergic drugs. You can see. Okay, this is the red and blue. You can see 9 red, 6 blue. 9 red, 6 blue. 9 red, 6 blue. Okay, and this is anticholinergic. 9 red, 7 blue. 9 red, 7 blue. So 2 of them are done. Okay, another 2 I will take, but I need a small break. I would like to take a break for 10 minutes. I will be coming back. After that, currently we have taken the session for 1.5 hour, I guess. 2 hours, I guess. Okay, so 1.5 hour or 2 hour more. That will be done and dusted. Okay, so give me a small break for 10 minutes. I will be back. Currently the time is 8:15 in my clock. I will be back at 8:25. 8:15, it's a break. Okay, 8:25, I will be back. 8:25, I will be back. Got it? After 10 minutes. So don't go anywhere. The session will continue and I will be back. Okay, I'm not ending the link. At the same link, at the same place, at the same YouTube channel, you please come. 8:25, I will be back. Adrenergic and antiadrenergic. You can't afford to miss it. Adrenergic, antiadrenergic. Please, you can't afford to miss it. So break time. I will be back. Hello, everyone. Am I back? I guess you can see me. Can anyone confirm in the chat box if I'm back? You can see, you can hear. Can I start the session? I guess I am. I guess, yes, it's working. Yes. So let's continue. So we have already completed cholinergic and anticholinergic. Now I'm starting adrenergic followed by antiadrenergic. So before we start adrenergic and antiadrenergic, people, just a second. So we have completed cholinergic and anticholinergic 2 chapters till now. And now we will quickly come on the adrenergic and antiadrenergic. You can see in the adrenergic drugs, I mean to say alpha beta agonist. I will teach them together, alpha as well as beta, and I will teach you which one is alpha agonist, which one is beta agonist, which use and adverse effect is based on what. And then I will come on antiadrenergic drugs. In the antiadrenergic drugs, I will teach you alpha blockers followed by beta blockers separately, 2 different chapters. So 3 more segments we have to go, 1, 2, and 3. Let's start it. So currently, I taught you cholinergic and anticholinergic drugs which were related to the parasympathetic system. And now I'm teaching you adrenergic and anti-adrenergic drugs which act on the sympathetic system. So you can see here the main neurotransmitter is noradrenaline. You cannot understand these 2 chapters, adrenergic and anti-adrenergic drugs, unless and until you understand everything regarding the noradrenaline. Okay, so here I taught you these 2 chapters. First, I taught you acetylcholine. Now, first, I will teach you noradrenaline, everything regarding that, and then we will move on these 2 chapters quickly. So, let me tell you regarding the noradrenaline. 4 things I want to teach you: its synthesis, storage, its release, and its uptake, one by one. Then we will compare and contrast the acetylcholine versus noradrenaline, and then we will move on the next chapter. So, what is noradrenaline? Here is noradrenaline. It is synthesized by the postganglionic neuron in sympathetic system. Yes or no? So how does it is synthesized? Tell me, how does it is synthesized? So let me zoom this portion for you to show its synthesis. So can you see in the next diagram this yellow neuron? Can you see this is yellow? It is the axon. This one. This portion is shown to you yellow. And can you see this organ? This organ is this one. You can see this is the organ having the receptors. It is having alpha receptors and it is having beta receptors. So inside the cytoplasm of this neuron, can you see this neuron, this axon? Inside the cytoplasm, this is synthesis takes place, noradrenaline. So first of all, you can see the steps. There is an amino acid which is known as phenylamine. Phenylamine is an amino acid. This amino acid, phenylamine get converted to tyrosine in the liver. This tyrosine enters in the exoplasm. Here, tyrosine. So tyrosine is there. So phenylamine to tyrosine conversion takes place in the liver. This tyrosine uptake takes place over here. Tyrosine. Now, this tyrosine will convert it into noradrenaline in multiple steps. You can see here, this tyrosine uptake takes place. This tyrosine converted first into dopa and then into dopamine. And this dopamine enter inside the vesicle. This is synaptic vesicle. In this synaptic vesicle, the dopamine convert into noradrenaline. So 2 steps are in the cytoplasm and 1 step inside the synaptic vesicle. So this tyrosine goes inside, tyrosine converted to dopa converted to dopamine, and dopamine enter inside the synaptic vesicle. Inside the synaptic vesicle, this dopamine converted to noradrenaline gets stored there only. Okay, if it is adrenal medulla, only in adrenal medulla, noradrenaline converted to adrenaline. Okay, otherwise this is the step. You can see first of all, phenylamine converted to tyrosine and liver. This tyrosine enter in the exoplasm, in the cytoplasm of the neuron. This converted to dopa converted to dopamine enters inside the vesicle. Inside the vesicle, dopamine converted to noradrenaline. And if it is adrenal medulla, only in adrenal medulla, noradrenaline converted to adrenaline. So these are the steps. They are in front of you. I hope everyone got the steps. Say yes if you got it. You can see phenylamine converted to tyrosine. Okay, tyrosine converted to dopa converted to dopamine converted to noradrenaline, and noradrenaline converted to adrenaline. This step takes place in liver. These two takes place in the exoplasm or cytoplasm. This one in the vesicle and this one only in the medulla. You can see the steps are in front of you. I hope everyone got it. Now, how does release takes place? At the time of the release, here the wave of depolarization is coming. So the signal is coming from the brain or the spinal cord. The signal is transmitted over here. It will cause depolarization on the axon. Because of depolarization, the calcium channels are present over here. Calcium influx takes place. Like in the same way, if you are attending the session from the beginning, like acetylcholine, since the calcium will go inside, calcium influx, whatever vesicles present here, the vesicles will fuse with the exoplasm and noradrenaline will come out. So when the wave of depolarization will come, calcium influx takes place, calcium causes fusion of the vesicle with the axonal membrane. and noradrenaline comes out. Once it will come out, it will act on its receptor, the alpha and beta receptors. Okay. Once it will act on its receptor, you can see this is noradrenaline, which is coming out with the green color. It will come here. It will act on the alpha receptor. It will act on the beta receptor. It will act there for a fraction of second. I must say fraction of millisecond, fraction of second or millisecond. After that, we have to destroy it. Now, how the destruction was taking place in acetylcholine? In acetylcholine, the great God has given us an enzyme over here. The name of the enzyme is cholinesterase, and that cholinesterase destroy the acetylcholine after a fraction of millisecond. Unfortunately, here we don't have any enzyme which destroy noradrenaline. Then you may be thinking, ma'am, how noradrenaline get its action is terminated? I mean, if you are saying it is not destroyed, we don't have any enzyme in this space to terminate the action to destroy the noradrenaline, then how its action is terminated? It cannot act on the receptor permanently. After a fraction of millisecond, we have to terminate its action. For termination, destruction with enzyme don't take place. In contrast to acetylcholine, its reuptake inside the neuron takes place. For termination, there are two pathways. One is neuronal, one is extraneuronal. What do you mean by neuronal and extraneuronal? See, after noradrenaline, this is noradrenaline, it is acted on alpha and beta receptor. It is acted on alpha receptor as well as beta receptor. Its reuptake takes place in the exon. Reuptake takes place with the help of a transporter known as NET transporter. Its reuptake takes place. Once it reaches in the exoplasm, from here its reuptake, second reuptake takes place inside the vesicle with the help of second transporter. The second transporter is VMAT, vesicular monoamine transporter, VMAT. So first with NAT from the space, it will go inside the exoplasm. From the exoplasm, it will further move inside the vesicle. It will further move inside the vesicle. Got it? Once it will be inside the vesicle, it's stored there, and with the next signal, next wave of depolarization, it will be again secreted. This is how it takes place. And sometime a small percentage, 1-2% of that, it will go in the blood. It will go in the blood and get metabolized in the blood. That is extraneuronal uptake. It will go inside the blood. Okay, so this is how the action is terminated. How many of you got it? How many of you got it? How the action is terminated. And once it is in the blood, it is metabolized. It is metabolized via two enzymes, MAO and COMT. Whether MAO followed by COMT or COMT followed by MAO, ultimately vinyl mandelic acid is formed. So noradrenaline get converted to vinyl mandelic acid. You don't have to learn this chemical complete structure flowchart. We have to just learn the noradrenaline ultimately converted to vinyl mandelic acid in the blood. That is the ultimate metabolite. Now compare and contrast. Everyone here. I taught you two neurotransmitters till now. I taught you cholinergic, anticholinergic drugs. We have already done and dusted. For them, the neurotransmitter was acetylcholine. And now I am teaching you adrenergic and antiadrenergic. Okay, for them, the neurotransmitter is noradrenaline. You see how they are formed, how they are synthesized, how they are released, and how their action is terminated. See, so here the yellow neuron and the green organ. Here also yellow neuron, and you can see the pink organ. So here you can see this is neuron, organ. So on one side, I will take acetylcholine. On one side, I will take noradrenaline. So for formation of acetylcholine, we need amino acid choline. Choline uptake takes place. For formation of noradrenaline, we need amino acid tyrosine. Actually, the amino acid is phenylamine. The phenylamine convert to tyrosine in the liver, and here tyrosine uptake take place. So here the first amino acid is choline. Here the first amino acid which is entering in the neuron is tyrosine, but in the body, phenylamine converted to tyrosine in the liver. Now here, choline once enter inside, it will convert it to acetylcholine directly. Here, tyrosine goes inside. Tyrosine first converted to dopa. Dopa then converted to dopamine. And dopamine enter inside the vesicle. Inside the vesicle, this dopamine converted to noradrenaline finally. Noradrenaline. Here, acetylcholine after formation, it will enter inside the vesicle and stored inside the acetylcholine. But it is formed outside only. Okay, and then it gets stored. So appreciate here the vesicle containing acetylcholine, here the vesicle containing noradrenaline. Appreciate the step, which step is taking place where. Now the signal is coming. The wave of depolarization is coming. The wave of depolarization is coming. Whenever wave of depolarization is coming, the calcium channels open. The calcium channels open. Calcium influx takes place. Calcium influx takes place. Because of calcium influx, the vesicle fuse with the axonal membrane and the release occur. Here acetylcholine comes in the space. Here noradrenaline comes in this space. Acetylcholine bind with its receptor muscarinic or nicotinic, whatever it is. And noradrenaline bind with its receptor alpha or beta, whatever it is. I hope you got it. Now it binds with its receptor here for a fraction of millisecond. It binds with its receptor here for a fraction of millisecond. After that, we have to terminate its action. How termination takes place? How termination? For termination of action, here the God has given an enzyme. The name of the enzyme is cholinesterase. Cholinesterase degrade acetylcholine into acetate and choline, and they are reutilized. They will go in the blood and reutilize. So for here we have an enzyme, but here we don't have an enzyme, which causes destruction of noradrenaline. For termination of action, reuptake take place. So here the termination of action is via enzyme. Here termination of action is via reuptake. For reuptake, two transporter is there. The first transporter is NET. From NET, this noradrenaline move in the exoplasm. And the second transporter is VMAT, VMAT2. Via that, from the exoplasm, it will move inside the vesicle and get stored again, waiting for the next wave to come. Everyone give me a thumbs up if you got it. Everyone say yes. Everyone give me a thumbs up if you got it. Okay. So this is how I taught you the two neurotransmitter, how acetylcholine and how noradrenaline. How acetylcholine, noradrenaline, how they are formed, how they are released, and how their action is terminated. Please learn, please understand, for termination of action of acetylcholine, we have enzyme. For termination of action of noradrenaline, the reuptake mechanism is there. I hope you got it. And you know the first amino acid from where they are formed. Here is choline, here is tyrosine. You get many MCQs. Which step is blocked by which? It is given in the notes. You can read it. Okay, later on. Now coming on the receptors. If you understood it, let's come on the adrenergic receptors. In cholinergic system, we were having muscarinic and nicotinic receptor. Muscarinic receptor are 3, M1, M2, M3. And nicotinic receptors are of 2. That is NM and NN. Okay. Just a second. Okay. But here in adrenergic, how many receptors we have? In adrenergic system, how many receptors we have in adrenergic system? In adrenergic system, we have alpha and beta. How many type of alpha? How many type of beta? We have 2 type of alpha. Alpha 1, alpha 2. And we have 3 type of beta. Beta 1, beta 2, beta 3. So total 5 receptors we have in adrenergic system. 2 alpha, 3 beta. Alpha 1, alpha 2. And beta 1, beta 2, beta 3. And God has given these receptors in our body. The great God has already given. See, alpha 1 are present on which organs and they cause what? Beta, alpha 2 present on which organs and they cause what? Beta 1, beta 2, beta 3, they are present on which organ and they cause what? So you have to learn it. Rather learning like this, I have simplified it. You don't learn alpha 1, alpha 2, beta 1, beta 2, beta 3. You just learn alpha, beta. Now, this is our master chart for the next 2 chapters. I will be starting adrenergic followed by antiadrenergic very fast. Okay. If you are with me on this table, the next 2 chapters will be cakewalk for you. Take my words. I will show you pharmacological action, uses, adverse effect, not 2, the 3 chapters. First, I will teach you adrenergic drugs, in which I will teach you alpha and beta agonists together. Then I will come on anti-adrenergic mein alpha blocker, then anti-adrenergic mein beta blocker. All 3 chapters I will show you in this master chart. Now you can imagine how this master chart is important for me. The next 3 chapters, the basis, the foundation of that is this master chart. Please do understand that. Please, I will give you 5 minutes to make you understand this master chart. Then I will start the chapters quickly and just flip it. You just understand the actions over here. The good will be taken as uses, the bad will be taken as adverse effects. I hope you are getting it. So see, one by one. Here I have shown you 13 organs and I have shown you the action of alpha on that organ and the action of beta on that organ. Okay, here I have shown you. For example, the first organ is blood vessel. On blood vessel, the God has given us alpha receptors as well as beta receptors. Alpha may say alpha 1 is present on the blood vessel, or beta may say beta 2. You know how many type of alpha and beta we have? We have 2 type of alpha, alpha 1, alpha 2. And we have 3 type of beta, beta 1, beta 2, beta 3. So on some organs, we have this. On blood vessel, we have alpha 1 and beta 2. That's my point. On blood vessel, the God has given alpha 1 and beta 2. What does they do? Alpha 1 causes vasoconstriction. Beta 2 causes vasodilatation. So alpha causes vasoconstriction, beta causes vasodilatation. Please learn that. Okay, this is the action of alpha and beta on blood vessel. Now coming on heart pe we don't have alpha. Coming on lung pe we don't have alpha. We have only beta, thankfully. So on heart, beta 1 is there, that is causing cardiac stimulation. We have beta 1 and that increases heart rate, velocity, contraction, everything. So it is positive inotropic. Okay, it increases everything. Okay, now on lungs, we have beta 2. And that causes bronchodilation. We don't have alpha. Here we have beta 2 and that causes bronchodilation. Okay, beta 1 is present only on 2 organs. One is heart and one is kidney. Here you can see kidney. Kidney may also, there is beta 2. So beta 2, I'm sorry, in kidney, yes, beta 1 is present only on 2 organs. Heart and kidney, not beta 2. Beta 1 is present. Rest all, it is beta 2 or beta 3. I hope you got it. Okay, the next organ is eye. I have already explained you previously. Okay, so eye may, the alpha is causing mydriasis, the passive mydriasis, and beta is increasing aqueous secretion, so increasing IOT. So that is the action on the eye. Okay, so coming on GIT and bladder. In GIT and bladder, in both of them, on sphincters we have alpha and on muscles we have beta. Okay, so both of them cause retention because it is emergency system. Imagine during emergency, the person don't defecate. During emergency, the person don't urinate. So we have to relax the muscle and constrict the sphincter. So relaxation of the muscle is caused by beta. Okay, and constriction of the sphincter is caused by alpha. You can see. Okay, so here also, relaxation of the muscle is caused by beta. Am I live, people? I guess I am. You have to give a confirmation. Am I live? Just a second. Let me confirm if I'm live. I will continue. I guess I am. Yes, I am. Okay. So on GIT as well as urinary bladder, in both of them, okay, in both of them, the muscle relax because of beta, and the sphincter constrict because of alpha. On the alpha, there is sphincter. So this is what you have to learn. Coming on the next, uterus. Uterus may, alpha causes constriction, beta causes relaxation. Uterus may. Both the actions are there. Coming on pancreas. Alpha inhibit insulin, beta augment insulin. So alpha is inhibiting insulin, beta is augmenting insulin. It's complicated. Okay. In the liver, in metabolism, we don't have alpha role. We have only beta role. And beta is catabolic. It degrade everything. It degrade the glycogen in the liver, glycogen in the muscle. It degrade the lipid in the adipose tissue. So it is degrading everything. The beta is present in the liver, in the skeletal muscle, in the adipose tissue, and it degrade everything. It is catabolic. Now coming on the kidney. In kidney, I told you we have beta 1. We have beta 1 only on two places, the heart and the kidney. In kidney, the beta 1 secrete renin in the blood. Renin angiotensinogen pathway. I will teach you this pathway in CVS. So renin is a hormone that is secreted by the extraglomerular cells into the blood from the kidney, the beta 1 cells. The beta 1 cell stimulates its release. And renin, what does it do? It converts angiotensinogen to angiotensin 1, angiotensin 1 to angiotensin 2, and angiotensin 2 causes rise in BP. I hope everyone got it. On male sex organ, you can see, on male sex organ, the ejaculation is due to sympathetic. Erection was parasympathetic, if you remember. Ejaculation is due to sympathetic alpha. So sympathetic alpha, the ejaculation. Okay. Apart from that, skeletal muscle, there is beta. Beta causes tremors in the skeletal muscle. Beta causes tremors. And in brain, beta causes anxiety. In the brain, beta causes anxiety. So these are the organs. I mean, this is the master chart, although it's complicated, but you have to learn it once. Just once. And it is nothing, it's physiology. There is no concept behind that. It's factual. These receptors, alpha and beta, on these 30 organs, the great God has implanted in us. These are present in us. They are functioning right now. So these receptors are already present in us. In some organ, we have alpha. In some organs, we have beta. In some organs, we have both. And what is the action of noradrenaline on these organs? That's what you have to learn. Then you will be able to understand the drugs over here. So let's start my next chapter, adrenergic drugs. Now, if you are ready with this, give me a thumbs up. If you're ready with this master chart, here only I will teach you the next 3 chapters. First, I will teach you adrenergic drugs, then I will teach you alpha blockers, then I will teach you beta blockers. Alpha and beta blockers together constitute antiadrenergic drugs. So I will teach you adrenergic followed by antiadrenergic, that is alpha and beta one by one. All the chapters are based on this table. Have you understood this table? Can we start? Give me a thumbs up. So let's start my next chapter, adrenergic drugs. Can we start? Chalo, my 3rd chapter for today. Adrenergic drugs. Adrenergic drugs means what? I'm teaching you alpha beta agonist. So agonist I'm teaching you together, but blockers I will teach you separately. Okay, so alpha or beta or both of them agonist. Tell me the definition. What is alpha beta agonist? I mean, what is adrenergic drugs? What do you mean by that? Adrenergic drugs, also known as sympathomimetic drugs. See, here is noradrenaline. You can see the diagram. This is noradrenaline. Noradrenaline is released over here and it acts on the alpha receptor or beta receptor and show its action. No, this action is not sufficient. This action is not sufficient. Okay, I want to augment this action. So I will give an external agency. I will give an external drug. Okay, whether oral, injectable. This drug via blood, orally, injectably, reach this space. And after reaching this space, this drug will bind with the alpha or beta receptor and show the same action as that of noradrenaline. So noradrenaline action is exaggerated, and that's why this is known as adrenergic drugs or sympathomimetic drugs. It is mimicking the action. I hope everyone got the definition. You can understand it now. Okay, so this is the definition. Coming on the classification of adrenergic drugs. This is the classification. Actually, the classification is based on the uses. Here, once you will understand the uses, now I will teach you here 6 uses. The classification is based on their use. Some of them are pressor agents which increase BP. Some of them are cardiac stimulants which act on the heart and stimulate the heart. Some of them are bronchodilators, they act on the lung and dilate the lung. Some of them are nasal decongestant. Okay, I will explain how. Some of them are CNS stimulant. Some of them are anorectics. Anorectics are the drugs that increases hunger in human, and some of them are uterine relaxants in female. So these classification, you have to learn the basis of classification, like anticholinesterase. Okay, in anticholinergic, the basis of classification was natural, semi-synthetic, synthetic. Here the basis of classification is their uses. So what's the, and after that you have to definitely learn the drugs inside each category, but broadly you have to learn the basis of classification. Here the basis of classification is not their chemical nature, it is not alkaloid, steroid, like that. The basis of classification is not natural, semi-synthetic, synthetic. The basis of classification is their uses. Okay, so we are dividing them into 7 categories based on their uses. Once you will understand the uses, learning classification will be very easy for you. I'm coming on the uses also, but broadly you see the classification over here. So there are certain adrenergic drugs that increases BP in human body. These are known as pressure agents. The best pressure agent is noradrenaline. It causes increase in BP. Ephedrine, dopamine, okay, phenylephrine, these are the pressure agents. There are certain which increases the heart rate, like adrenaline, isoprenaline, and dobutamine. Here we have dopamine, here we have dobutamine. Don't get confused. Okay. Some of them dilates the lung. They are used in asthma. They are drug of choice in asthma. You can see isoprenaline, salbutamol, terbutaline, salmetrol, formoterol, bombuterol. I guess everyone knows. I will teach you all these drugs and respiratory drugs, right? So these are the treatment. These are bronchodilators. Some of them are CNS stimulants. Okay. So we will give them in ADHD and all disorders, amphetamine, dexamphetamine, methylamphetamine. These are the derivatives of amphetamine. Some of them relax the uterus. Okay, we will give them in threatened abortion. The best among them is ritodrin, isosuprin. So these are uterine relaxants. Some of them are nasal decongestants. So we use them as a nasal spray. The best one is xylometazoline, oxymetazoline. You have to learn the main prototypes which I'm taking over here. Anorectics increase hunger. The same amphetamine come here as anorectic also. I will explain why. You will get the reason for why. You may be thinking, ma'am, why? You will explain. I will explain everything in this table. You just learn this table. In this table, I will explain everything. So this is the classification. So classification is factual, people. I cannot help much in that. I can read the drugs, but you have to stick on your wall and learn the classification. Now, some of them are alpha agonist. Some of them are beta agonist, and some of them are both. I will explain one by one. Okay. Some of them, I will explain them 3 in detail. Which 3 I'm going to teach you in detail? Noradrenaline, isoprenaline, and adrenaline. These 3 in detail, I will teach you in detail. You can see these 3 have alpha and beta both agonist. Okay, I will teach you these 3 in detail. You can see here. Where is noradrenaline? Here is noradrenaline. Okay, where is adrenaline? Here is adrenaline. Where is isoprenaline? This one. So they are alpha as well as beta. You can see noradrenaline is alpha 1, alpha 2, beta 1, beta 3 agonist, but not beta 2 action. Similarly, isoprenaline is beta agonist, but not alpha. Adrenaline is again alpha beta both, but no weak beta 3 or no beta 3. It's beta 1 and beta 2. I will explain them in detail. Okay, now mechanism of action. So we are done with definition. We are done with classification. Now we are coming on mechanism of action. Can we come on mechanism of action? What's the mechanism of action? You tell me. I guess you got it. Here also, you understand this diagram. What is this diagram? This is physiological inside me, you, in all of us. This can be any organ in my body, from head to toe. It can be any organ in my body. So in these organs, this is noradrenaline, which is secreted over here, and this noradrenaline is acting on the alpha receptor or beta receptor and shows its action. But this action is not sufficient in me physiologically. That's why I'm having some disease. This action is not sufficient in me. That's why I'm having a disease and presenting to you as a doctor. You are a doctor. You are giving me a drug. Okay. So to treat my disease, you are giving me drug. 2 types of drug. One of the 2 types of drug you are giving to me. So what this drug is doing, this drug is supposed to increase the action over here because my disease is due to less action. I want to exaggerate the action so that my disease can be cured. I will explain that with example. Okay. So here one of the drug, what it is causing, one of the drug is Hamshakal of noradrenaline. It is having similar structure as that of noradrenaline. So it will come here. Since it is Hamshakal, identical twins, similar structure as that of noradrenaline, it will bind with alpha and beta and show the same action as that of alpha and beta. So this is known as direct action. What is known as direct action? The second type of drug, it is not Hamshakal. It is not the structurally similar. It is not the identical twin of noradrenaline. So it cannot bind here with the alpha and beta receptors because alpha and beta receptor cannot bind. They will say, no, you have a different phase. You are not noradrenaline. We will not bind with you. So what this drug will do, this drug will enter inside this neuron and increase the synthesis and release of natural noradrenaline. This drug will go inside, increase the synthesis and release of natural noradrenaline. So this drug is having indirect action. So we have two type of adrenergic drugs: direct action, direct sympathomimetics, and indirect action, indirect sympathomimetics. What does the direct do? Direct has Hamshakal, similar structure as that of noradrenaline, so they directly bind with the receptor. And indirect one don't have the same structure, so they increase the release of the natural noradrenaline. They are in front of you. So some of them are direct sympathomimetics, some of them are indirect, and some of them have both these action. The direct one directly act on the receptors. The indirect one can't act on the receptor. The indirect one enter in the neuron and cause the release of natural noradrenaline more and more. And mixed one have both, direct as well as indirect. I hope you got the mechanism of action. So you know the definition, you know the classification, and you know the mechanism of action of adrenergic drug. Can we revise? What is the definition? What are adrenergic drug? They exaggerate the actions of natural noradrenaline. Okay, that's why they are known as sympathomimetic drugs. Classification wise, we divide them in 7 categories based on their function. Some of them are pressor agents, some of them are cardiac stimulants, some of them are CNS stimulant, some of them are bronchodilators. Okay, some of them are anoractics, some of them are uterus relaxants, likewise. Okay, you know the prototype drugs inside each category. Mechanism of action, I taught you the 2 mechanism of action: direct, indirect, and the third one is mixed. Direct directly act on the receptor, indirect enter in the neuron and increase the release of the natural noradrenaline, and mixed have both action. Now coming on the pharmacological action, the most important, people, if you understand pharmacological action, that's the end of the chapter. The good one will be the uses marked with red color, and the bad one will be the adverse effects or contraindication marked with the blue pen. So I will show you the uses and contraindication from the pharmacological actions itself. So please, I request all of you to understand the pharmacological action well. If you are understanding it, there is no need to understand the uses and adverse effect. No need to learn, I mean. So let's start the pharmacological action. The complete pharmacological actions are in front of you. Now, one by one, I will switch the organ. You know, the toughest to understand is the blood vessel, then heart, then lung, then eyes. One by one, I will teach you all 13 organs. I want you to tell me the action of alpha as well as beta. Okay, on these organs, one by one, we will see in detail. Let's start with blood vessel. Now, blood vessel is complicated. Why? Because alpha causes vasoconstriction, beta causes vasodilation. So, what is the overall action? What is the overall? Again, I repeat, alpha causes vasoconstriction, beta causes vasodilation. Alpha may be to be specific, it's alpha 1, which causes vasoconstriction. And beta may to be specific, it's beta 2, which causes vasodilation. You can cross check in my table. My table is, you know, Bhagwan ka diya hua table. You have to learn it as it is. That's it. That's it. You just learn this table. Your complete 3 chapters are done and dusted. Everything I have included with small fonts, you know, in this table. You just understand. You know, you can see here alpha 1 causing vasoconstriction and beta 2 causing vasodilation. The same thing I have written. Alpha 1 causing vasoconstriction, beta 2 causing vasodilation. You can see. So what is the overall effect on my BP? On noradrenaline. So this is, you can see, this is my blood vessel, suppose. My blood vessel is having 3 layers: intima, media, and externa. Okay, so media, I'm talking about the media. In my blood vessel, in my media, okay, I'm having alpha 1, I'm having beta 2. Okay, the God has already implanted inside me, inside my blood vessel, inside all of our blood vessel. Okay, so when noradrenaline is coming, noradrenaline coming and binding here, causing vasoconstriction. Noradrenaline coming and binding here, causing vasodilation. So what will be the overall effect? Is it vasoconstriction? That is increased BP. Is it vasodilation? That is reduced BP. So what is the effect on my BP? You are getting my question. Okay, to understand this, it is complicated. That's why I'm saying, please understand the concepts behind that. Now, let's come on the next also. Heart also, let's check together. Heart may, thankfully, we don't have alpha or very little action. We have beta. Beta may, but we have beta 1 on the heart. So that's why I have drawn heart also. So inside my body, I am a human. Inside my body, I'm having many blood vessels and I'm having one heart. And I'm having many blood vessels inside my body. Yes or no? So inside my blood vessel, I'm having alpha 1 and beta 2 in the media of my blood vessel. You can appreciate the 3 layers. And inside my heart, the one and only heart, inside my heart, in my myocardium of the heart, I'm having beta 1. Appreciate the 3 receptors first. Appreciate the 3 receptors, then I will explain you this complexity. This is alpha 1, this is beta 2, and this is beta 1. Now, when noradrenaline comes, suppose this is noradrenaline, which is secreted out, it will go and bind here, causing vasoconstriction. It will go and bind here, causing vasodilation. It will go and bind here. The same noradrenaline, it will increase the contractility. It will increase the contractility. You can see here in the chart. It is cardiac stimulant. It will increase the contractility. Say yes, say. Now, what is the effect on my BP? What is the effect when noradrenaline will come in my blood? Currently, I don't have noradrenaline in my blood. I don't think so because it comes in emergency situation. And currently, I'm very relaxed because teaching is my best, job I can do. So currently, I'm very relaxed. I don't have any emergency situation. So inside my body, I'm having acetylcholine right now. I don't have noradrenaline. But whenever I'm in some emergency, tiger behind me, I have to save my life. At that time, noradrenaline will come in my blood. So my question to you, when noradrenaline will come in my blood, it will go in the blood vessel, bind with alpha 1 causing vasoconstriction, bind with beta 2 causing vasodilatation, and it will go in my heart and bind with the beta 1 of the myocardium causing increased contractility. So what is the effect on my BP? My BP will increase or decrease? Say, ma'am, you have to be specific. There are two type of BP component, SBP and DBP. Which BP you are asking? Your SBP, systolic blood pressure, or your diastolic blood pressure? Normally, systolic blood pressure is 120 and diastolic blood pressure is 80, 120 mm of mercury and 80 mm of mercury. So you are asking about which BP to be specific, or overall you are asking the mean BP. So because the answer differs, so you have to understand what is SBP and what is DBP. You have to understand here. SBP systolic blood pressure depends on heart contractility. Whenever heart is contracting, my heart is contracting more, SBP will be more. My heart contractility is less, SBP is less. So SBP don't depend on blood vessel. SBP depend on heart contractility. Please have a concept. It's physiology actually I'm teaching you. Now DBP depends on blood vessel status. Blood vessel is constricted, DBP will be more. And blood vessel is dilated, DBP will be less. So DBP depends on the blood vessel. SBP depends on the heart. So likewise, we can decide separately. I hope you got it. I hope you got it. Say yes. So this is what I want to tell you. SBP, DBP. Okay, SBP depends on cardiac output and DBP depend on blood vessel. So this decides my SBP, systolic blood pressure. Heart is contracting more, so SBP will be more. Heart is contracting less, SBP will be less. And DBP depends on vessel status. If there is vasoconstriction, DBP is high. If vasodilatation, DBP is less. Give me a thumbs up if you are getting. Got it? Now, so what is the summary? What is the crux? You can compile the two things with the receptor with this concept I taught you. So say, ma'am, that means you are saying alpha 1 receptors present in the blood vessel causes vasoconstriction. So they increase our DBP. I want to say that. Yes. So alpha 1 receptor increase DBP because they are present on vessel. Alpha 1. So God has given alpha 1 in the vessel. Okay. Beta 2. Okay. Beta 2 also present in the vessel. Okay. But they cause vasodilatation. And that's why they reduce DBP. Yes, they reduce DBP. Okay. And beta 1 are present in the heart. As I told you, beta 1 are in the heart. They increase the cardiac stimulation. That's why they increase SBP. So this is the result. Okay. So the summary is alpha 1 increase DBP. Okay. DBP. Beta 2 reduce DBP. Reduce DBP because both of them are present on blood vessel. And beta 1 present on the heart increase SBP. Increase SBP. So this is the crux. How many of you got the crux? Everyone give me a thumbs up if you got it. I'm going to teach you vasomotor reversal of Dale. It's complicated, but I will try my best. In my lectures, nothing is complicated. Say, this is the crux. This is the crux? Yes or no? Yes or no? So I cannot comment ki BP will increase or BP will decrease. So we will comment separately for SBP and DBP. So we will say, in this diagram, you can understand. If you understood this diagram well, you can go ahead with this diagram. You can see God has given which receptor on which organ. Please appreciate the three type of receptors I have highlighted. Appreciate I am a human. This is a blood vessel inside me. This is my heart. Okay, appreciate God has given which receptor where. So God has given two type of receptors in my blood vessel, many blood vessel, alpha 1 and beta 2. And God has given me one heart. In my heart, in my myocardium, I am having beta 1 receptors. Now tell me the summary. What does they do? Say, ma'am, when noradrenaline come in your blood, whenever there will be a tiger behind you, you run, you save your life. At that time, noradrenaline will come in your blood. Noradrenaline bind here, bind here, bind here. When noradrenaline bind to alpha 1, there will be vasoconstriction, so your DBP will rise. Okay. When noradrenaline bind to beta 2, there is vasodilatation, so your DBP will fall because DBP depends on vessel status. And when noradrenaline the same noradrenaline going here, now going to your heart, bind with the beta 1, so it causes cardiac stimulation, cardiac contractility increase, and that will rise your SBP. This is what I want to say you from different things. Everyone give me a thumbs up if you got it. If you got this concept. Okay. So this is the crux. This is the crux. I call it crux. If you got it, please say yes. Everyone give me a thumbs up. Say yes. Now, what is the effect of BP when we give these drugs? Suppose you are injecting noradrenaline to me. You say my BP will rise or fall. My SBP will rise or fall. My DBP will rise or fall, or my mean BP will rise or fall. 3 questions, 3 answers. Leading questions, leading answer. Okay, when you are giving an injection of isoprenaline to me, suppose you are injecting. So again, the same 3 questions. SBP ka kya hoga? What will happen to SBP? What will happen to DBP? What will happen to mean BP? Again, the most important, if you are giving me an injection of adrenaline, what's going to happen? You should be able to explain. You don't just learn, ki, ma'am, with this will increase, this will decrease. The receptor status in front of you. Noradrenaline binds with alpha 1, alpha 2, beta 1, beta 3, but not with beta 2. Okay, it is having agonist activity for these. Isoprenaline bind with only beta, not alpha. Isoprenaline only with beta, not with alpha. And noradrenaline bind with alpha 1, alpha 2, beta 1, beta 2, but not beta 3. You have to learn this, first of all. No, this is a fact. I cannot change it. It is a fact. These are the drugs having receptor agonist action for these receptors. Now you have to use your common sense, that crux I told you here. You have to apply that crux and tell me the summary, whether each injection one by one we will take. So let's talk about the first injection. The first injection we will take is noradrenaline. Suppose you are injecting noradrenaline in me. Okay, I'm your subject. You are a doctor. You are injecting noradrenaline. Measure my BP. What's going to happen? Use your common sense. You will say, man, it is having alpha 1 receptor. So it will act on the alpha 1 and increase your DBP. It is having alpha 2, but alpha 2 is not coming over here. So alpha 2 is of no use. Okay, it is having beta 1. So beta 1 is going here. Okay, and it is increasing your SBP. Okay, and it is having beta 3 action, but beta 3 is of no use here. Okay, not related to BP. It don't have beta 2 action. It don't have beta 2 action. Cross it here. So the summary is, it will increase my DBP, it will increase my SBP. I don't know whether you understood or not, but it will increase in SBP, it will increase in DBP. It will increase in SBP, increase. So overall mean BP will also rise. SBP will also rise, DBP will also rise, and overall mean BP also rise. Say, people say yes, no, but respond. Say. So this is the action of injection of noradrenaline. If you know the crux, just apply. Just learn two things, people. On this page, you don't have to learn the complete page. Okay, according to me, on this page, you have to learn this receptor status. If you know this receptor status, okay, and you have to learn this crux. This crux. Okay, you apply this receptor status on this crux, you will reach on your answer. It is having alpha 1 action. So according to alpha 1, DBP will rise. It is having beta 1 action. So according to beta 1, SBP also rise. It don't have beta 2. It don't have beta 2. Okay, so SBP rise, DBP rise, dun 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 dun. Mean BP will rise. Got it? So this is the action of noradrenaline. The same is written. See, noradrenaline. SBP rise, DBP rise, mean BP will rise. So this column is done. This column is done. Now coming on isoprenaline. You are giving me an injection of isoprenaline. What's going to happen to my BP? Say. See its receptor status. Now you will get your answer. If you have the receptor status, see, this is the receptor status. Just learn that. This is a fact that cannot change. You have to learn this fact. Apply it on the crux. You will get your answer. So it is having no alpha. It is having beta 1 as well as beta 2. Since it is having beta 1, SBP will rise. But since it is having beta 2, DBP will fall. SBP will rise, DBP will fall. And it don't have alpha action. It don't have alpha action. So SBP will rise, DBP will fall. You should know the reason. Please, you will get marks for writing reason. Usually it comes for 2 or 3 marks. They will ask why. The why is important. You should write down the receptor correctly. You're getting my point. And mean BP will fall. Okay, so SBP rise, DBP fall, and mean will fall. So again, see isoprenaline. SBP rise, DBP fall, and the mean will fall. Say, people say, are you getting it? Are you getting it? Now, tricky. Okay, adrenaline. The things are not as simple. Okay, these two were simple. Okay, but now adrenaline. Let's come on adrenaline. See its receptor agonistism. You can see this is the agonist. Agonist of what? Just learn it. Adrenaline is agonist at what? And apply it on the crux. Now, it is not that way simple. It is not that way simple because it is having alpha 1 as well as beta 1 as well as beta 2. You are getting my point. It is having all three. So you will get confused now what's going to happen. Okay, what's going to happen to SBP? What's going to happen to DBP? Okay, don't have beta 3 and alpha 2 is of no relevance over here. So let me tell you one by one. At low concentration, start with low. As soon as you will give me the injection, it will be low concentration and gradually it will increase. So at low concentration, beta 2 predominant. Beta 2 predominant. At low, beta 2 predominant. And at high concentration, after some time, there will be a peak of concentration, alpha 1 predominant. These two are contradictory. Now, again say, start from the beginning. See its receptor status. Again start. Start with the receptor status. Say, ma'am, I don't have confusion in SBP, but there are two DBP. DBP will increase or decrease? You are saying it is having alpha 1 also. You are saying it's having beta 2 also. So what will happen to DBP? DBP will increase or DBP will decrease? So it depends on the concentration. It depends on the concentration. Are you getting my point? So at low concentration, beta 2 predominant. So first BP fall. At high concentration, alpha 1 predominant, so BP will rise. So as soon as you will give me injection, my BP will first fall, then rise. Okay, I'm sorry. At low concentration, at low concentration, at high concentration, alpha 1 predominant, and at low concentration, beta 2 predominant. Beta 2. So yes, everything is correct over here. The only thing I have interpreted it wrong. So as soon as you are giving me the injection, the complete injection going in one shot. Okay, so as soon as you give me the injection, it will be high concentration, not low. Okay, as soon as the complete injection you are giving me in muscle or in IV, so it directly going in my blood and high concentration, and gradually it will cleared as glomerular filtration, and gradually the concentration will be low. So initially, as soon as you give the injection, alpha 1 will predominate, the BP will be high. And after some time, when it is excreted in the glomerular filtrate in the urine, so beta 2 will predominate, its concentration will fall, and at that time the BP will decrease. So as soon as you give me the injection, first BP rise, then it become normal, then it will fall. So it is known as triple response. So give me the injection of adrenaline, measure my BP. First you will notice the rise. After a few minutes you will see the normal, and after that you will see the fall. The rise is due to alpha 1 and the fall is due to beta 2. This diagram you have to draw in adrenaline. This is what I have explained you, the triple action. First, rise in BP, because at high concentration, alpha 1 predominant. Okay, then BP return to normal. And then fall in BP, because at low concentration, beta 2 predominant. Everyone give me a thumbs up. Say yes if you said, if you understood. Got it? So this is the action of adrenaline. Say, ma'am, can you prove it? Okay, the rise is due to alpha 1, how you are sure? And the fall is due to beta 2, how you are sure? So again, we will do the same experiment, but before giving the injection of adrenaline, give me injection of alpha blocker. First, give me injection of alpha blocker, block my alpha receptors. Now give adrenaline. So alpha 1 will not act because alpha receptors are already blocked. No, this time you will get only fall, not the rise. This was discovered by vasomotor, proven by this was proven by Dale, and that's why it is known as vasomotor reversal of Dale. So here we are giving adrenaline after injection of alpha blocker. So we'll get only fall, not the rise. If you are giving injection of adrenaline, you will get rise, then fall. But if you are giving alpha blocker followed by adrenaline, you will get only fall. So that's what I might mean to say. So if you are giving injection of adrenaline, okay, what will be the graph? And if you are giving first alpha blocker and then adrenaline, what will be the graph? Adrenaline. What will be the graph? Can you tell me? So here graph is first rise, then normal, then fall. And here the graph is only fall. You are getting my point. The rise is due to alpha 1, the fall is due to beta 2. Here, since you have blocked the alpha, to be specific, here you give alpha 1 blocker, specific alpha 1. So alpha 1 is blocked. Alpha 1 cannot act. So only fall will be there. And the fall is due to beta 2. And this was discovered by Dale, the scientist Dale. We call it vasomotor reversal of Dale. You frequently get question on this in your university exams. Say yes. So if you are giving adrenaline after alpha blocker, only fall, not rise. And it is known as vasomotor reversal of Dale. I hope it was complicated. I tried my best. So you can see adrenaline mein. Okay, you can see SBP, DBP, they will initially rise, then fall. So it will neutralize. Okay, so I hope you got it. So we are done with the action on blood pressure and BP. I taught you 3 drugs over here. I taught you noradrenaline, adrenaline, and isoprenaline. Any of them they can ask in your exam, what is the effect of BP by giving the injection of these drugs? And you should know their receptor status. If you know their receptor status and you know the concepts, the crux, I call the concept as crux. You just apply the receptor status on the crux, you will get your answer. Now coming on heart. Let's come on the heart. Heart maybe we don't have alpha, we have only beta. Beta maybe we have beta 1 on the heart. Okay, there is a beta 1 on the heart. Okay, just a second. There is a beta 1 in the heart. Just a second. I am live. Am I live? I guess I am. Yes. So let's come on the beta 1. Okay, beta 1 is present on the heart. What does it do? It increases rate, force, velocity. So it is positive inotropic, positive chronotropic, positive dromotropic. So rate, force, and velocity, they all will be increased in the heart. Heart pe we don't have alpha. Lungs pe again we don't have alpha. You can see the lungs pe we have only beta, that is beta 2, and beta 2 are bronchodilator. They dilate the bronchioles. You have to learn it. Coming on the eyes. Eyes may alpha causes mydriasis, the active mydriasis, and beta causes increased aqueous secretion, so increase IOT. Okay, this I have already explained you in the first chapter. So I'm talking about adrenergic drugs alpha. It causes active mydriasis due to alpha. Okay, and on ciliary muscles, if you talk, it increases IOT. It increases IOT. Now coming on GIT. Coming on GIT. Okay. GIT as well as bladder. On both of them, the sphincter pay, we have alpha, and the muscles pay, we have beta. Okay, and overall, they cause retention. So they relax the muscle, constrict the sphincter because it is an emergency situation. In emergency situation, no defecation, no urination. So we have to relax the muscle and constrict the sphincter. So relax the muscle because of beta, constrict the sphincter because of alpha. Ultimate result is retention. Okay, so muscle relaxation is due to beta and sphincter constriction is due to alpha. And the ultimate result of both of them, muscle will relax, the sphincter will contract. So feces cannot pass, no defecation because it's an emergency situation. And that's the overall action of alpha and beta agonist, right? Bladder pe bhi same. Bladder pe bhi the muscle relax and the sphincter contract. The muscle relax is due to beta and the sphincter contract. Sphincter contract is due to alpha. Overall result is retention. That is the bladder. Okay, coming on uterus. Uterus pe contradictory. I mean, alpha contract the uterus, beta relax the uterus. Species to species, animals to animals, the action differ. But in human, overall, at the time of term, adrenaline say it is relaxed. Okay, so on uterus, there is a complicated mechanism. Don't go in the detail. Pancreas may alpha, I already taught you, alpha inhibit insulin, reduces insulin, and beta augment it. Beta augment it. Okay. Then the next is metabolism in the liver. I already taught you the beta. Alpha don't have any action. The beta is catabolic. It degrade everything. So it degrade glycogen in the liver and convert into glucose. So hyperglycemia. It degrade glycogen in the muscle and convert into lactic acid. So hyperlacticemia. It degrade the lipid in the adipose tissue. So increases free fatty acid. And it is calorigenesis. The next is kidney. Kidney mein we don't have alpha. Kidney mein we have beta, beta 1. I told you beta 1 present only at two places, in the heart and in the kidney. So in the kidney, there is beta 1. In the kidney, the beta 1 releases renin. You know, renin angiotensinogen pathway get activated. In the male sex organ, we don't have beta. It is alpha 1, which causes ejaculation. Erection was due to M3 receptor. If you remember, M3 receptor, M1, M2, M3 may was there, the male sex organ. Okay, and ejaculation is due to alpha. So erection is due to M3, ejaculation is due to alpha 1, and this is the only organ on which sympathetic and parasympathetic systems are working complementary, not the opposite. Okay, now coming on skeletal muscle. Skeletal muscle may beta causes tremors. The beta causes tremors, and CNS may beta causes anxiety, apprehension and anxiety and restlessness. So that is the function, actions I told you. If you understand, nobody is going to ask you the action in your exam. But if you understood the action, the uses and contraindication, they are definitely going to ask you in your exam. They will ask you the uses and adverse effect of alpha and beta agonist, and you should be able to understand and answer why, the reason assertion questions, if you understood this. Now, the good things are taken as uses and the bad things are taken as contraindication. It's very easy. Okay, let's take the good uses and bad uses. The good I will mark with red color. The bad I will mark with the blue color in my master chart. So let's start the uses. There are 7 uses. The 7 good things are there in the action. What are the 7 uses? One by one. Whenever we want to increase the pressure, this is the same as that of classification. In the classification also, we are having these 7 classes, if you remember. Okay, I told you the classification is based on uses. So these are used as a pressure agent. They increase BP. The alpha agonist we use to increase the BP. You see what is alpha? What does alpha do? See my red marking. Alpha causes vasoconstriction. So it increases BP. So whenever you want to increase BP, use it. So when we want to increase BP, you tell me the condition when we want to increase the BP in your patient. If my patient is hypotensive, I want to increase BP. If my patient is an anaphylactic shock, I want to increase the BP. If I'm giving local anesthesia, I want to increase BP. Why? During local anesthesia, I want the local, suppose here I am a surgeon, I want to operate in this area. I'm giving local anesthesia, not general. So I want the local anesthesia to be in this area. So I will vasoconstrict. So that local anesthesia remain in this area, systemic toxicity is minimum, and the duration of action is prolonged. So during local anesthesia, we use vasoconstrictor. Okay, to control the local bleeding. Suppose I am having nasal bleeding. So a cotton soaked in adrenaline can be put here that causes vasoconstriction, bleeding reduces, and nasal decongestant. So in all these conditions, I want to do vasoconstriction. So that's why I'm using an alpha agonist. A alpha agonist is used as a pressure agent whenever you want vasoconstriction. One by one. So you can see hypotensive state. Okay, whenever the BP is less, you want to do vasoconstriction, give a alpha agonist. Whenever anaphylactic shock is an emergency, the BP falls rapidly and the person can die within few seconds or minutes. So it's an emergency. In emergency, give adrenaline 0.5 milligram IM injection. It's the drug of choice for anaphylactic shock. It's your question. It's your MCQ. Please learn it. Okay, so during emergency, In anaphylactic shock, if you want to do the vasoconstriction and save the person, increase the BP, give adrenaline 0.5 milligram intramuscular along with the local anesthesia. I told you now, if you are giving a local anesthesia, you want to do vasoconstriction, so local anesthesia remain in this area only. It is not showing systemic toxicity, and the duration of action of local anesthesia is prolonged during the surgery. If you want to control local bleeding, suppose nasal bleeding, so take a cotton and soak it in adrenaline 1 in 10,000 concentration and put it here. So it will cause vasoconstriction of the blood vessels, alpha agonist. Vasoconstriction. So the bleeding will reduce. The next is nasal decongestant. You have to understand here what is nasal decongestant. What do you mean by nasal decongestant? See, this is my nose. Please don't spam. Someone is spamming. Kunal Sagar. Don't spam the chat box. You will get the reply after the session. Listen. So you can see this is the nose. This is the nasal septum. This is the nose. This is the nasal septum. Inside the nose, the two nostrils, the two nasal cavity. Inside the nasal cavity, these are the blood vessels. The blood vessels are like this. These are the blood vessels. Inside the nasal cavity, these are the blood vessels. Okay. Now we inhale, we exhale. Like this. So there is space. There should be space for inhalation, exhalation. So this is the space. We are inhaling, exhaling. Inhaling, exhaling. The space should be there. But suppose these blood vessels get dilated. Okay, in some time we have the rhinorrhea, some infection, so the blood vessels get dilated. Let me do dilatation of the blood vessel. I'm dilating the blood vessel. The blood vessel get dilated. Vasodilated over here, vasodilated over here. So see, the space is very much reduced for inhalation and exhalation. This is known as my nose, meri naak band ho gayi, nasal congestion. It is known as nasal congestion. In Hindi, naak band hona, nasal congestion. We want to do decongestion, so we will give the nasal spray. That causes vasoconstriction. Once the vasoconstriction is done, the space is resumed. Okay, we give the nasal spray. Okay, so that is causing vasoconstriction, shrinkage of the mucosa because of vasoconstriction, and it will cause a relief. So nasal decongestion ke liye we need vasoconstriction. Yes or no? So these are the 5 diseases where you want to give alpha agonist for doing vasoconstriction. I have shown you 5 flowcharts. See the end result of my 5 flowcharts. The end result of my 5 flowchart is vasoconstriction. So vasoconstriction in hypotension, one by one. I want to do vasoconstriction in 5 conditions. Number 1, in hypotension, in anaphylactic shock, along with local anesthesia, to control local bleeding and nasal congestion. I want to do vasoconstriction to relieve it. So these are the 5 diseases where I would like to give alpha agonist for doing vasoconstriction, and it is known as pressor agent. Okay, so that was my first use. Based on this property, I taught you 5 diseases here. You have to learn the 5 diseases over here. What are the 5 diseases? Hypotension, anaphylactic shock, local anesthesia, nasal decongestion, and to control local bleeding. Okay, you need vasoconstriction. Now, one of the use on beta agonist. Beta agonist causes, beta 1 agonist to be specific, it causes cardiac stimulation. Okay, so whenever I want cardiac stimulation in my patient, whenever my patient is in cardiac arrest, whenever my patient is in AV block, whenever my patient is in congestive heart failure, in all these conditions, I want the cardiac stimulation. So I will give beta 1 agonist. I will give beta 1 agonist because of cardiac stimulation. So cardiac arrest, AV block, and congestive heart failure. In these conditions, I want to increase the heart rate, heart velocity, and heart contractility. So I will give beta 1 agonist. That will do positive inotropic, chronotropic, and dronotropic effect. In which, name the diseases, you can give it in AV block, you can give it in congestive heart failure and cardiac arrest. You can learn the doses if you wish. Okay. Now the third use. So we have given alpha agonist whenever we want to do vasoconstriction in 5 diseases. We have given beta 1 agonist whenever we want to do cardiac stimulation in 3 diseases. You should be able to enumerate the 5 diseases here. You should be able to enumerate the 3 diseases over here. I hope you are getting it. The 5 diseases, whenever you got vasoconstriction, you want to do vasoconstriction. The 5 diseases is hypotensive state, anaphylactic shock, along with local anesthesia, nasal congestion to control the local bleeding, and the 3 diseases where you want cardiac stimulation. What are the 3 diseases? Cardiac arrest, AV block, congestive heart failure. Now, beta 2 causes bronchodilation. When you want to do bronchodilation in your patient, asthma. Okay, so asthma is the drug of choice. In asthma, we give beta 2 agonist. So we give beta 1 agonist whenever we want cardiac stimulation. Okay, a cardiac stimulatory effect. We give beta 2 agonist whenever we want bronchodilation. That is an asthma. That is the third use. The fourth use based on the eye. In the eye, it causes mydriasis. Okay, since it causes mydriasis, so we use it in fundus examination, retina examination. So whenever we go to the ophthalmologist for fundus examination, the ophthalmologist puts some drop before doing the fundus examination. So we can use alpha 1 agonist for that. Number one. And number two, since alpha 2 agonist reduces IOT, so we can use them in the glaucoma. You can use them in the glaucoma. So we use mydriasis for fundus examination and decrease aqueous secretion for glaucoma. So we are using these two. We are using alpha 1 agonist over here. Okay, so we are using alpha 1 agonist here, beta 1 agonist here, beta 2 agonist here, again alpha 1 agonist here. Now next, bladder pe both. We will take both agonist. For bladder, we will take both agonist. Alpha plus beta. Both agonist we will take. Because bladder pe, here we have beta and here we have alpha. On the bladder muscle, we have beta receptor. And on the bladder sphincter, we have alpha. What does they do? Okay, the beta relax. The beta relax. Okay, and the alpha contract the sphincter. Beta relax the muscle, alpha contract the sphincter. The overall result of both of them together is retention of urine. So whenever you want your patient to retain urine, you want your patient to retain urine? Yes. I want the retention whenever the patient is having incontinence. And I want the retention whenever there is nocturnal enuresis in the children. Enuresis is bad wetting. So in these two conditions, if a patient is coming to me, doctor, I'm having urinary incontinence, I cannot hold my urine. And then when the mother is coming, doctor, my child is 10-year-old, 12-year-old, 15-year-old, but he does bad wetting during the night. So I want to withhold the urine at the night time. So I will give alpha plus beta agonist. So what they two together do? The beta will relax the uterus, alpha will constrict the sphincter, urinary retention. Amphetamine the drug can be used here. It is alpha plus beta agonist. Okay. Now coming on the next, uterus ka relaxation. I will give beta 2 agonist for relaxing uterus. Beta 2 agonist relax the uterus. You can see here. It will relax. So whenever I want my patient to relax the uterus in threatened abortion, and if the abortion, she is pregnant and there is a threatened abortion, I want the uterus to get relaxed. I will give beta 2 agonist. Okay. Or she is having severe pain during menstruation. You know why pain during menstruation, dysmenorrhea? Because of uterus contraction. So we want to relax to relieve the pain. So in both these conditions, I want my patient, her uterus should relax. So I will give beta 2 agonist. I will give, these are the best drugs to give there. Beta 2 agonist. Okay. The last use is, CNS may beta 1 causes restlessness, apprehension, all these. So I will give in ADHD patient. I will give in obesity patient. ADHD, what are ADHD? Hyperactive children. Some children are attention deficit hyperkinetic disorder. It is known as ADHD. Attention deficit hyperkinetic disorder. It is known as ADHD. Okay. So, overall it depresses the system. So we can use these drugs. Okay. We will use the beta 1 agonist over here. You have to learn beta 1, beta 2, alpha 1, alpha 2, which one? Narcolepsy, epilepsy, Parkinsonism, and in obesity. Obesity, what does it do? It suppresses appetite center. Beta 1 suppresses appetite center. So less hunger, less obesity. Okay, less hunger. So weight loss will be there. So these are the uses in the CNS. Okay, so I taught you the classification. Now you will have a better understanding of the classification. I taught you can learn the classification once I will finish the uses. Now you can see pressor agent, cardiac stimulant, bronchodilator, nasal decongestant, anorectic, CNS stimulants, uterine. The same I taught you here. You can understand the classification and you can learn which category is given where. Okay. So I taught you 7 uses, people. You don't have to learn these 7 uses. See my 7 red markings. Can we revise? So whenever you want to do vasoconstriction in your patient, name 5 diseases. Whenever you want vasoconstriction, you give alpha 1 agonist. Whenever you want cardiac stimulation to increase, give beta 1 stimulant, beta 1 agonist. In 3 diseases, you want to increase the cardiac stimulation, cardiac arrest, AV block, and congestive heart failure. Whenever you want to do bronchodilation in your patient, like in asthma, give beta 2 agonist. Whenever you want to relax the uterus of the patient, like in dysmenorrhea and threatened abortion, you give beta 2 agonist. Okay, whenever you want to do urinary retention, give alpha and beta both agonists, like in urinary incontinence and enuresis. Okay, whenever you want to do mydriasis, like for fundus examination, and decrease aqueous secretion, like glaucoma. So fundus examination and glaucoma, you give alpha 1 agonist. Okay, and in CNS, the 5 diseases you have to learn: narcolepsy, ADHD, obesity, Parkinsonism. In all these, we give beta 1 agonist. So alpha 1, alpha 2, beta 1, beta 2, which agonist? Just a second, I have to put it on charging. I cannot see your comments. Just a second. So this is, there are 7 uses. You can see the 7 uses. Okay, now coming on contraindication. Only 2 contraindication. You can see here. I will mark both the contraindication with blue color. Number 1 contraindication, if the patient already having high BP, severe high BP, never ever think of giving alpha agonist. Don't give alpha 1 agonist. BP is already high. If bleed can occur. So don't give the BP is already high. And the second contraindication, if the person is having tachycardia, if the person already in ventricular tachycardia, if the person already in tachycardia, don't give beta 1 agonist because it will further increase the heart rate and the person can die. Okay, so don't give alpha 1 agonist in high BP, and don't give beta 1 agonist in ventricular tachycardia. So ventricular tachycardia will be a contraindication for beta 1 agonist, and high BP is a contraindication for alpha 1 agonist. So we have two contraindications over here. So the uses and contraindication. This is a contraindication for alpha 1 agonist. This is a contraindication for beta 1. So mind the receptors. If you try to mug up, I cannot mug, I don't know about you. If you try to mug up, na, ki this is a use based on this, you can't. I can't, I mean. Okay, you have to learn this table. From this table, everything is simple and you can understand in a very easy language, and you can answer the why for all of them. So I have completed the third chapter, adrenergic drugs, in which I taught you 7 uses and 2 adverse effects or contraindication, whatever you say. You can appreciate the 7 red and the 2 blue markings in this table. And my pattern is this: learn this table. The good things are the uses, the bad things are adverse effects. This is my pattern. I hope you all are getting it. Okay, now coming on the last chapter, the fourth and the last chapter, complete. I promised you complete ANS in one shot, just on 4 pages. So this is my fourth master chart. So antiadrenergic drugs, I taught you cholinergic, I taught you anticholinergic, I taught you adrenergic, and now I'm moving towards the antiadrenergic drugs. So let's start antiadrenergic drugs. Can I start? Tell me the definition. One by one we will start. Tell me the definition. Okay, tell me the definition. Here I will teach you 2 chapters, alpha and beta blocker. First alpha blocker, then what is antiadrenergic drug overall? Antiadrenergic drugs are the drugs that block alpha receptor or beta receptor. The one who block alpha receptor are alpha blocker. The one who block beta receptor are beta blocker. We will take them separately. Agonist we have taken together, but antagonist, I mean blockers, we will take separately. So these are the competitive antagonists or blockers of alpha or beta receptor. So the natural noradrenaline cannot bind with its receptor. If alpha is blocked, it cannot bind with alpha. If beta is blocked, it cannot bind with beta. So whatever noradrenaline is supposed to do on this organ, that will not happen. The opposite of that will happen. And that is the action of antiadrenergic drugs. Are you getting it? So that is the action of antiadrenergic drugs. Yes, just a second. Okay, so let's try. So there are 2 categories. We are having alpha blockers that blocks the alpha receptor. We are having beta blockers that block the beta receptor. Let's start them one by one. You can see 2 columns over here. So I have to teach you 2 chapters right now. Let's start alpha blockers quickly. What is the definition of alpha blockers? You already know. Alpha blockers are the drugs that block alpha receptors. So here alpha is blocked, beta is not blocked. So if the noradrenaline is released here, it can bind with beta, but it cannot bind with alpha. So whatever it was supposed to show on alpha, the opposite of that will happen. Okay, and that will be the alpha blocker. Now you are understanding, it is not actively doing opposite. Okay, so in this table, okay, so you have to do the opposite. When I'm teaching you alpha blocker, do opposite of this. And when I will teach you beta blocker, my next chapter, the last chapter, do opposite of this. So this table is master table. In agonist, you have taken them together. In alpha blocker, you will do the opposite of this, reverse of this. And in beta blocker, you will do the reverse of this. Okay, so this table is the master table. So currently, I'm teaching you alpha blocker. You know the definition. Alpha blockers are the drugs that block the alpha receptor, not the beta. So mechanism of action may the reverse will happen. Coming on the classification of alpha blocker. So we are having 3 type of alpha blocker. You can see non-selective that block alpha 1 and alpha 2 both, and selective only alpha 1, only alpha 2. So the 3 category, alpha 1 plus alpha 2 together, non-selective blocker, selective alpha 1 blocker, selective alpha 2 blocker. Selective alpha 1 में prazosin, terazosin, doxazosin. These are important. Prazosin, terazosin, doxazosin. And alpha 2 selective में yohimbine. Yohimbine is selective alpha 2. So learn selective alpha 1, learn selective alpha 2. Non-selective में again reversible, irreversible. Reversible में phentolamine and irreversible में phenoxybenzamine. You have to learn at least prototype. Here only one drug. Here learn at least 3, learn 1. So the classification is easy. How many blockers we have? Alpha blocker. Alpha blocker में we have non-selective. We have alpha 1 selective, alpha 2 selective. Non-selective blocker, alpha 1 blocker, alpha 2 blocker. Non-selective में we have again 2 category, reversible, irreversible. Okay, so alpha 1 में we have prazosin, terazosin, doxazosin. Alpha 2 में we have yohimbine. Here we have phentolamine, and here we have phenoxybenzamine. So this is how you have to learn this classification. So you know the definition, you know the classification. Mechanism of action also you already know. What is the mechanism of action? Obviously, naam mein hai, as the name indicates, alpha blocker block alpha. obviously. Alpha blocker, what else will do? It will block alpha. So you can see if I'm giving alpha blocker to my patient, it will block the alpha receptor. So the noradrenaline present here cannot bind with alpha. Okay, so whatever it was supposed to do on the alpha, the opposite of that, the reverse of that will happen passively. So it will prevent the natural noradrenaline to bind with alpha. So whatever it was supposed to do on alpha, the reverse of that will happen passively. So that is, you have to do reverse of this table. Whatever written, consider reverse in your mind. Okay, so if alpha was doing vasoconstriction on the blood vessel, alpha blocker do vasodilatation. Similarly, alpha was causing mydriasis, active mydriasis, it will do passive meiosis. Okay, so whatever alpha was doing contraction, it will be relaxation. So whatever written here, just reverse it, and that will be your alpha blocker. Give me a minute. Let me open the comment box. I hope I'm live. Am I live, people? Just a second. I guess I am. Yes. Okay. Got it. Yes. So let's move. So I told you definition, classification, mechanism of action. Can be revised? Then we will move on the pharmacological action. What is alpha blocker? Alpha blocker blocks alpha receptor. Okay. That's the definition. Classification, it is non-selective. Selective alpha 1 blocker, selective alpha 2 blocker, and you know the drugs in each category. Mechanism of action, since it blocks the alpha receptor, so what it prevent noradrenaline to bind with alpha blocker, since alpha is already blocked. So noradrenaline, whatever supposed to do on the alpha, it will not do that action, and opposite of that action will happen passively. So that is the mechanism of action. I use the word passively. Okay. Now coming on the pharmacological action, just do reverse of this table. Now one by one, we will quickly reverse. So on blood vessel, noradrenaline bind with alpha 1 and cause vasoconstriction. Since alpha 1 blocker block the alpha 1 receptors on the blood vessel, so vasoconstriction will not happen. Passive vasodilatation will happen. And that's why there will be fall in BP. That's why alpha 1 blocker causes hypotension, and they are used as antihypertensive drug. They cause hypertension, you can see. That's why they are used as antihypertensive drug. Sometimes they can cause dizziness and syncope if they've caused more fall in hypertension. Okay, this I've already explained you. You know the adrenaline receptor. Say yes. I have already explained you. Adrenaline have agonist activity for how many receptor? Adrenaline show agonist activity for alpha 1, alpha 2, beta 1, beta 2, but not for beta 3. And you already know my crux. I have already explained in the last chapter. So since it is having alpha 1 agonist, it increases DBP. Since it is having beta 1, so on one hand, it is increasing SBP. And since it is having beta 2, on other hand, it is decreasing DBP. So DBP increasing or decreasing? Actually, it will be neutralized. So initially at high dose, it will be increased DBP. And later on at low dose, it will be decreased DBP. So it is a triple response. I've already explained you, it will be a triple response. So initially, as soon as you give the alpha 1 predominant at high dose, and later on, once it will be washed off from the blood, beta 2 predominant. Okay, so first DBP increase, then decrease. So if you are giving me an adrenaline injection, so first BP will rise, then it will normal, then it will fall. Okay, this is the normal triple response of the adrenaline. But so how this rise is due to alpha 1, because at high dose alpha 1 predominant, and the fall is due to beta 2. Okay, because at low concentration beta 2 predominant. I told you. Now prove it. For proving, we are giving alpha blocker injection followed by adrenaline. First you give me alpha blocker, alpha 1 blocker. You know the alpha 1 blocker, prazosin, terazosin, toxazosin. So first you give me that injection, and then you give me adrenaline injection. So if the alpha 1 receptors are blocked, so directly after giving injection of insulin, my BP will fall. It will not rise. It will only fall. It is not rising because alpha receptors are blocked. So rise was due to alpha. So it is not rising. It is just falling, and it is known as vasomotor reversal of Dale. I have already explained you since I'm teaching you alpha blocker here. So alpha don't have any action of heart. A little action is there. It increases the contractility a little bit. Main contractility increases due to beta, a little bit due to alpha, a little bit due to alpha. So reflex tachycardia is there, but main action is not there. The next is eyes. On eyes, what does alpha do? And what does alpha blocker will do? Alpha causes active mydriasis. So alpha blocker will cause meiosis, passive meiosis. Alpha agonist was causing active mydriasis. So opposite of that will happen. Okay. The alpha blocker will cause passive meiosis. I have already explained you in the first chapter. Okay. So this you can understand from here. In the eyes, GIT may, what alpha receptor was doing? I mean, what noradrenaline do? Just do opposite of that. Noradrenaline causes retention. It relax the muscle, constrict the sphincter. It will do opposite. It constrict the muscle, relax the sphincter. Okay, it constrict the muscle, relax the sphincter. So noradrenaline, shall I draw it or you got it? So suppose this is the intestine. and this is the bladder. And this is the sphincter of both of them. Okay. So alpha is mainly present over here. I'm sorry. Alpha is mainly present over the sphincters. Okay, so normally noradrenaline when come in emergency in my blood. Okay, so noradrenaline comes in emergency. So it goes and bind with the alpha, it goes bind with the, and it constrict the sphincter. It constrict here sphincter, it constrict here sphincter. So in emergency, no defecation, no urination. During emergency, we all know that. Now give a drug alpha blocker. Alpha blocker. Alpha blocker will come and block here. Alpha blocker will come and block here. So noradrenaline when coming, it cannot bind because the receptor is already blocked. Alpha blocker have already blocked this receptor. So noradrenaline cannot bind here, cannot bind here. So this will not constrict, it will relax. This will not constrict, it will relax. So defecation happen. Okay, and urination happen. So with alpha blocker, the defecation and urination happen. So here loose motion, defecation happen, and here urination. Urination, the urine flow will improve. Urination will happen. So it will be useful in BPH patient. You can understand it from here. If you know the basics, everything is very easy. In male sex organ, it is alpha was causing, noradrenaline binding with alpha 1 receptor causing ejaculation. It will inhibit ejaculation. Alpha blockers will it will block the alpha receptors on male sex organ. So it will inhibit ejaculation. So impotency is a side effect of alpha blockers. Impotency is a side effect of alpha blockers. So I taught you all the pharmacological action. Actually, all are written over here. You have to just reverse it. This column, you have to reverse it. We have quickly seen it. Now, the good things are uses, the bad are adverse effect. We will take 8 good and 5 bad. We will mark the good one with red color and we will mark the bad one with the blue color. One by one, we will see. Let's come on the uses of alpha blocker. Very easy. There are 8 uses. One by one, I will show you. The first is hypertension. You can understand, out of the 8 uses, 7 of them are related here and only 1 is related here. Total 8 uses are in front of you. 7 of them are based on this property and 1 of them is based on this property. Okay, the first 7 uses I will come. These 7, you can see. These 7 uses are based on one property, that alpha blocker causes vasodilation. Because noradrenaline or alpha causes vasoconstriction, so alpha blocker does the opposite of that, that is vasodilation. So in hypertension, we want vasodilation. In pheochromocytoma, we want vasodilation. In shock, we want vasodilation. In peripheral vascular disease, PVDs, like Raynaud's disease and all, we want vasodilation. In congestive heart failure, we want to reduce preload, we want vasodilation. In prinzmetal angina is due to vasospasm of the coronary, we want vasodilation. Male impotency, I will explain why we want vasodilation in male impotency. So the principle of all these to treat these diseases is vasodilation. In all these diseases, something is happening. I will teach you the pathology of all these diseases, but to treat all these diseases, we need vasodilation, and that's why we are giving alpha blocker, since alpha blocker causes vasodilation. Okay, noradrenaline or alpha causes vasoconstriction, and alpha causes the opposite of that, that is vasodilation. So these 7 properties, these 7 diseases based on the property vasodilation. One by one I will prove. Okay, these 7, one by one I will prove. The first is hypertension. Obviously, common sense. In hypertension, you want vasodilation. Okay, so in hypertension, if the patient is coming to you with hypertension, you want vasodilation or vasoconstriction? You want vasodilation. So you can give alpha blocker. For example, you can give prazosin, alpha 1 blocker. Give alpha 1 blocker. Okay, here alpha causes vasoconstriction, alpha 1. You block it, so it will be vasodilation. So vasodilation and fall in BP. So this we don't have to prove. What is pheochromocytoma? What do you mean by pheochromocytoma? Pheochromocytoma is a tumor of adrenal medulla. This is adrenal medulla. Adrenal cortex, adrenal medulla. It's a tumor of adrenal medulla. Suppose it is a tumor in the adrenal medulla, it secretes abundant of noradrenaline in the blood. So there is flush of noradrenaline in the blood. And what is noradrenaline? And suppose this is blood vessel. This is blood vessel. On the blood vessel, we are having alpha 1. This noradrenaline will come and bind with the alpha 1 and causes vasoconstriction. So in pheochromocytoma, BP is very high. BP is very high. You know the reason? What is pheo? You have to understand what is pheo. Pheo is a tumor of adrenal medulla. Adrenal medulla may noradrenaline get synthesized. Since adrenal medulla may tumor, so abundant flush, flood of noradrenaline will come in the blood. Abundant of noradrenaline. So now noradrenaline will go to all organs, but it will go to blood vessel also. In the blood vessel, in the media, we are having alpha 1. It will bind with the alpha 1 causing vasoconstriction. So severe high BP. Patient have high BP. Okay, very high BP. You want to reduce it. Okay, so the cause is pheochromocytoma. You give alpha blocker. So this alpha 1 will be blocked with the alpha blocker. So even if the blood is having high concentration of noradrenaline, that noradrenaline cannot bind with alpha 1 now. So BP will not rise. It will fall passively. So this is how in pheochromocytoma it is useful. You can read it by your own. So this is how in pheochromocytoma, whenever there is a tumor in the adrenal medulla, you can see here the adrenal. The tumor is in there, so it is secreting lots of noradrenaline in the blood, causing high BP. If you want to reduce this BP, this drug will be useful here. Okay, got it? Now, secondary shock. In secondary shock, there is reflex vasoconstriction. If you want to save the patient, do vasodilatation. Do vasodilatation. So, in reflex shock. What is peripheral vascular disease? In peripheral vascular disease, the blood vessel is inflamed. The blood vessel is inflamed. Okay, when the blood vessel is inflamed, you want to treat it, you have to relax the blood vessel. Do vasodilatation. Okay, the recovery will be fast. Okay, like in Raynaud's disease, there is vasoconstriction. So, if you want to treat the wall of the blood vessel, relax it. So, vasodilatation. If you are doing vasodilatation with alpha 1 blocker, the person have relief. The person have relief. Congestive heart failure. We want to do vasodilatation of the veins. Okay, so that preload is less. What is congestive heart failure? The heart is weak. You want to reduce preload as well as afterload. I assume you know what is preload, afterload. If not, please watch my CVS drug lecture. So preload, you want to reduce preload as well as you want to reduce afterload. Preload depends on venodilatation and afterload depends on arteriodilation. The alpha 1 blocker do the dilatation of both. So it will dilate the vein as well as artery. So preload also reduced, afterload also reduced. If the heart is weak, it will be useful. So congestive heart failure, it is useful. We give alpha 1 blocker that causes vasodilatation. It reduces preload as well as afterload. The next is transmental angina. What is transmental angina? This is coronary of the heart. The heart, we are having 3 coronary arteries, right coronary artery, left circumflex, left anterior descending. If there is a vasospasm in the coronary, there is transmental angina. There is severe chest pain. Okay, that is angina. Angina is chest discomfort. So that is angina. So what treatment you would like to offer? We want to vasodilate this coronary. The problem will be solved. For vasodilatation, give alpha blocker. In transmental angina, the coronary is in spasm. Give alpha 1 blocker. That will cause vasodilatation. Okay, so coronary spasm will be relieved. So I taught you 6. This is the 7th one. Okay, in all of them, I have highlighted one word in my flowchart, that is vasodilatation. I'm explaining in all these diseases how vasodilatation is useful. Okay, so see my flowcharts in the notes in the workbook very closely. I have provided you the workbooks. In my workbooks, please see this red marking very closely. Vasodilatation in all these 7 diseases. Now, this one is difficult to understand. Male impotency due to erectile dysfunction. What is erectile dysfunction? This is penis, the male sex organ. You can see. Okay, how does the penis get erect? How does during sexual intercourse, how does the penis get erect? How? Inside the penis, these are the blood vessels, these are the sinusoids, these are the blood vessels. Okay. Whenever vasodilatation takes place, now here the blood vessels are constricted. Whenever vasodilatation takes place, now all the blood vessels inside the penis, you can see they are dilated. So penis get erect. So for erection, vasodilatation is required. Vasodilatation is required. Now so this occurs physiologically. This occurs physiologically in males during sexual intercourse. So during sexual intercourse, it occurs physiologically, but in some males, it's unable to happen. It's unable because the blood vessels inside the penis of such males from vasoconstriction, they don't vasodilate during sexual intercourse. So this disease is known as erectile dysfunction. Okay, this disease is known as erectile dysfunction. Being a doctor, we want to treat this person. So if we want to treat this person, what treatment logically you would like to offer? So we want to vasodilate the blood vessels inside the penis anyhow. So we will give injection inside the penis. Yes, the injection of the penis inside the penis, alpha 1 blocker. What does alpha 1 blocker do? Alpha 1 blocker causes vasodilatation. Okay, so here we are giving the injection. You can see here we are giving in erectile dysfunction, we want to dilate the penile blood vessels. So to correct the erectile dysfunction, the penis cannot erect. We want to erect it to treat the patient. So we will give intrapenile injection of phentolamine. That will cause vasodilatation of penile blood vessel and produce the erection. So before the sexual intercourse, patient can give this injection, but it is not commonly used because sildenafil, I will teach you sildenafil also in CVS, that is available as oral form. So oral tablets are obviously more comfortable as compared to injections in the penis that will be painful and troublesome, and that needs expertise. Patient cannot give the injection to himself. So these are theoretically it's good, but practically it is not given for this purpose. And sildenafil is available, and sildenafil is having different function. I will teach you. So that is available for the erectile dysfunction. So it is not used practically, but you should understand the concept, how it can be used. Okay. But the risk of priapism, is very high. That's why it is not. It needs a specialist to give this injection, and repeated injections are required, and repeated injection can cause the penile fibrosis. So nowadays sildenafil is preferred and this injection is not given, but theoretically you should know. So I taught you seven uses based on the property vasodilatation. Tell me the 7 diseases when you want the vasodilatation in your patient and you are giving alpha blocker to cause the vasodilation in your patient. And the last 8th use is based on the bladder. In the bladder, what does the alpha blocker are doing? It is used in BPH. Tell me the disease BPH. What is the disease BPH? Benign prostatic hyperplasia. Can you explain this disease to me? What is benign prostatic hyperplasia? See, we are talking about the male. Prostate is a gland present only in male, not in female. This is the bladder of a male. From the bladder, you can appreciate the urethra is coming out, the urine comes out. The urine comes out of the urethra. Okay, now suppose here the bladder is full. Bladder is full, and you can appreciate the gland. The gland is spherical around the urethra. So inside the gland, there is a hole. There is an opening from which the urethra is passing inside the gland. You can see in the diagram. So it is the natural alignment like this. It's a normal prostate. So, there is enough space in the urethra. This urethra is like a, pipe from which the urine is coming out. So when the bladder muscle contract, and here the sphincter relax. Okay, bladder contracts, sphincter relax, the urine pass out. The passage is clear. But suppose the prostate gland enlarge, BPH, prostate gland, I teach you in pathology how does it occurs pathologically. So when the prostate gland enlarge, it is compressing the urethra. Appreciate the urethra. Urethra hardly get compressed. There is very less passage. So even these patients, these are old males, grandfather age. So they are contracting their bladder, they are relaxing their sphincter, but urine come drop by drop. It is known as dribbling of urine. So when a grandfather age patient like 70-80 years old coming and complaining, doctor, my urine don't come in one flow, it come drop by drop, and I need hour to empty my bladder. It's a typical disease, BPH. We can do the biopsy, we can confirm, or it can be prostate carcinoma. In both of them, the in BPH it's more common. The prostate size is enlarged and is compressing. It is compressing the urethra. Now I will give alpha blocker over here that will not treat the basic etiology. Alpha blocker do not, please understand, alpha blocker do not constrict the prostate. It will not act on prostate. Alpha blocker has no action on prostate. Say, ma'am, then how alpha blocker will help here in BPH? You are saying in BPH the basic problem is increased size of the prostate that is compressing the urethra. So urine, the passage is not clear. The passage is compressed. So when urine is passing from bladder to urethra, it is passing through a narrow urethra. Here the urethra is clear, and here the urethra is like that, very narrow. So here urine will come in one flow from bladder. Okay, here urine come very drop by drop, it's very compressed. So here it has no action. The alpha blocker have no action on the prostate, but alpha blocker increase the contractility of the bladder and increase the relaxing power of the sphincter, both ways. So it don't treat the primary etiology, mind my words, but yeah, it is helping symptomatically to BPH patient to pass the urine. The ultimate treatment is the surgery. Via surgery, the prostate has to be reduced so that the urethra again dilate and the urine can pass. So till the patient goes for the surgery, or some patients reject the surgery, or in old age sometimes surgery is not possible, so we give this. Okay, so what the alpha blockers are doing here? Alpha blocker constricting the bladder more and relaxing the sphincter more, constricting the bladder and relaxing. But here the narrow passage is still there. Okay, but it helps sometimes symptomatically to pass the urine in one flow, or relatively better flow, I can say. Okay, so in BPH, this is how for increasing, for dynamic component, we are giving alpha blocker that relax the sphincter basically and contract the muscle. I hope you are getting it. Yes. So this is in BPH. So in BPH, we use these drugs. Alpha 1A selective. You can learn the drugs. It is tamsulosin and saludocin. We use these drugs when the primary treatment is the surgery. If the prostate is enlarged, you have to take it out. So, but we can give these drugs. So tell me the 8 uses. 7 based on vasodilatation and 1 based on bladder sphincter relaxation. Bladder ka sphincter relaxation. So total 8 uses are in front of you. So these 7 uses are based on vasodilatation, action of alpha blocker, and BPH the use is based on sphincter relaxation. It is not treating the primary etiology, it is relaxing the sphincter so that the urine can pass easily, contracting the muscle a little bit and basically relaxing the sphincter. So these are the 8 uses. Here I have drawn 7 flowcharts. In my all flowcharts, I have highlighted one word. See in the workbook, if you have received, we will send you vasodilatation. The ultimate thing is the vasodilatation. Okay, so how vasodilatation is helping in all these diseases, I have explained you in the flowchart. Okay, in all these diseases, there is vasoconstriction, which is causing the trouble, which is causing the disease, which is causing the etiology of the disease, etiopathogenesis of the disease. So doing vasodilatation will be useful in these diseases, and that's what the alpha blockers are doing. So alpha blockers causing vasodilatation, helping in these 7 diseases. You should be able to explain in the flowchart. And alpha blocker relaxing the sphincter and giving symptomatic relief in BPH, not the main cure. So this you should be able to explain with the help of the flowcharts. Okay, draw my flowcharts. My unique way of teaching is the flowcharts, people. Yes or no? People say, am I live? Say, got it. So we are done with the 8 uses. Now 5 adverse effects or contraindications. So we are done with the red markings. You can appreciate my 8 red markings. You say, ma'am, where is 8? You can appreciate 7 are here. You can appreciate 7, and this is the 8th one. So 8 red uses. Now coming on 5 adverse effects. So 5 blue markings. These are the 5 blue markings. Alpha blocker. Okay. Don't give alpha blocker if the patient is having problem of postural hypotension. You know what is postural hypotension? What do you mean by postural hypotension? Whenever we wake up from supine position to standing position, this is supine position. You know, whenever we sleep, we shouldn't stand like this in the morning after sleeping. We should take, you know, a curvet. You know, we should turn to one side and then wake up. This is a wrong posture. If you are suddenly raising, you know, gravity is always functional, whether we are aware or not aware. Newton ka gravity, the apple falling, it's always functional. So whenever you wake up suddenly, the out of the 5 liter of blood, most of the blood, the gravity will attract and it will go in the leg veins, so brain will receive less blood and you will feel fall of blood and you will have syncope, and that's known as postural hypotension. So whenever we wake up like this, from this to this, you know, most of the blood due to gravity, it will go here, and you know, so blood pressure will fall. It is known as postural hypotension. So brain will receive less blood and we feel, and many times you may have feel, but it's okay. The God is always great. God has given a backup mechanism. You know, as soon as the BP fall, in all body, the blood vessel, as soon as the BP fall, as soon as we feel like this, everywhere in the body, the alpha receptors get activated. Okay, noradrenaline will come in emergency. Noradrenaline is always ready like a guard. As soon as emergency come, it comes in the blood. So noradrenaline will come in the blood. It will bind with the alpha receptor, cause vasoconstriction, and again rise the BP. So many times I also feel it. I guess you may have also experienced. Whenever we change the posture, we feel little bit dizzy, but within a fraction of second, everything is restored. So this is postural hypotension, and thankfully God has given this backup mechanism in us. Now suppose this problem is very frequent in some patients. Okay, and you are giving alpha blocker to them to treat some other disease. I taught you the 8 uses. Out of the 8 uses, patient is having any of the disease, and you're giving alpha blocker to treat that disease. So this problem will exaggerate. Postural hypertension will exaggerate because, you know, the BP is restored because of alpha receptor, and you are blocking the alpha receptor to treat some other disease. So whenever the patient wake up, there is no back, you block that backup to treat some other disease in your patient. So postural hypertension can be the problem because you are blocking the alpha. So whenever the patient arise from supine to erect position, you know, vasoconstrictive backup mechanism because of alpha 1 will not come in role, and patient will have postural hypertension. So that can be the one side effect. Second is nasal blockage. What does it do? So out of the 8 uses, the 7 uses are based on vasodilatation. You can't forget alpha blocker cause vasodilatation. Alpha blocker, okay, normally alpha causes vasoconstriction, so alpha blocker causes vasodilatation. Okay, so whenever we give alpha blocker to the patient, this is the nose, this is the septum of the nose, the 2 cavities in the nose. So it causes vasodilatation in the blood vessels. Here, the blood vessels also. It causes vasodilatation of these blood vessels. Vasodilatation. Okay, so very less space is there. Very less space. So alpha blocker, the patient on alpha blocker usually feel nasal stuffiness. So that can be the side effect. Nasal blockage, nasal stuffiness. Palpitation can be the problem because you will say, ma'am, alpha don't have any action on the heart. Why you are saying palpitation? Because of reflex tachycardia, I told you. Loose motions can be the problem. You can see here because alpha blocker is contracting the muscle and relaxing the sphincter. So motion pass. So loose motion can be the side effect, and impotency, inhibition of ejaculation. Okay, alpha causes ejaculation. Alpha blocker causes inhibition of ejaculation, and that's impotency. Now, it's very irony if you want to understand. In the uses I told you, alpha blocker are given as a treatment for erectile dysfunction, but they themselves cause ejaculation impotency. I don't know whether you understood or not. For sexual intercourse, 2 things are there in the male sex organ. First, erection, followed by ejaculation. Okay, this is in a sequence. Okay, now I'm saying the alpha is required for ejaculation. Okay, so alpha blocker cause ejaculation impotency. Alpha blocker, they inhibit ejaculation, so impotency. But alpha blocker are given in the treatment of erectile dysfunction. I have explained via blood vessel. Okay, so for erectile dysfunction, we give alpha blocker. But what is the use? You will correct erection, so ejaculation problem will occur. So alpha blocker are not given for impotency. For erectile dysfunction, I told you sildenafil will be preferred. This is one of the reasons. I hope you got the 5 adverse effects. No need to learn if you have understood the concept. My complete session is full of bombarding of concepts. Not of mnemonic, not of rectification, not of one-liners. It's full of concepts if you are understanding and enjoying. So I taught you the 5 adverse effects. Now, the summary of alpha blocker. Alpha blocker. Appreciate the uses, appreciate the adverse effects. People, appreciate the uses, appreciate the adverse effect. So 8 uses, 5 adverse effect. 8 red markings, 5 blue markings in this column. Reverse this column. This is alpha. You do alpha blocker, reverse the actions written here, just reverse and see the 8 red and 2 blue. We are done with the uses and adverse effect of the alpha. Okay, now the last chapter. I'm teaching you the fifth and the last chapter. I started my session from cholinergic, then I came on anticholinergic, then I taught you adrenergic. In adrenergic, I taught you alpha beta agonist together. Then I taught you alpha blocker and antiadrenergic. Now antiadrenergic, my last chapter, beta blocker, the fifth and the last. So complete 5 chapter. In the end, I will show you just on 4 pages. That's my promise at the beginning. So let's come on my last chapter, beta blocker. We are done with alpha. Now let's come on my last chapter, beta blocker. Let's come on beta blocker quickly. Another 20 minutes. Quickly we will come. Now you got the pattern now. So it's very easy. Let's come on beta blocker. The same headings, my master chart. Say. So let's start with the definition of beta blocker. What's beta blocker? Beta blocker are the drugs that block the beta receptor, obviously, as the name indicates. So you can see these are the drugs that block the beta receptor, so that the natural noradrenaline cannot bind with the beta receptor. Since the natural noradrenaline cannot bind with the beta receptor, whatever action it was supposed to show on this organ, that cannot show that action. So opposite of that action will happen passively, and that's the action of beta blocker. I hope you got it. So you got the definition: beta blocker block beta. Anna, beta blocker block beta. What is the classification? The classification of beta blocker again in front of you. Non-selective block beta 1 as well as beta 2. Okay. And this is beta 2 select. There are 2 type of classification and you have to learn both. The 2 type of classification, one above, one below. See both classifications. First see above. This is non-selective, beta 1, beta 2 both, and this is beta 2 selective. Because beta 2 is present on heart and kidney. Rest everywhere we have beta 1. I told you. Yes or no? This is beta 1 is present on heart and kidney. Rest everywhere it's beta 2. This is beta 1 selective. That's why it acts on heart and kidney. That's why it is known as cardioselective. So we have 2 type of beta blocker. Okay, beta 1 plus beta 2 and only beta 1. Beta 1 plus beta 2 or only beta 1. That is cardioselective because beta 1 is exclusively present on heart and kidney. This ISA is intrinsic sympathetic activity. I will explain what do you mean by that. Intrinsic. So this is without intrinsic sympathetic activity. This is with intrinsic sympathetic activity. And this is alpha blocking property. What is intrinsic sympathetic activity? Actually, sometimes beta blocker are big. They have little bit beta agonist activity also. Say, ma'am, you are saying 2 contradictory things. You are saying beta blocker or beta agonist. Yes, main property is beta blocker, but a little bit beta agonist also. So the beta blocker with beta little bit, not main. Main is beta blocking, but a little bit beta agonistic activity. That beta agonistic activity is known as intrinsic sympathetic activity, ISA. Intrinsic. So these are the blocker. They have only blocking activity, no sympathetic activity. And these are the blocker. Along with blocking activity, they have little bit sympathetic activity also. And they have with beta blocking, they have alpha blocking also with beta blocking. So these are the 3 categories you have to learn. So here you have propranolol, sotalol, timolol. Here we have pindolol. Here we have labetalol and carvedilol. All of them are lol. Okay, got it? Cardioselective you can learn. Cardioselective is only beta 1 blocking. Selective beta 1 blocking. It is metoprolol, atenolol, acebutolol, bisoprolol, ismolol, betoxylol. You can learn. Okay, all are lol. So this is one of the classification. The other classification is first generation, second generation, third generation. If you want to learn. Okay, so first generation is non-selective. All the non-selective will come here. Second generation is cardioselective. They will come here. And third generation is with alpha blocking or vasodilator activity. So these are the special one. So we are merging the 2 classification. If you want to go with one, learn above. If you want to learn both, it's your choice. So please, again, my advice, take the printout, the 60-page printout I am having. Take it one side printout, not both sides. Stick it on your wall. Wherever you stay, in your hostel, in your room, wherever. So while eating, sleeping, just look at that. Don't try to, intentionally learn that. The drugs will automatically fit in your mind that which drug is coming in which category. Mind my words. Please take them seriously. We are done with definition. We are done with classification. Definition, beta blockers are the drugs which block beta receptor. Classification, we are having non-selective beta blocker and beta 1 selective. Non-selective we are having with intrinsic activity, with ISA, without ISA, and with alpha blocking property. And you should know them separately. Now coming on mechanism of action. Tell me the mechanism of action. I have already told you the mechanism of action. Say, what is the mechanism of action? Beta blocker block beta receptor. So this is beta blocker blocking the beta receptor. Okay, the beta receptor is blocked. Now this is noradrenaline. Noradrenaline cannot bind with its beta receptor. So noradrenaline, it is preventing the noradrenaline, the natural noradrenaline, the endogenic noradrenaline to bind with the beta receptor. So noradrenaline, whatever supposed to do on this organ, it cannot do that. And the passively opposite of that action will happen. And that's beta blocker. So it is preventing It is preventing the natural noradrenaline to bind with the beta receptor. So whatever it was supposed to do, the opposite of that will happen. Okay. So what are the pharmacological action? Reverse this column. You learn this, people. This is the God's table. If you are learning this, the 5 chapters are at the tip of your tongue. It's very easy. And this is the God has given these receptors in our body from head to toe. It's fact. We cannot deny it. Wherever we have alpha 1, alpha 2, beta 1, beta 2, beta 3, you have to learn that list and just apply on the drugs. It's as simple as mathematics. In mathematics, we don't learn the calculation 2 plus 3 is equal to 5. We don't learn that. We calculate instantly, right? So we know how to do that. Similarly, here just learn this chart and apply that instantly. You know, the alpha blocker, the beta blocker, the alpha agonist, the beta agonist, cholinergic, anticholinergic. So you have to just apply like mathematical calculation. You just learn the rules and regulations, how it is done, and you just do it spot on spot. This is my advice. So it will be a conceptual learning. Anyways, come back. The pharmacological action, I'm teaching you the last chapter, beta blocker, right? Beta blocker may just reverse this column. Whatever written, you reverse this column. Because in this column, I have written what noradrenaline, when bind with beta receptor, is supposed to do. Now, noradrenaline is unable to bind with the beta receptor. So opposite of that will happen, whatever written. You think in your mind the opposite of that. So let's start one by one. So let's start first, blood vessel. Blood vessel pain. Now please see the irony. It's very complicated. See the irony. What beta do on blood vessel? Say ma'am, vasodilatation. So what beta blocker will do? Opposite of that. Say ma'am, vasoconstriction. Say or not? Obviously. Hana? Beta do vasodilatation. Say yes. Beta do vasodilatation. When noradrenaline combined with the beta 2 on the blood vessel, it do vasodilatation. Now you are giving beta blocker. So noradrenaline is unable to bind. So vasodilatation will not happen. The opposite of that will happen. That is vasoconstriction. Okay, we all got that. But still, vasoconstriction will happen. Still, we give beta blocker as drug of choice. One of the drug of choice for hypertension. Say ma'am, you are saying ki beta blocker causes vasoconstriction. I have proved in the table. Okay, I am saying beta causes vasodilatation. Yes, it is written in my table. See. Beta causes vasodilatation. Dekho everyone. See, beta causes vasodilatation. So beta causes vasodilatation. We understood it is written in the table. So obviously beta causes vasodilatation. So beta blocker will cause vasoconstriction because it will inhibit the noradrenaline to bind with the beta. Obviously. But this is true. We understood. This is true. We understood. But you are saying ki beta blocker is given as drug of choice in hypertension. Ma'am, how come? You may be thinking, ma'am, how come? Are you crazy? How it can happen? It's already causing vasoconstriction. So how you can give it in hypertension? In hypertension, it will further cause vasoconstriction and increase the BP rather than decreasing. If the patient is coming with hypertension, being a doctor, I want to reduce its BP. So how I can give a drug that causes vasoconstriction? But still we do it. Beta blocker are the first choice of drug. Now, can you explain this irony? Can you explain this paradox? People say yes, no, but say something, respond. Come on. So I'm having explanation for that. Let me tell you first question, then the answer. See, first you understand the question. Now, beta blocker, they block the beta 2 receptor. Okay, beta 2 receptor used to do vasodilatation. Okay, they block that. So vasodilatation will not happen. The opposite of that will happen, vasoconstriction. I agree. But still, fall in BP in hypertension is due to beta blocker only. Now, in hypertensive patient, we give beta blocker. But the mechanism is not this. See, I have done 1 red marking and 2 purple markings. Okay, because of red, the beta blocker is causing vasoconstriction. I agree. Okay, but see the 2 purple. Because of this 2 purple, we give them in hypertension. See, beta blocker causes cardiac stimulation. So beta blocker reduces the cardiac contractility. And that is how we are controlling BP. Okay, beta causes renin increase in blood. Beta blocker reduces renin in the blood. Reduces renin means reduces BP. Okay. Renin angiotensinogen pathway will be suppressed. Okay. So because of these 2 mechanisms, it is acting as an antihypertensive drug. It is not acting as an antihypertensive drug because of vasoconstriction. Based on the vasoconstriction, you may be thinking it is increasing BP. But no, it is not increasing BP. Although, now see my 2 lines. Although beta blocker causes vasoconstriction, but it don't increase BP, rather it decreases BP. Yes, both the lines are correct. Beta blocker causes vasoconstriction. You can see. It causes vasoconstriction, it's true. But even after causing vasoconstriction, it don't increase BP, it reduces BP because of the other 2 mechanisms. Give me a thumbs up if you got it. If you got it, I tried. Okay, so the same thing is written. Still, it causes fall in BP. It causes vasoconstriction, I agree. But still, it causes fall in BP because of the remaining 2 mechanisms. It reduces cardiac contractility and it reduces renin. Okay, that is beta 1 action. Say, people, say, got it? I hope you got it. Now, the next is on heart. On heart, beta increases contractility. So, beta blocker reduces contractility. It reduces rate, force, and velocity. It reduces all three things because beta increases, beta blocker reduces. That's why it will be helpful in arrhythmia, angina, MI, because it is reducing the force. It is reducing the velocity. It is reducing the contractility. It is reducing everything. It is reducing the rate. That's why it is useful in these diseases. Say yes if you are getting it. Got it? The next is bronchodilation. The next is bronchodilation. Beta causes bronchodilation. Beta blocker does imagine the opposite of that. Beta causes bronchodilation. Beta blocker causes vasoconstriction. So contraindicated in asthma. Never ever do this blunder. You are doctor now. Any patient with asthma coming, never imagine to give beta blocker. Always ask your patient, do you have asthma? If asthma, no beta blocker. The asthma get exaggerated because beta blocker causes bronchoconstriction. The patient already have asthma, and if you give beta blocker, that will be exaggerated. So patient will go in attack of asthma. Got it? The next on the eye. On the eye, you can see beta increases IOT. Here I have written beta. So beta blocker reduces IOT. Since beta blocker reduces IOT, it is used in glaucoma. It is used in glaucoma. The next directly come on the liver. In the liver, beta was catabolic. I told you. So beta blocker is anabolic. Beta breaking anything. Beta blocker don't break, combine everything. Okay, it inhibit. So it inhibit noradrenaline by acting on beta causes it causes glycogenolysis. This one inhibit glycogenolysis. Glycogenolysis is inhibited. Beta blocker inhibit glycogenolysis. It inhibit lipolysis. Since it inhibit glycogenolysis, it inhibit lipolysis. So there is hypoglycemia, reduced lipid, and that's why tiredness. The patient on beta blocker on a long time, the patient have reduced exercise capacity and tiredness. So that will be the side effect. I hope you are getting why. And next, beta causes anxiety. Beta blocker reduces anxiety. Beta blocker suppresses anxiety. So I hope you are getting it. So if you understood, you have to just reverse this column, nothing else. Whatever I have written, just reverse it. Now take the good things out, take the bad things out. The good things is uses, the bad things is adverse effect. So I'm having 6 good and 7 bad over here. Quickly we will do. Okay. So whatever I taught you, take the good things here, take the bad things here. Mark the good things with red color, mark the bad things with blue. You know my pattern now well. So let's start the uses. The 6 uses are in front of you. See the 6 uses. If the patient was coming with hypertension, you can see. So based on this property and this property, we are reducing its BP. Okay, we are not reducing the BP based on vasodilatation. Vasodilatation means vasoconstriction. Vasoconstriction, BP will exaggerated. We are reducing the BP based on, we are reducing the cardiac. Beta blocker reduces cardiac stimulation and beta blocker reduces renin. So both beta 1 action is there. I hope you are getting it. If a patient is coming with hypertension, same thing is shown. So when we give beta blocker to a hypertensive patient, beta blocker reduces cardiac output and reduces renin. Okay, you can see it reduces cardiac output and renin, and this is how fall in BP. That's why the beta blocker are first choice for hypertension. The first choice of hypertension. Ravina, please don't spam putting the same message again and again. I can read it once, I can read it the same 100 times. So kindly please don't spam. Anyone, please don't spam. I can read the comments, but I will not answer in between. I have given you the support number. Please ask your query, course related query on the support number, not here in the session. Okay, so kindly please, I request you, Ravina, don't spam. Okay, come back. Concentrate on the facts over here, concepts over here. Come back. So hypertension may beta blocker are first choice. Okay, now coming on the next. Based on vasoconstriction property, migraine. Why migraine happen? Migraine is severe headache occur. What happens in migraine? Why headache occurs in migraine? Cranial blood vessel dilate. That's why the headache occur. In some people with some stimulus, migraine have different stimulus. Some have migraine with less sleep, some with coffee, some with chocolate. The stimulus are different. Whatever is the stimulus, the cranial blood vessel dilate. The cranial blood vessel dilate, vasodilate, and that's why the patient have the disease migraine. Now I am a doctor. I want to treat migraine of my patient. I want to do cranial vasoconstriction, so headache will go away. So vasoconstriction, beta blocker do vasoconstriction. Beta blocker do vasoconstriction. Beta blocker do vasoconstriction. So they treat the headache. So that's why they are used in migraine. Okay. Now the next 1, 2, 3, 4, 5, 6. The next 6 uses, they all based on heart action. The next 6 uses based on heart. Okay. What does beta blocker do on heart? They reduces heart rate, reduces heart velocity, and reduces contractility. They reduces all 3. Okay, the beta blocker. So based on which we are having the 6 uses. It is used in MI, arrhythmia, angina, okay, dissecting aneurysm, congestive heart failure, pheochromocytoma. In all of them, we want to reduce rate or contractility or velocity. So based on the heart, these are the uses. Okay, the third. So I taught you hypertension based on vasoconstriction, migraine based on heart, the six diseases based on which heart we want to reduce the rate, velocity, and constriction. Glaucoma. You can explain glaucoma over here. You can see the eye. Where is the eye? Glaucoma. Beta increases IOT. Beta blocker reduces IOT, and that's why they are useful in glaucoma. Okay, beta blocker reduces aqueous synthesis, and that's why reducing IOT, and that's why useful in glaucoma. The next is tremors. You know, beta causes tremors. Beta causes tremors. So beta blocker are useful in tremors. They inhibit tremors. They inhibit tremors. So in tremors, some people have tremors, you know, very small, yeah, like irritating tremors. So that can be blocked with the beta blocker. The next is anxiety. Beta causes anxiety. So beta blocker have anti-anxiety. So these are the 6 uses I taught you. No need to learn any of the uses. All the uses are marked with red color in front of you. You can enumerate the uses if you wish. Okay, you can enumerate the uses if you wish. Say yes if you got it. Okay, so these are the 6 uses. You can count. The red colors are 6. These two together known as hypertension. They are used in hypertension based on these two. Okay, migraine can be explained over here. Okay, IMA, glaucoma can be explained over here. Tremors and anti-anxiety. These are the 6 uses. Say, got it? Now coming on the last, the contraindications or the side effects of the beta blocker. The last thing, my 5th chapter. So what are the side effects? No need to learn. You take out the bad things from that table only. That will be side effects. There are 7 side effects. I will mark them with blue color. I have already marked them. Based on vasoconstriction, there are 2 side effects. You can see beta blocker causes vasoconstriction. Since vasoconstriction is there, the cold hand feet disease, cold hand feet, the end arteries are vasoconstricted, so the hands and feet are cold. So the patient on beta blocker for some treatment, for some disease, they usually have cold hands and cold feet. Number 1. Number 2, peripheral vascular disease worsen. You just understand one thing: whenever there is a peripheral vascular disease, we have to dilate the vessel to relax. If we constrict the disease, if we constrict the blood vessel which is already diseased, so PVD will worsen. So if a patient is on beta blocker and patient already have PVD, the PVD will worsen because of vasoconstriction. So because of vasoconstriction, 2 things are happening bad in the patient. Number 1, the patient is having cold hands and cold feet, and the patient, because of vasoconstriction, if the patient have PVD, that get worsened. Now the third is based on the cardiac decreased cardiac stimulation. If the patient is having decreased cardiac stimulation, don't give it in partial block. It will convert into complete block. If the patient is already having partial block, if you are giving beta blocker, it will further reduce the rate. It will further reduce the velocity. From partial block, the patient will convert into complete block. Never ever give beta blocker to a patient with partial block. It's a contraindication. I hope you got it. The next is asthma. And the next side effect or contraindication is asthma. Beta blocker cause bronchoconstriction. So that's why it is contraindicated in asthma. If the patient already have asthma and you are, unknowingly or by mistake, being a doctor, you are giving beta blocker to such patient, the patient can go in asthma attack, because patient already have bronchoconstriction and beta blocker further exaggerated. So patient will go in the attack of asthma. Okay. Now the next 3 side effects are based on metabolism. I told you it is anabolic. Okay, it reduces glycogenolysis, it reduces lipolysis. Yes or no? Since it reduces glycogenolysis and it reduces lipolysis, so impaired cardiac tolerance. Okay, lipid profile is also altered. You can see. Yes. Okay, lipid profile and tiredness. There, because of hypoglycemia and less lipid, it will be tiredness. Lipid profile altered and cardiac intolerance. Carbohydrate intolerance. Carbohydrate tolerance. Okay, impaired carbohydrate tolerance. Okay, so I hope you got all the side effects and everything can be explainable from this table. You have to do reverse of that and think about it. So these are the seven. Out of the 7, 4 is absolute. If you want to learn all 7, very good. If you can't learn all 7, learn 4. The mnemonic is ABCD. A, B, C, D. A for asthma, never give beta blocker in an asthma patient. B for block, partial AV block. It will convert into complete. Never ever, don't even think of giving beta blocker to a partial AV block. C for congestive heart failure. Okay, and D for diabetes. Okay, never give beta blocker. Diabetes is here, this one. Impaired cardiac tolerance is diabetes only. Okay, so you can see never give beta blocker in these 4 conditions. So that is a side effects that you can explain. So we are done with 6 uses and 7 side effects. You can see the summary: 6 uses and 7 adverse effect. See my markings, the red and blue. You can see 6 red and 7 blue. I hope you can count and you can understand and you can say the explanation of all. So as I promised at the beginning of my session, as I promised you that at the end of 4 hours, I will give complete ANS in just 5 pages for 5 chapters. You can see. Okay, so I taught you 4 chapters today: cholinergic, anticholinergic, adrenergic, antiadrenergic, without skipping even a single point, and the 100% session is conceptual. It is not of mnemonics, it is not of one liners, it is just conceptual, full of concepts. So everything I'm having a concept to explain you, and you can write the answer of why in your exam, whether it's a long question, short question, very short question, in the form of full flow charts and images. This is how the complete pharmacology I have just compacted in 25 to 30 hours. Complete pharmacology in my course, the Final Gear course. You can see the summary. Cholinergic drugs, anticholinergic drugs, you have to fill it here. If you have filled it, don't forget to take the snapshot and send it to my personal WhatsApp number as a proof that you have attended my session, you have made this master chart, and I will be very happy if you are doing so. Okay, so complete cholinergic, anticholinergic based on this master chart. In cholinergic, do it as it is. Take it as it is. Take the good things and bad things from here. In anticholinergic, reverse it and then take the good things and bad things. So that is the summary. Okay, then adrenergic, anti-adrenergic mein alpha blocker, beta blocker. This is based on this chart. For adrenergic, take it as it is. Take the good things and bad things as uses and adverse effect. And for anti-adrenergic, reverse it. For alpha blocker, reverse this side. And for beta blocker, reverse this side. And then take the good things and bad things. This is the simplest language I can explain you. So this is a summary in front of you. You can see. This is the summary in front of you. You can see this is cholinergic drugs. Okay, 9 uses, 6 adverse effect. See my red and blue. You see the 9 red and 6 blue. Uses are shown with red, adverse effect with blue. This is anticholinergic drug. See the 9 uses and 7 adverse effect. Again, the same chart. Consider reverse of that. See adrenergic drugs, appreciate the uses and adverse effect. See the 7 uses and 2 adverse effect. You can count the red and blue. And alpha blocker, see the uses and adverse effect this side. And beta blocker, see the uses and adverse effect this side. So I taught you 5 chapters in 4 hours. Don't you believe me? Can't you see how important this topic for your university exam? For your university exam, how many long question, short question, very short question, and MCQs are framed from drug acting on ANS? And you can't understand the pharmacology ahead without understanding ANS. You cannot skip ANS in pharmacology. If you skip ANS in pharmacology, actually you are skipping the entire pharmacology. It forms the foundation and basis of ANS. I consider ANS as in general pharmacology only. You have to understand alpha beta receptor if you want to understand any unit in pharmacology. That's why I picked this first one. Okay, and the remaining courses available on the app if you want to go. So you can have a look. These are the long questions. These are the long questions, short questions, short questions, short questions, very short questions, very short questions, very short questions already asked in various university pan India. We have picked up the PYQs from previous 5 years of pan India university, and these many questions we found. Okay, in today's session I didn't entertain the doubts, but if you have any doubts, please don't hesitate to ask on our support number here, 1103. It's 9321. Okay, 9321 001103. Okay, this is the number. So on this number, please ask your doubt. All these questions we have already uploaded on the app. I have not shown you university wise and topic wise. Okay, the major universities of India, the 30 universities we have covered here. We have given the PYQs of all universities on our app. Okay, and topic wise also the questions are given. And on app, we have compacted the entire second prof syllabus, patho, micro, pharma, in just 75 hours. 25 hours patho, 25 hours micro, 25 hours pharma. So this recording already uploaded on the app. This already uploaded on the app. Out of 25 hours, 10 hours already uploaded. The remaining 15 hours I'm going to take live in the next 4 days. In the next 4 to 5 days, that will be packed before 1st of August. Okay, the sessions are already scheduled on the app. The timing will be from 10 to 2:30. 10 to 2, you can say. 3-4 hour session will be there. Okay, for the next 4 to 5 days, and complete 15 hours will be completed. So this is pre-recorded 100%, pre-recorded 100%, pre-recorded partial 50%, and the remaining 50% will be live. Okay, so I want to be transparent before you go. Tomorrow we are launching the course. So tomorrow I'm eagerly waiting, 27th of July. Okay, Monday night, 11 p.m. the course will be live. Okay, you can purchase it on the website, from the app. You can enroll if you wish. And happy to announce, for 24 hours we have a huge discount, huge offer available. For knowing the offer, you can text on the support number. Thank you so much. I'm ending the session. Hope